Northwood from Rocky Mountain Laboratories in Hamilton, Montana.
Good morning, everybody. On the program, I'm supposed to give you an overview on Lyme disease. I'm not going to do that. Because everybody that's going to follow the program is going to talk about Lyme disease. So you're going to get an overview. And so many articles have appeared in the last few years on Lyme disease. If you want a good overview, I suggest that you get the April issue of Reader's Digest. There's a good overview there. So this, along with the data that we got here this morning, is going to give you a pretty good knowledge on Lyme disease. My discussion today is a historical analysis of events that eventually led to the discovery of this virus in physiology. The disease complex is now known as Lyme borreliosis, Lyme disease, Lyme virus. I do this to credit those whose names are rarely mentioned in today's literature, despite the fact that they significantly contributed to one of the most exciting detective stories in microbiology. The earliest reference to the disease manifestation of Lyme borreliosis dates back to 1883. And the German physician Dr. Alfred Buchwald described this cutaneous syndrome as diffuse idiopathic skin atrophy. In 1902, Dr. Herxheimer and Hartmann introduced the name acrodermatitis chronica atropicans, or ACA. This disease, as most of you know, occurs commonly in Europe, but rarely in the United States, although in the last few months it has been recorded in this country. Stand on the professor, please. In October 1909, the Swedish physician Dr. Arvid Afzelius, seen here on the screen, demonstrated to the Swedish Dermatology Society in Stockholm patient with a ring-like 1/2 to 2 centimeters measuring lesion that slowly migrated by expansion of its peripheral borders and was accompanied by central clearing. Typical initial lesion, Lyme borreliosis, and here's the central clearing. This lesion was thought to have developed as a result of a tick bite by Ixodes ricinus, and it was referred to as erythema migrans. Afzelius did not publish his observations. Please take the slides off. Until 1921, when he reported on a case seen in 1908 and on 4 other cases he has seen since. In 1913, Dr. Richards from the dermatology department of the hospital Wieden in Vienna, Austria, described to a 29-year-old woman a similar lesion that lasted for 7 months. Because of the length of the time of that lesion, he called it erythema chronica migrans, which became known as ECM in the literature. By the beginning of the 1920s, both these physicians and additional physicians have seen many cases like those described by Afzelius and Richards. Etiology was unknown. Afzelius, whose cases were all associated with tick bite, speculated that the infection could have been produced by a virus transmitted by the tick or by a toxic substance contaminating the ticks. Richards gave no reference to tick bites in his original articles. but he speculated that ECM may be due to a pathogen. The toxin appeared unlikely to him because of the affliction's long duration. That's just what Richard said in his 1922 article. Perhaps, he states, we are dealing with a skin infection caused through the bite of a tick. Therefore, attention should be directed towards microscopic bacteriologic investigations of the intestinal tract and of the salivary gland secretion of the tick. End quote. No one suggested this, followed his suggestion. The first evidence of a nervous system involvement associated with ECM was reported in 1922 by the French neurologist Garin and Boujardou. They reported a typical painful meningoradicolitis after a bite by the Ixodes hexagonus, a bite that resulted in a reddish skin lesion. It should be noted, however, that Garin and Boujardou diagnosed their case as typical tick paralysis, and that it was not until 1930 that the Swedish dermatologist Dr. Hellström recognized the lesion described by Boujardou and Garin as the syndrome later referred to as Van Watt syndrome, part of Lyme borreliosis. Of interest is also the conclusion by Garin and Boujardou. Let me show off a little French. Si cette maladie est due à un virus spirochète sans doute, comme on le soupçonne, notre observation indique qu'il faudra rechercher ce virus dans le centre nerveux et non point dans le sang, which translates, if this disease is caused by an agent, a spiral tooth without doubt, as one assumes, our observations suggest that this agent should be looked for in the central nervous system and not in the blood. In 1936, Dr. Ascani from the Dermatology Clinic of the University of Heidelberg discussed 2 additional cases of ECM, and he pointed out that about 3 times as many cases were attributed to tick bite than to any other cause. He reviewed the significance of ticks as vectors of human and animal pathogens and concluded that ECM is tick transmitted and caused by an agent from the tick's salivary glands, although it remains to be determined whether this agent is a toxin or a living pathogen. The same conclusions were reached by Gelfer Hansen, who in 1945 reported 3 additional ECM cases, one of which had lymphocytic meningitis. The cause of ECM continued to remain in the dark until 1948, when Dr. Karl Lenhoff from the Dermatological Clinic at the Karolinska Institute in Stockholm presented a report entitled Spirochetes in Ecologically Obscure Diseases. In this publication, Lenhoff claimed to have developed a staining technique that permitted him to demonstrate elements representing the morphological aspect of spirochetes in 27 diseases, including psoriasis, zoster, varicella, rubella, lymphadenous benignitis, various erythemas and lymphogranulomas, endocarditis, leukemia, and erythema migraine. Now, the staining method that Lenhoff used was based on Professor Ehrlich's theory that certain antibiotics specifically interact with a causative agent, and that this interaction could be made visible with certain chemical producing deposits on pathogens such as spirochetes, plasmodia, and so on. Lenhoff used mercury chloride interaction with spirochetes, made visible by ammonium sulfide, which results in a deposit of mercury sulfide. Lenhoff concentrated his efforts on demonstrating spirochetes as the cause of psoriasis, and he found in 72 of 80 German and 1 of 52 Swedish patients typical with spirochetes that in 95% of all cases could also be demonstrated by dark field microscopy. Now, Lennox paper caused a lot of excitement among dermatologists and physicians because it never before had been so easy to demonstrate spirochetes, especially not in so many distinct clinical entities without etiology. One of several physicians who questioned Lennox's findings was Dr. Schuppli from the dermatological clinic of the State Hospital in Basel, Switzerland. He decided to go to visit Lennox's laboratory in Stockholm and to acquaint himself with the staining method and to verify the spirochetal etiology of psoriasis. He was successful in staining spirochetes in cultures, in serum, and in the blood. Although fine structures of the organism were never detectable because of the heavy mercury sulfide precipitations. He also found the technique to be non-specific. That is, other microorganisms and fungi stained as well. Of 50 psoriasis cases that Schuppli investigated, one showed one single spirochete. In thick dots, on the other hand, spirochetal elements similar to those illustrated by Lenhoff could be seen in 12 of 50 cases. Whether these were spirochetes or spirochete-like elements could not be determined. The same was true for spirochete-like elements in histological section. And the next slide, please. Just bring it down. Dr. Schuppli also examined dark field preparations from glands of lymphatic leukemia patients, and in 3 of 8 of these patients he found spirochetes of typical morphology. The organism could also be found in tissue imprints, although they could not be differentiated from tissue fibers. I may add here that lymphatic leukemia lesions could be treated successfully with penicillin. Slide over. Dr. Schuppli's conclusion stated that Dr. Lenhoff's staining method may be well suited for the demonstration of cultured spirochetes. However, it is not specific, since tissue fiber, mycelium, or fungi and other microbial agents stain as well. Needless to state that Dr. Lenhoff's staining method did not find the right approval among physicians, and has not been found to be a useful technique in demonstrating spirochete in erythema migrans lesions. In 1949, Dr. Hellström of the Karolinska Institute in Stockholm presented a talk entitled ECM Afzelius with meningitis at the 43rd annual meeting of the Southern Medical Association in Cincinnati, Ohio. He not only reviewed the number of cases in which after tick bite both erythema and subsequent nervous disorders occurred. The first of such, as you remember, was described by him as 1930. But he also reported on the successful application of penicillin in the treatment of ECM by his colleague Dr. Holstrom, and he presented his thoughts concerning the still unsolved etiology of ECM. Personally, he writes, I feel inclined towards interpreting erythema chronicum migrans Afzelius with or without meningitis as being the manifestation of an infective agent with allergizing property, which is transmitted by ticks and possibly other insects. Circular erythemas, he continues, subsiding in the center and advancing peripherally with obviously local phenomena of polarization and immunization, as well as meningoencephalitic processes occur not infrequently in association with diseases due to spirochetes or other infections where the causal organism is present in locomorphy both in the skin and nervous system. And then he says, it seems reasonable to raise the question of whether the ticks are carriers of spirochetes with allergizing and immunizing properties, and in his summary, he concludes, our investigations tend to demonstrate that the spirochete is the cause of the disease. Definite evidence is still lacking, that Dr. Lenhoff's findings as far as histologic sections repaired from lesions of erythema migrans are remarkable. End quote. Now, the first indisputable evidence that ECM was caused by an infectious agent susceptible to penicillin was provided by Dr. Binder and his co-workers a few years later in 1955. They successfully transplanted pieces of skin taken from the peripheral zone of a lesion of an ECM patient into 3 volunteers, Dr. Binder being one of them, who within 1 to 3 weeks developed typical erythema migrans lesions. In fact, a subpassage to a 4th person was equally successful. Treatment with penicillin in each case led to the prompt disappearance of the lesions within a few days. Because of the efficiency of antibiotic treatment, viruses were ruled out as the cause of ECM in Europe. In 1962, French scientists presented serologic evidence suggesting ECM would be caused by a rickettsia. Using the highly nonspecific virus-wide elimination test, they reported 6 of 7 ECM patients with antibodies against the epidemic typhus agent rickettsia colchicum, the murine typhus agent rickettsia muscaria, and the glutinous fever agent rickettsia gonorrhea. Although these findings could not be confirmed by other investigators, the rickettsial etiology of ECM was kept alive by the electron microscopic demonstration of rickettsia-like microorganisms in macrophages of 2 ECM patients. And this induced Dr. Klaus Weber, a dermatologist in Munich, to have the serum of 13 ECM patients evaluated against 14 rickettsial antigens by 2 different laboratories, one in Bratislava and the other one in Hamilton, Montana, laboratory. With the exception of a few non-diagnostic low types against the rickettsia partis agent rickettsia acari and against Coxiella bonelli because of acute fever, all tests were negative. In this country, as you all know, the first case of ECM was not observed until 1969 in a physician who had been bitten by a tick while hunting grouse in north central Wisconsin. The attending physician, Dr. Rudolf Skrymensky from Milwaukee, accurately diagnosed the case and treated the infected with penicillin. According to Mr. Harvey Murray, who had lived in the community of Lyme, Connecticut since 1959, diseases of unknown origin had occurred there since the mid-60s. But it was not until 1975 that the research team headed by Dr. Alan Steele, Yale's rheumatology department, began its retrospective investigations. Of the 51 residents, 39 children and 12 adults who had developed attacks of asymmetric swelling and pain in large joints, particularly the knee, 15 had expanding lesions thought to fit the description of the European ECM. However, since arthritis, with few exceptions, had not been reported to be associated with European ECM, Dr. Steele and his associates believed that the patient had been suffering of a previously unrecognized clinical entity and named it at first Lyme arthritis and later Lyme disease. Possibly misled by the fact that arthritis is known to occur in certain viral infections such as rubella, hepatitis B, mumps, influenza, and so on, and often is found in mosquito-borne group A arboviral infections, they concentrated on the serologic evaluation of acute and convalescent sera of patients for antibodies against adenoviruses, coxsackie-viruses, cytomegaloviruses, hepatitis B, herpes simplex, influenza, lymphocytic meningitis, mumps, and rubella viruses, and 216 arboviruses, 38 of which were tick-borne. All tests were negative, as well as serological tests against rickettsial agents. Also negative for viruses were 62 pools of ticks collected off vegetation communities east and west of the Connecticut River, where the incidence of Lyme disease was high and low respectively. In that study, 622 Ixodes damni, first considered to be Ixodes scapularis, that later described as a new species, were evaluated. Also unsolved for almost 100 years remained the etiology of acrodermatitis chronica tropicans, which I mentioned at the beginning of my talk, which had been considered a distinct clinical entity, although many patients, 38% of them, remembered having been bitten by a tick, Ixodes ricinus, and 9 of 55 reported skin lesions similar to erythromelalgia that differed in appearance. They have the slides. Acrodermatitis chronica tropicans, as you may remember, develops months, and that's important, months after the initial infection as a primary chronic disease, or even years after the initial and secondary stages of Lyme disease. So ACA is not exactly the same as the initial lesions in Lyme disease. Here you see a typical violation discoloration of ACA in the initial stage. There's another one from Dr. Aspling from Sweden, the slide from her. And here's the chronic stage of ACA, where the skin becomes very transparent and looks like cigarette papers. Slide off. Regarding the cause of ACA, there have been two major hypotheses. One, the disease is caused by an infectious agent, and two, it may be caused as a result of hormonal vegetative defects initiated by traumatic and hypothermal factors. An important observation, however, was made in 1942 by R.H. Colley at the dermatological clinic of the Martin Luther University in Halle, Wittenberg. In his thesis, directed towards evaluation of the pallida reaction, Colley noted that 6 or 7 patients with ACA gave a positive reaction against Treponema pallidum. His boss, Professor Grüneberg, confirmed these observations 10 years later, and he speculated that the reaction must have been due to a spiral that was the causative agent of acrodermatitis. In the meantime, in 1946, penicillin was found to be very effective in treatment of ACA. And all research efforts were now directed towards the identification of a living agent. In 1954, Dr. Kurtz from the dermatological clinic at the University of Munich was the first to show what Binder showed in 1955 with ECM. He showed that ACA was indeed an infectious disease. He successfully transplanted tissues of affected skin from an ACA patient into 4 volunteers, including himself, and recorded a clinical picture similar to that of ACA. That is chronic inflammation that lasted for as long as 312 days and disappeared only after treatment with penicillin. Kurtz speculated that a large virus may be the cause of the disease. But 2 years later, he found no evidence of a viral etiology, and he concluded that the cause of ACA continues to be an open question. The successful transfer of spirochetes from the blood of ACA patients into mice was claimed by Dr. Lowe. In 1955, Kuhleit, Colley, and Grüneberg used the pallida reaction to determine the production of antibodies against spirochetes. Meineke, however, 2 years later repeated Lowe's experiments, and with the exception of a few low titers, he was unable to confirm the serological responses in mice. He questions Lowe's claim of ACA being a spiroketosis. Thus, at the beginning of the 1980s, the causative agent of ECM and ACA in Europe and of Lyme disease in the United States remained elusive. Primarily because no one, and I emphasize, no one follow Dr. Lipschitz' 1923 recommendation that attention should be directed towards microscopic bacteriologic investigations of the intestinal tract and of the salivary gland secretions of the tick. That is exactly what I did in 1981. And Dr. Jorge Benach and I evaluated ticks from Long Island as vectors of the spotted fever agent rickettsia. Because we were not successful in detecting this agent in the American dog tick Dermacentor variatus, we speculate that possibly other tick species, such as Ixodes damni, have the slide, which you see here, and which occurs abundantly on Long Island, and especially on offshore islands, may play an as yet unestablished role in the ecology of spotted fever. We did not find rickettsia in these ticks. Instead, I found in the hemolymph of two females a microfilarium, which is the larval stage of a nematode belonging to the superfamily Muscaridae that led me to the polar stained spirochetes. Those are called the nematode. Here are the polar stained spirochetes. It's now unknown, according to Belfry, the causative agent of Lyme disease in the United States and related disorders in other parts of the world. And ending up on a humorous note, having the name Burgdorfer is not an easy thing for Americans and for scientists throughout the world. I want to show you what they have done to me. Any focusness? These guys here think the F should be changed to pH. Now these things, the neighbors are long enough. John Anderson, where are you? Shame, John, that's your literature. There have been people that have called over the phone. Hi, Dr. Berthold, how are you? Getting better. Where are you? Shame on you. I might try to write that. And there are some people that don't believe that Lyme disease should be credited. They really solve the problem by calling it la maladie de l'auteur. I'm sure that Dr. Steele would like that. And here comes the jewel. My wife likes this one. Says you have to be working with bugs all your life. Ladies and gentlemen, thank you for your attention.
Thank you. Our next speaker is from Scotland, my clinic in Chapel, Texas, Dr. Doug Curry, who has recognized and diagnosed many cases of tick-borne relapsing fever, and he will hear on the presentation.
asked to give this talk, I said yes before I realized anybody was going to be following it. It's somewhat daunting to follow Dr. Berger. The disease I'm going to present to you briefly is in contrast to the newest of the spirochetal diseases, Lyme disease, perhaps one of the oldest. And in fact, the agent which causes this disease is probably the first recognized human pathogen, because it was first seen in blood smears in Europe in the middle of the 19th century. It has been around for a long time. Could somebody turn the slide on, please? And its worldwide distribution, as recognized by many of the names. There are two forms of relaxing fever. Perhaps the most common, at least in earlier times and first recognized, was the loud form of the disease, which tended to come in epidemics, especially in times of stress, war, etc. In Texas, the disease used to be common and no longer is as a tick-borne disease. This shows some data which unfortunately you can't quite see the bottom, but it doesn't really matter because it sort of drops off to zero. Interestingly enough, if one could see the time scale, the time when relaxing fever essentially disappeared in the state is in the very late 1940s, when both penicillin and tetracycline were introduced. Were used very commonly, and since relaxing fever spirochete is very sensitive to both of these agents, and since the disease tends to be fairly spectacular in its acute onset, the impurities of these agents perhaps wipe out the disease as a reportable disease, since you can't have relaxing fever if you don't have a relapse. If, however, we look at what used to happen, one can see that at least in this study, the disease was widely distributed. Tends to be the white dot represent cases from the 30s, the red dots cases from the 70s. Widely distributed in South, Central, and West Texas in the drier parts of the state. Rocky Mountain spotted fever in this state tends to be an East Texas disease, and one of the major reasons for this is that the agents are carried by different ticks. This is a fairly typical sort of clinical presentation. The arrow represents when the patient first came to the doctor. And in making the diagnosis of relapsing fever, actually the history is perhaps the most important part of the story, because one gets a distinct history of very marked paroxysmal episodes of high fever, chills and fever, with spontaneous resolution, and then with a repetitive pattern at usually a 7 to 10 day interval. As you can see in this case, there is some variability in the interval, but actually after a couple of attacks, the patient can predict what's going to happen the next time around. In this particular situation, we were able to make the diagnosis by looking at the blood smear from the patient. Came saying, I think I'm going to be sick again. With that history, we waited a couple of days. He came in with his paroxysmal fever, and we were able to make a diagnosis with looking at the blood smear. During the afebrile periods, the spirochete is not found in the peripheral blood. It exists in the liver, where it undergoes an antigenic shift. And it's been shown experimentally that the pattern of disease is in fact because with the lysis of fever, one can show specific antibodies to the spirochete. It then has a protected area in the liver where it undergoes an antigenic shift, then to reemerge again, and the specific antibodies for the first attack don't affect the organism during the second, and so forth. Eventually, the patient does, however, get over this on their own, even without treatment. Just another couple of cases to make the other points. Again, very marked fever, very striking sort of illness. And most of us probably, if we saw a patient like this in our office with heart rate, chills, fever, etc., also with the case where I was being hard-headed. I first saw the patient here. The reason that you don't see tetracycline until way out towards the end, as you can see, the disease is kind of waning. This was the first patient that I ever saw with the disease. Being an infectious disease specialist, I was thinking FUO and malaria, lymphoma, and all sorts of wild, wonderful things. And it was only at this point that the patient said, "Doc, why do I keep relapsing?" That rings a bell. So I quickly excused myself, ran across the halls of my office, pulled out the textbook of medicine, and read the brief 2 paragraphs it had, and thought, "Dang it, it fits perfectly." As you can see, I did not make the diagnosis in this case, however. He was smeared negative right at the end of the time, so we made a deal. I said, "I think I know what you have, but this is a very rare, unusual disease. Would you mind coming in the first day you got fever?" He said, "Well, that will be next Tuesday." So he came in, and we did a smear, and it was negative. The point being that as these attacks go on, become attenuated, the number of spirochetes in the peripheral blood decreases, so it becomes harder and harder to make the diagnosis. We did have to go ahead and give him some tetracycline. He called me the next morning and said, "You know, the funniest thing, I felt okay when I left the office, but I took that tetracycline and I got a hard chill and a real high fever." Then I remember the last paragraph in the book. It said something about a person I don't have. And finally, just a last case for this. Again, parasites of fever, and this just makes the point that sometimes the pattern is not with an attenuating sort of pattern, but it can be quite great. There are lots of other things that we think about in this disease in terms of differential diagnosis of other agents that present paroxysms of fever, but in fact, if one thinks about it, that pattern I just showed you is in fact unique. The periodicity is quite different from that of malaria. It's not a biphasic illness like leptospirosis. These are things that are in fact much more common perhaps than relaxing fever. So we have to think about it, but it's in fact, if one can get the patient to stay away from the doctor's office long enough to establish the pattern, then the diagnosis becomes somewhat more easily made. The disease obviously is caused by one of the spirochetes, Borrelia. We won't worry about that point anymore since one of the world's experts is sitting right up here on the front row. This is what the organism looks like in a right sink. The diagnosis is made by looking in the peripheral blood in the right sink and seeing the typical spirochetes. These are the kinds of spirochetes that were seen over 100 years ago. Nothing really has changed much about that. Here's another one just to make the point. I don't know whether you can see that. These are quite large, about the same size as a white blood cell. They can be quite difficult to see, however, because like many other spirochetes in right state, they don't stain all that well. Now, there are lots of ticks. We started at the top with the one for which this conference is aimed, and if we drop all the way down to the bottom, the spirochete that causes relapsing fever is actually caused by and is carried by one of the soft-bodied ticks, Arthrodoros, and there are various subspecies. There are some other things that are interesting about these ticks because the disease is carried both by the nymph, it can be transmitted by the nymph, or by the adult. In color, they're much prettier. Now, they're pretty, but they're also very small. These are free-living ticks. They live on vegetation. The host passes by, they attach, feed, and drop off. They like particularly dry, sandy, cool habitats, and so are found oftentimes, at least in this state, in the hill country, in caves where there's of the patients I've seen. And in fact, I've seen 3 patients now over the last several years who were all raccoon trappers, one of which we were able to find the ticks in his sandy floored basement where he kept his skins amongst skins. So this organism can live within the tick for a long time. Ticks are very hardy. They can stand long periods of drying out, desiccation, and so forth. So once an area has been established with the tick, it's very hard to eradicate. Dr. J. Sanford, whom I think probably all of you will recognize his name, described a cave in North Central Texas up around Denton when he was still at Southwestern, which was famous for producing a number of cases of relapsing fever. And in fact, that cave is still infested now some many years later. There are caves known west of Austin where the disease was described in the 1930s, and in the same area today, cases have been transmitted. Now, one of the other interesting things about relapsing fever is that the tick transmits the organism's transovarially to its offspring, so that the organism itself becomes self-perpetuating. And as I mentioned, both the nymph and the larva and the adult stage are infected in man. Now, I mentioned there are different species. The disease has a worldwide distribution. In this country, the disease is relatively limited west of the Mississippi. In Texas, one of the areas, but then throughout the far west coast, especially California, Oregon, and Washington. Many different animals have been known to be infected by this organism, and though raccoon is not on this list, I suspect strongly that one could infect raccoons with it. The armadillo gets a bad rap for all sorts of things. Is probably not the standard vector around the state of Texas, nor is it probably the standard vector for leprosy. Now, just a couple of comments about the different forms of the disease, because the wild-borne disease is the one that's been studied most. The reason being that it's a much more severe disease, and obviously, especially in underdeveloped parts of the world, can cause quite a lot of problems. Most of the work in the last few years has been in the last couple of decades, in fact, has been done at the Naval Research Station in Addis Ababa, where this disease is still endemic as a wild-borne disease. It's of note that it may have in fact contributed to the outcome of World War II, in that around the time of the Battle of El Alamein, there were some 30,000 Italian and German troops in hospital suffering from relapsing fever prior to the age of penicillin. Because that part of North Africa was one in which one in trenches and whatnot can certainly contract the disease. The wild-borne disease tends to be a little bit more of a female to male predominance in contrast to the tick-borne disease, which is male predominance, probably because of exposure. In both of these diseases, they tend to be diseases of younger people. The fatality ratio in wild-borne disease can be as high as 40% in untreated cases, as low as 4% when it's promptly recognized and treated. The mortality rate in tick-borne disease is said to be 2 to 5%. I think this is probably an overestimate, at least in modern times. The incubation period we know for tick disease is around a week. We don't really know exactly how long the wild-borne incubation period is for obvious reasons, since one's not quite sure when one is fed by a mouse usually. Duration is a little bit longer in wild-borne disease. For the first attack, on the average of about 5.5 days, whereas it's on the average of 3 days for tick-borne disease. But note, again, the wide range of clinical picture in the tick-borne disease, all the way from half a day to 17 days. The duration of the febrile period for the first attack, around a week for the tick-borne disease. I'm not sure about that 63 period. We have some doubts about that, but it is found in the literature. I've not been able to track down the original figure for that. The duration of relapses, shorter, number of relapses. With the wild mouse-borne disease, generally this is a more severe disease, but with fewer relapses. With tick-borne disease, a little bit longer, the longest done was some 13 episodes. And needless to say, that was recorded in the days before penicillin. Even the most hard-headed infectious disease specialists would probably resort to antibiotics with that kind of history so if they didn't make a diagnosis. Tick-borne disease tends to have a higher maximum temperature, and as I mentioned this early on, can be a very spectacular disease with very high fever, regular accepted. Splenomegaly, hepatomegaly can be seen. A rash occurs in about a quarter of the patients with tick-borne disease, and this is just a non-specific maculopapular sort of rash. It lasts only during febrile episodes and is not anything like erythema chronic migraine. CNS involvement occurs, and this is an aseptic meningitis. Again, self-limited disease does not lead to any long-term ill benefits as we see in Lyme disease. And this just makes the point that one sees a moderate elevation of the CSF white cells, usually on the mononuclear side. Protein and glucose tend to be essentially normal, and one can see spirochetes in up to 12% of the CSF if one does it. Patients don't often get a lumbar puncture during this period. They complain of headache. Myalgia is very much like a rickettsial illness, and in fact, that's probably in Texas the leading differential for the first attack. They act very much like a rickettsial illness with diffuse illness, much the same history of exposure and so forth. And we tend to treat, as you know, rickettsial diseases with tetracycline empirically. That takes care of this problem as well. How do we make the diagnosis? Other than smear, we don't. Basically, serologies are really not useful. Basically, as I mentioned, because of the continued antigenic shift, the organism is difficult to culture. The other kinds of serum things we look for are also very non-specific. So basically, a high index of suspicion and looking for the organism is the only way we can make the diagnosis. Now, just a couple of comments. The first time reaction we mentioned, treatment, then a rise in temperature, sometimes fall in blood pressure. A great deal of effort over the last 20 years has gone into trying to define what causes the Herxheimer reaction in this particular disease as compared to syphilis. There are some differences. It said in the one always has it and it's severe. This really refers to Lyme disease with treatment. In fact, the recommendation in Lyme disease is to use only tetracycline because the Herxheimer reaction tends to be ameliorated by perhaps slower action. One can treat tick-borne disease with tetracycline without getting a Herxheimer reaction. And in fact, one can use penicillin sometimes, as you'll see subsequently, without getting a Herxheimer reaction. The onset is rapid. Other than that, there's not much difference in what one would see in this disease and secondary syphilis. A number of things have been looked at, and he's trying to explain this, and I guess probably the bottom line, and I don't think it's really worthwhile going through all of this. Bottom line is that there tends to be a turn-on of what we used to call endotoxin-like reaction. And basically, many of the things that one would see when one gives endotoxin, one sees in the Herxheimer reaction. However, the reaction itself is probably not classic endotoxin itself, but an endotoxin-like material. That's what that's all about. Now, just a couple of other comments, and I will end giving us, I think, a little extra time. Since though this is a fascinating disease, I think it really gives mainly just a contrast to what this conference is all about. There have been some ways, I think, that we've noticed that one might make this diagnosis in a perhaps more efficient way. However, for those of you who don't work in laboratories, a culture counter, an automated histogram, and it generates a histogram based on the size and so forth of platelets, red cells, and white cells. And in fact, for the white cells, one gets a fairly typical kind of curve, which is predictable. This is actually what it looks like. I always like drawings like that, where this is what it's supposed to be like, and then they hand you something like this, but it won't be anything like it. But in fact, this is a printout from a color counter of a perfectly normal person, at least the upper line of the white cells that wants to look at. Well, we recently had a patient, because focus. Did someone see you? Okay. This was a recent patient. We had yet another retention Skinner and Trevor who appeared with a history of relapsing episodes of fever. We got a CBC, and I got it to look for to get the right thing to look for the smear. I forgot about the fact that they do these things automated now. In fact, if it's normal, sometimes they don't even make a smear, they just interpret the graph. Fortunately, you can see, I believe, if you contrast it to the previous slide, this curve here looks very different from this one. And in fact, the distortion of this is caused by the spirochetes themselves. Now, I was curious how long it would take to go back to normal with this patient since he was sick enough to be put in the hospital. We put him in the hospital, and I decided to use penicillin, so we gave him some intravenous penicillin, and he did not have a Herxheimer reaction. However, notice only 1 hour after the dose of penicillin, this curve looks very much more like normal, and by 3 hours after the dose of penicillin, completely normal. Interestingly enough, this patient also is the only patient I know of that I've ever heard of who was treated with non-penicillin or non-tetracycline, yet another antibiotic that many of us use empirically. The old drug known as reflex Catlex. This patient was actually treated with his first paroxysm of fever with 10 days of oral cephalexin. It didn't work. He did take the medicine. And I can't really explain that because I would have predicted that the cephalosporins probably would be very effective in therapy for this disease. And as we say goodbye to this Borrelia, I want to thank you for letting me come and tell you briefly about this disease, since it is still seen in the state. Only by thinking about it, however, and looking prospectively for it, will we see it. Thank you.
Our next speaker is from the University of Texas Health Science Center in San Antonio. Very well qualified to speak on the biology of various Borrelia species, Dr. Alan Orr.
Also the Lyme Foundation for sponsoring this meeting here. It's very nice that we have such an interest in Texas and the Southwest, and it encourages me to follow in Texas as the 5th International Lyme Foundation in 1992 or whenever Texas would be held. I'm going to take up the story that Dr. Bergdorfer and Dr. Hurley have started about the Lyme agent and also relapsing fever, and tell you more about the biology of these organisms. A lot of what I say will be hopefully serve as enough to other speakers in the conference, because we're going to have a lot of interesting things to say. This is the spire piece. This one here is the Borrelia burgdorferi. But I always thought it was a particularly sinister-looking organism worthy of a good fight. And often while growing once, especially Borrelia burgdorferi, this is one of the early cultures, the culture soon after it's been recovered from a patient or from a tick, and tends to grow these large clumps like this. Later on, it will disperse in the media. But I also thought this was maybe an interesting phenomenon worth study of why the early insecticides seem to grow in clumps like that. Spirochetes are defined not only by their spiral shape, but also by the paraplasmic or endoflagellum they have and insert subterminally here and stretch the length of the organism. These flagella are covered by another membrane, so they're not like typical bacterial flagella on the outside. These are in fact on the inside. And another characteristic of Borrelia share is that they're passed by an arthropod, in this case a tick. And ticks are excellent agents, as you well can imagine or know, of transmitting diseases from one species of mammals to another species, or even from birds. And the Borrelia, this is another type of classification that Dr. Curley showed you one way of classification. This is a sort of a broader view in which we see, well, maybe you can't in the back, but there is an ancestral eubacterium here, and all the other bacterium have been derived from this. And spirochetes, using some genetic techniques, have been found to be quite different from other bacteria. They're about as different from gram-negative bacteria, which are in this group here, as gram-positive bacteria are from gram-negative bacteria. In fact, we're probably more closely related to plants. Humans are more closely related to plants than spirochetes are to their other types of bacteria. So there's been a lot of evolutionary distance that's existed between these organisms. So what we know about gram-negative and gram-positive bacteria, the common bacterial pathogens, doesn't help us very much with spirochetes. We're really finding out we have to break new ground. For growing the organism, all the Borrelia, most of the modern methods date to Dr. Kelly's formulation, and he built upon a long history of attempts to grow the organism, many of which, if you look in the literature, I consider to be successful, but never really got the recognition that they deserve. But Dr. Kelly based his media upon the radicerum and albumin, which certainly are helpful for growing the organism. The peptide glucose, sodium bicarbonate, and it helps to have a viscous agent in it, such as gelatin, which helps the organisms, gives them something to swim against. They are living in a viscous environment with blood and tissue. Now, I think Dr. Kelly's real critical contribution was the addition of N-acetylglucosamine. And Dr. Kelly, we don't hear from him too much these days, but he did attend the earlier Lyme or Lyme disease meetings. And I asked him why he picked that out among all of the things that are in the chemical shell. And he said that he realized that chitin, the exoskeleton or one of the constituents of the exoskeleton of ticks, was in fact a polymer of N-acetylglucosamine. So he thought maybe the monomer form of it would be a large amount, so he added that medium. I think it really made a difference. You can serially cultivate the organism now, and if you leave this out, the organisms do very poorly. The organism dates back perhaps to a time when the Earth was different, and when there was more oxygen and more carbon dioxide. It's also typical of something that might be a pathogen. It grows, it really doesn't like high temperature, anything above 39 degrees. It does poorly. It may tolerate it, but it doesn't grow well. Microaerophilic. It was divided about every 12 hours, maybe plus or minus 4 hours. And you can achieve up to 10 to 8 cells per milliliter of culture medium. That's about 10% of what you get with E. coli or gram-positive bacteria. Many people have used antibiotics as a selective way to isolate the organism from what may be a contaminated environment. Usually this is most important in isolating from ticks. And in our first attempts at this, we used thiacryluracil and aldehydic acid. But and certainly all spirochetes are resistant to rifampin completely. So rifampin is often useful, and they're relatively resistant to aminoglycoside. I think you got to acknowledge Dr. Alan McDonald's contribution of suggesting use of phosphomycin, which has turned out to be very helpful too. And we use currently a combination of rifampin and phosphomycin. But I think a lot more work could be done. We were able to achieve a while ago growth of the organism Borrelia burgdorferi on an agar plate, but it never grew as colonies. And Dr. Purdy and Russ Johnson in Minnesota sort of improved upon that. We're able to achieve colonies by upping the concentration of agarose in the media, and we subsequently were able to achieve that too. And these are just different colonies of Borrelia burgdorferi. Another phenomenon that isn't very well understood, but all of these are from a single strain of Borrelia burgdorferi. You can see the variety of colonies that you can get. Unfortunately, the efficiency of plating, the number of bacteria that is put on the plate, the number of actually grows as colonies is still low. So again, more work has to be done. Another view of spirochetes. This was a picture done by Bill Cobb and I in Hamilton. You can see this is a sort of cutting the spirochetes in sections, sometimes in cross sections. Here you can see the flagella here longitudinally. And it's been pointed out that the organisms are sensitive to penicillin, and I'd like to show you what that looks like. This is the same organism, except it's been treated with penicillin for 3 hours. And you can see the dramatic effect it has of lysing the organism, everything sort of spilling out. And this is also interesting. You can see all these small little membrane vesicles, which occur normally in cultures, but are much amplified when the penicillin or presumably tetracycline is used too, although we don't know that. I think this is worth pursuing as a cause of sort of amplifying the disease and also related to the jurisdiction syndrome. On the top, a little bit about relaxing fever, and I thank Dr. Hurley for the excellent introduction to that, and so I'm probably going to repeat some things he said. This just shows the worldwide distribution of relaxing fever. This was in the 30s, it's an old textbook, and I think you'd find it much contracted now in terms of louse form right here. But it's true, it still exists in Ethiopia. And one of the people who's done a very nice job in studying louse form relaxing fever is actually in Texas now. He's at Texas Tech, Dr. Tom Butler. And I had a chance to talk with him. He says that he's sure that there's still a lot of relapsing fever in Ethiopia in the highlands. And there's, there's worries that it could develop into the Sudan or any part of Africa or the Middle East if we have wars and a lot of refugees again. It's ready to happen. This is Dr. Hurley and I found the same picture. I'm just going to point out that a lot of excellent work has been done on relapsing fevers in the 30s and 40s and 50s by Dr. Kemp and others out of Boston, out of the University and the State Health Department. Really made some groundbreaking discoveries. And so you can see it's a Western disease for the most part. And we've, let me just back up. We used as our strain, a strain which I think really was involved in collecting at one point. It was from a shorting. It was from an outbreak of relaxing fever up by Spokane involving some Boy Scouts. And then who really kept Borreliology alive over the years, had the strain, and then Dr. Herb Stoner the Rockwell Laboratory began doing various studies with this particular strain. But this just shows from that outbreak in Spokane, 2 of the Boy Scouts who got infected there, and then much like what you've seen before, the lapses here. And the same thing will happen with the experimental animals. And this has been very useful. It's a very good animal model for relapsing fever. And if you look at either the animal or the person with contact infection, you will find numerous organisms. Sometimes in mice, the number of organisms outnumber the number of red cells. And the animals are quite ill at that point. But this phenomenon of relapsing has long fascinated microbiologists and immunologists. In fact, soon after the discovery of the organism in Berlin, the agent for relapsing fever in Berlin, all the early pioneering immunologists were fascinated by it because they thought this would be a sort of provide a lot of insight in how the immune system works. Paul Ehrlich wrote several articles about it. And basically what happens is that you can infect a mouse with a single organism of, say, one serotype 7. And this was what we find in mouse A, the number of organisms grow up. And then with the appearance of IgM neutralizing antibody, you get the disappearance. And I beg to differ with Dr. Hurley in terms of where they go. As Dr. Stoner has to show that the organisms are still present in the blood at very low numbers. And they don't really consciously switch. They're switching spontaneously. They'll switch in a test tube. It's just a mutation, a low mutation rate that occurs. And survival of the fittest. The new mutations, new variants are immune, or say resistant to the antibodies circulating, and they will grow up. So you get serotype 21 now. All of this is reversible. We can take serotype 21 and put it in mouse B, which presumably is not immune to serotype 7 now, since it's naive. And you get serotype 21 coming up in the first peak and serotype 7 again. So all the information to make serotype 7 is present in the cell. It's never lost. So this, that's why it's reversible. And so the genetic information is still there. And to Dr. Stoner's very patient and painstaking work, he isolated approximately 25 different serotypes from Borrelia firmicide, the agent that we were studying. 25 different serotypes from a single organism. This took him several years and multiple mice and making antiserums. It really was quite an extensive work. And as you can see from that slide, the frequency of serotypes is not equal through the first relapse. Some of the serotypes, for instance, 7, are very frequent in the first relapse. Others, like 5, would be infrequent. These other serotypes you'd more likely find in a later relapse. So there's some sort of sloppy, what we call sloppy programming to the whole process. Now we're fortunate in terms of being able to work with Dr. Stoner before he was retired and learn the biology of the organism, and also we're fortunate to have really in the same institution to learn from him. And one of the first things we did is to look at 5 different serotypes. Just looking at their proteins. These are total proteins separated by electrophoresis. And they all have a common protein here, which turns out to be the endoflagellum protein. It's internal. And it's not likely exposed to antibodies, at least initially. But they all differ in this other protein, what we call the variable nature protein. And this is what we think that confers antigenic variation, or serotype specificity. And I don't go into all the studies that we've done on this, but we've been very interested in this phenomenon that looked at molecular biology. And I just briefly show a slide that summarizes those findings, and I'd be happy to talk to people later if they want to know more about it. But basically, the change from a serotype 7 cell to a serotype 21 cell, it's like a mutation, but it's something that's reversible. And that there are plasmids in the cell. There are different types of plasmids, storage plasmids and expression plasmids. And in a sense, this is like a cassette player. You've got a player here, and if you have the right, if you have a tape in it, it's going to make the music. If you have the right gene in it, it's going to make the protein that covers the cell, the variable major protein. But you can change the cassettes. So you can take the cassette stored up here, for instance, 21, and put it into the player, and now you have serotype 21 protein made. Now you still have a copy of the cassette 7 around. You have multiple copies of it. So you can always, from this point, serotype 21, go back to serotype 7 by just taking this copy of the cassette, putting it in the player, and now you get 21. So that's a pretty overly simplified way of explaining it, but basically the concept. Now we'll move to Lyme borreliosis. And I'd just like to make the plug that Lyme borreliosis is its name now. I think I'm right in saying most people would agree that that's a very appropriate name. But you'll hear more about the clinical aspects of the disease, but it's clearly their protein manifestations. And in that sense, I think in a quantitative sense, not in a qualitative sense, because I think relapsing fever can have many of these same symptoms. It just occurs much less frequently. For instance, there's Bell's palsy. There have been numerous articles showing that Bell's palsy occurs in relapsing fever. Arthritis has not been a common symptom, but many of the neurologic involvements have been reported over the years in relapsing fever. It's just not in the recent symptoms. You'll hear more about the vector. In this case, it's Achilles business. And I'm now going to start the story from where Willie left off. Willie had found these spirochetes in the Achilles ammonite ticks that Jorge Bonat had sent him. And later, Fred Hayes, the lifelong with the preparation given to him by Willie, showed the organism in the midgut of the intestine of the tick, and Willie provided us in our laboratory with some of these midguts. We had experience with growing the growing of relapsing fever, and we tried to grow them in that media, and they grew. They grew without any difficulty. And this is what the first isolate looked like. It looked a little bit different from the Borrelia crimsoni. I think, Willie and I looked at that. We clearly could see there was a different type of organism. It wasn't the relapsing fever Borrelia that we had seen in other situations. This is showing that the organisms were used for indirect immunofluorescence studies, and Dr. Grunwald, a practitioner in Long Island, provided these sera that he had from patients that he had seen over the previous 3 or 4 years, and he had kept these sera on patients. And this was, I think, what would be considered unusual for a local practitioner. But he kept these, and he generously provided them to us for studies and showed the demonstration that these patients had antibodies to that agent that Willie had seen and been cultivated was the start of this whole thing. We did some other studies, collaboration with Willie and Alan Steer, doing Western blots, and obviously this is hard to interpret in this version, but I wanted to make the point that the immune response to the agent can vary quite a bit from one person to the next. This is each heavy block here would contain serial sera from a single patient. Most of these patients have complicated disease, arthritis or neurologic disease. This patient here turned out to be controlled and no reaction. But all the other patients, you can see that there may be no reaction, there may be fairly weak or very heavy reaction, and the different types of proteins. So this is still a challenge of trying to study the immune response to this agent. We certainly are just beginning, all of us, to do that. And we've concentrated on 2 particular proteins. at least to begin with. We're looking at many others now, but to begin with, we're interested in two proteins that seem to be in large amounts, and they reminded us of the variable major proteins of Borrelia hermsii. So it was similar sorts of studies that we could do. And this shows Western blot with a rabbit that really had infected via a tick, 3050. This is a rabbit we had injected with the culture that we obtained from ticks directly into the vein, and this is normal rabbit serum. And you can see the rabbit infected via the tick has a very broad immune response, numerous antigens, probably protein antigens, intended via intravenous immunization with culture grown organisms is very restricted against these proteins here. This we've seen this in mice, we've seen it most recently in a baboon, same response. Primarily these two proteins here. I'm sorry, you probably can't see these, but there are two proteins about 31 and 34,000 molecular weight, and they have the characteristic that they can be cleaved from the cell by protease trypsin or protease K, or nucleotides. This again was very similar to what we've seen with Alaskan fever Borrelia. So we call this OS-A, the lower one, 31,000, and OS-D. And I think there's one, you not define them on the basis of their molecular weight. There's a family of phosphate proteins and a family of OS-D proteins. Another characteristic of these proteins, these major proteins, is that if they're on the surface, shown by this immunogold study, but if you use unfixed organisms, use live organisms and incubate them with the antibody, and then use immunogold beads here. This was studied with Bill Todd, that you get aggregation of the antigen. And this is very unusual for bacteria. Most bacteria have a very rigid membrane or cell wall. Gram-negative bacteria would never do this, so they're fairly rigid. And this actually looks more like a eukaryotic cell. The fact that you have this aggregation, the membrane is very fluid, mycoplasms that we use there. But spirochetes and mycoplasma have this phenomenon of patching. And this may be one way of avoiding immune response, because we have, ultimately, you'll have shedding that it attaches, just kind of shed off in those little vesicles. So you can have antibodies sticking to the cell, but it can be sort of released. When we look at a larger number of organisms, as people around the country and around the world began isolating these organisms from ticks and animals and people, we found that there was a great deal more heterogeneity than we first saw in the United States. For instance, these are strains in the United States, from Munich, from Bird, from John Anderson, isolate from the Bird, and 3 from Sweden. And again, I'm afraid the critical part of the slide is for people back can't see, but there's a great deal of difference in these OS-type proteins, whether they're OS-A or OS-B or OS-G or E is not clear, but certainly in these family of proteins there's a great deal of variety. And for instance, in the same group of strains, we have one monoclonal that bound to 3 of the strains, but not to the other 3. And it turned out that monoclonal, and I'm sure others could do it too, but this one could help differentiate between U.S. and European strains. The U.S. strains tended to be bound by that antibodies, 3PS, and others, the ones from Europe, tended not to. So there were U.S. or North American type strains in Europe, and I won't go into the implications of that now, but it may be interesting to follow that up. But there was a great deal more heterogeneity in Europe than there is here in the United States. These are some studies of showing in vitro variation, and Tom Schwan has found this, and perhaps we'll talk more about it too, but just briefly show that you can get variation of these proteins in vitro as strains or cats We found variation in size of the OSPI protein and the appearance of other proteins as this one changed. And we found that these lower molecular proteins are in fact related to the OSPI. So variation occurs in the test tube and the culture media, also occurs in animals. And this was an early study with Kengage and Willie, in which they infected some cotton rats and bled the animals at various times. And we looked at we cultured the organisms and found out in the cotton rat that there was a change in the OSPI protein, and also interesting is other protein too, that after day 9 here, that there is a loss of reactivity of this OSPI protein with the antibody. Again, it's pretty famous way to follow there. So in vitro and in vivo variation occurs, and I think this is just being sorted out now. With Tim Howe and Leonard Mayer, we cloned into SG coli genes for OSPI and OSPI. We found that they're together. These are in sequence now. It's Sven Bergstrom and found that it's what's known as operon. Both of them are produced together. And they're also seem to be closely related. With studies with Claude Barron at the Rockmount Lab, we found that there are other unique features about these proteins and biology of the Borrelia. For instance, in the Borrelia, Burgdorferi and the other forms of Borrelia, the DNA, the hereditary material occurs in 3 different forms. It occurs in the chromosome, occurs as circular, supercoiled circular plasmids, and also linear plasmids. Again, I can't go into, don't have time to go into all the background of that, but they do occur in these 3 forms. And we found that the genes for those surface proteins are located not on the chromosome, which you might expect, but they're located on the linear plasmid, on about 49 kilobases, 49,000 bases. And this is similar to what we found in relapsing fever. So these abundant proteins are made by plasma, not by the chromosome. And this is plot here in a picture of one of these linear plasmids. They're not like the typical bacterial plasmid, which is circular, but these are linear. And that these plasmids, there's a variety of plasmids in the cells. This is the initial shelter item isolate, which was definitely called B31. 1982, soon after it was recovered. And this is after 4 years it had been passed, and looking at the plasmids, all of these are different plasmids, looking at them, we found that there are differences. And Fred High, Wes Johnson, and Minnesota, and Tom Schwann, and Willie Burgdorferi, and Hammer that done these studies and then demonstrated in even greater detail the changes that occur with these plasmids. Plasmids can differ within a strain with time, and also can differ between strains collected from different places. And these are the same 6 strains, again, from different parts of the world. And all of these are plasmids, and they can be considered quite different. In fact, it may be better to use plasmids to tell strains apart. Again, with the warning that they may change quickly. But if you get them at the right time, they may be the best way to tell strains apart, because there's much more variety in plasmids than perhaps even with monoclonal antibodies or looking at proteins. And again, another group of strains. This is B31, strain from California. This is the Texas isolate, one of the first Texas isolates. Strains of CSF, and all of these comes from Jorge Banach in New York, and all these others are from Europe. And there is, you can see the variety of strains. Our latest finding is that the organism continues to surprise us with interesting things. It appears the chromosome of these bacteria is also linear. If you look at any textbook, you'll see that it's assumed that bacteria circular chromosome. And for the most part, that's probably true. But the Borrelia enterina, Terrasana, Hermsii, and Burgdorferi all seem to have linear forms of their chromosomes. They're about 950 to 1,000 kilobases. And they migrate into certain types of gel. And the plasmids are way down here, and these are the chromosomes. The significance of that, I don't know, but again, it points out how different these creatures are. And a little bit more of some findings that of unknown significance at this point are that the organisms have bacteriophages, that they have viruses themselves. It's possible, there's some viruses here on the Borrelia, Fred Hayes, these pictures, that these, I think it's conceivable that these viruses of the bacteria are in fact related to those linear plasmids. So linear plasmids, if they resemble anything, resemble animal viruses. They look like the concept of chicken pox. And to point out this one thing that Stanley Falco has said, that pathogenicity has evolved in quantum jumps rather than slow adaptive evolution. Things like viruses and plasmids allow that to happen because they can change very rapidly in terms of evolutionary time, and they can move between strains. And this may have allowed some change, perhaps, in Borrelia burgdorferi from an organism that was fairly restricted in its host distribution to one that's much more promiscuous now. And I'm just going to end by pointing out some studies we're doing toward a vaccine. And I tell you, frankly, the vaccine may be difficult because I think we have to make a comparison with the cause of rheumatic fever. Streptococcus, daily streptococcus. There's obvious need for a vaccine against beta hemorrhagic strep. Why don't we have one? Because everybody is very scared that if they immunize someone, you're going to cause something like rheumatic fever or the neurologic disease. And we have a lot of parallels between Lyme borreliosis and the complications and rheumatic fever. So we don't want to be injecting things into people that's going to actually make them worse. So I think it's going to be a very slow process of really trying to develop. But I think, that we have in the world now tools for doing that, recombinant DNA, very powerful techniques for looking at this peptide synthesis. We have been able to produce the OS protein in large amounts. Now, this shows down here being produced by E. coli. I mean, it could be done by yeast or other cells. This is work done with leaf and milk back around my laboratory, but it's continuing. And we can immunize rabbits with this recombinant material or control E. coli and found that the rabbits had antibodies against 5 of those 6 strains. So there's, again, this is a type of experiment that can be done. I mean, this antibody can be used to see if it's actually detective or anything like that. So I think there's reason to hope that a lot of progress, at least understanding disease, can be made. A final picture that's in focus here, but this, Alan Steer and I were invited to go to the Soviet Union. Here, there, and we were also fortunate of meeting some excellent researchers in the Soviet Union. This is Dr. Kornberg from the Gamma Institute, who also is keeping the flame of radiology alive in the world. And these are 3 people from Lithuania. We were in Vilnius, Lithuania, here at a very exciting time in their country. And we have fortunate to have visiting us as a postdoctoral fellow, Ariana Shadidny, right here, and Ariana is the back of the audience. So we go both. Thank you.
A couple of announcements. Anybody that's interested in continuing education credit, we can sign up at the registration desk now. I'd also like to point out that the refreshments at the break.
Live in McAllen. We're looking forward to these types of schools in James County data. Come here. I live in Jackson, New Jersey. It's about midway between New York and Philadelphia. And we are in the center of a hyper-endemic Lyme disease area. I would guess that within a 5-mile radius of my house, there are several thousand cases of Lyme. Very heavily wooded area, there's a lot of new construction, new subdivisions going on. There was recently a 1,200-acre parcel bulldozed and a reservoir was made, and we had a dramatic influx of small mammals from this area. I practice internal medicine with my wife, and we saw our first case of Lyme disease in 1980 when we were still in residency. That was basically a curiosity at that time. Had a reaction. Medicine was an infectious disease, special diagnosis. When we finished our residency, what is the residency?
Hold it up to your mouth.
Okay, we finished our residency in 1984, and the first summer in practice we saw perhaps 50 cases of ECM rash. And we were very excited about that because it was a disease that very few people knew about at that time. As the years went on, we saw a trickle of ECM rashes. But the surprising thing what happened in the last year and a half, we started seeing patients with bizarre manifestations of multi-systemic disease. Not all of these people told us that they had been bitten by ticks, had bullseye rashes, and it was almost millions of patients that we had been seeing for several years that all of a sudden had bizarre symptoms. The whole host of symptoms that have been associated with Lyme disease. And there's a very good handout available from the Lyme Foundation, 39, a list of 39 items that are look for to assistance with patients. But anyway, last year we diagnosed and reported 324 cases of Lyme disease. Next slide. Cases in 1988.
You can hold the microphone up to your mouth.
The hallmark of making the diagnosis of Lyme disease is really clinical suspicion, especially in advanced disease. The ECM rash certainly is helpful. It occurs in about 50% of the cases. Serology is also important in making the disease, but we must remember that a negative titer does not exclude the diagnosis of Lyme disease. Interestingly, when we break patients down into sex, females were 217, males were 107. So it's a 2-to-1 ratio. I don't want to speculate about the sexist implications of this. It's well known that women do go to physicians more frequently than men do, and will seek medical attention for minor complaints where males may not. Next slide. Of the 324 patients that we saw, 30 were clearly stage 1, where there was an ECM rash present. And stage 2 and 3 I lumped together because it's generally difficult to separate these out. I think the staging was more a convenience for the physician. They probably doesn't really describe what happens in the disease. Almost all the patients that we saw in stage 1, 2, and 3, we initially started treating with oral antibiotics. We used penicillin, doxycycline, tetracycline, amoxicillin, and cefuroxime. I haven't had enough time to compile all my data, and which of these oral medications is superior. My gut feeling is that there's probably not too much difference between them. Interestingly, of the patients that we treated with the ECM rash, 8 of them eventually went on to develop advanced symptoms in spite of what we thought was adequate oral treatment. In the first part of the year, we had been treating with a 2-week regimen for ECM lesions. When we started seeing these patients returning months later with advanced symptoms, we started treating for 3 weeks. And at present, we divided it up into if you have a pure, just an ECM lesion with no systemic or constitutional complaints associated with it, we'll treat for 3 weeks. If there are things like fever, headache, myalgia, and the other number of symptoms, we'll go to 6 weeks at this point. 7 of these 8 patients that developed advanced disease, even after retreatment with an extended course of oral antibiotics, required parenteral treatment. Of the 324 patients that we reported, 167, or 52% of them, had clearly positive serology. We used several laboratories. The IFA, 1 to 256, we considered definitely positive. They had a positive ELISA. We used several different ELISA systems, both the Whitaker and the 3M. 76 of these patients, or 23%, had borderline serology, which we would call IFA of 1 to 128, or what we call the ELISA reading. 81 of these patients were seronegative, which represents about 25%. Of these patients, 55 had definite history of ECM or Bell's palsy. Other strong clinical suspicion of Lyme occurred in 26 of these patients, which represent about 8%. I haven't compiled the statistics on how many of these seronegative patients had received antibiotics early in the stage of the disease, but it's probably about half. Patients requiring parenteral antibiotics. There were 142 patients that we treated. The decision to treat with parenteral antibiotics is difficult to make. It may take months of treatment with oral medication before we get a successful or positive response to treatment. We generally treat for about 2 months when a patient presents with stage 2 or 3 disease, and then we wait a while, patient off antibiotics. If there is no improvement clinically or deterioration clinically, we'll make the decision to treat with parenteral. In some cases, if the patient has severe neurologic manifestations or chronic arthritis, we would opt for the parenteral treatment early. Of the 142 patients that we treated with parenteral antibiotics, 109 were females, were 77%, and males were 32%, 20%. Again, we saw a 2-to-1 ratio of females to males with male diagnosis of Lyme, and in those that required parenteral treatment, again, a much higher percentage of women. agents used were Rocephin, Clapron, or aqueous penicillin. We initially treated everyone with 2 weeks of parenteral therapy. And we found that most patients did quite well with IV antibiotics. However, several months after treatment, a number of them relapsed and came back and required further treatment. Initially, this was very disturbing. And last October, we decided that we would, across the board, increase our initial treatment to 21 days, like we've been doing. I don't have follow-up statistics on patients that we treated for 3 weeks, but again, it seems at the present time that a smaller amount of people are returning for retreatment with the 3-week regimen. Our doses for the intravenous antibiotics are Rocephin ceftriaxone is given 2 grams IV once a day. Clapron we give 3 grams every 12 hours. Aqueous pen generally give 4 million units every 4 hours for a total of 24 million units a day. The Rocephin and the Clapron we generally start as outpatient treatment. The patient is started on the antibiotic in the morning in the office and mix the antibiotic in a 100 cc bag of normal saline and using a butterfly, run it in over a half an hour. We observe the patient for 4 hours. There's no reaction. The patient goes home, comes back the following morning, gets another dose of antibiotic, and from there on is treated at home by a visiting nursing service. The aqueous penicillin we generally start in the hospital. We'll hospitalize the patient for 2 or 3 days, make sure that they're tolerating the medicine. And these people are sent home on what's called a CAD pump. It looks like a large Walkman, attaches to the belt. It's programmable. That contains a 24-hour supply of antibiotic, and the machine is programmed to deliver the antibiotic via an heparin lock as desired. For people that have poor venous access, there are several options. We recently started using what's called a PICC line, P-I-C-C. This is a peripheral intravenous central catheter. It's inserted into an antecubital vein, goes into a subclavian vein. Don't normally have to do x-rays after the insertion, but it's probably a good idea. The other end looks just like a heparin lock. There's a sterile dressing placed over it. It's changed once a week, and that's been working out quite well. Some people would require a Hickman catheter also for extended treatment. Other patients that we treated with parenteral antibiotics, we had 33 what we consider treatment failures, or 23%. Of these, 28 were females, and 5 were males. These patients had a relapse of all their symptoms several months after initial treatment, after which they had a good response and able to go back to work or resume school, and when their symptoms did return, we felt that it was wise to retreat. At the present time, if I start a patient on Rocephin, if he fails 3 weeks of Rocephin, my follow-up medication would be either aqueous pen or can break them down into age category and sex, and we see that the bulk of failures occurred in women between the ages of 30 and 50. Again, it's very disturbing. This seems to coincide with the distribution of women that we see in presentation disease. These women tend to do terribly with Lyme disease. Their symptoms are much more severe. Their response to oral antibiotics is very poor. It's possible that there's an influence of sex hormones here. I can only speculate as to what these numbers really mean. Okay. We had 8 patients that required more than 2 courses of intravenous antibiotics. Interestingly, 2 of these patients had received corticosteroids prior to the diagnosis of Lyme disease. In one case, it was an optic neuritis, which was treated with high doses of prednisone, and another case was a joint injection with depthanidrolone for suspected neuritis. See, the length of symptoms of these 8 treatment failures varied from 6 months to 6 years, so there's really no correlation there. Of the patients that require more than 2 courses of intravenous medication, look at their serology. You can see there's 47% on the 3M ELISA. This is very, very high. This would correspond with an IFA somewhere in the around 4,000, 24,000. The only thing we can say, not statistically significant at this point, but the poor responders tend not to have very high serology. Of the patients that require more than 2 courses of IV treatment, again, the women clearly having a problem. There were 3 patients that we call unresponders. They have not responded to Rocephin, penicillin, clapperine, prolonged courses of oral medication. The average age of unresponders was 37 with a median of 40. That's going back to the previous table. The 3 unresponders, their length of symptoms was 1 year, 8 months, 4 years. They all had borderline serology. 2 of 3 had borderline serology. 1.28 was met laboratories, or greater than 1.25 is considered positive. 2 of the 3 patients had previous corticosteroids. 1 of them had an ECM. The ages were 15, 44, and 44. This is just an interesting slide. Actually. This was a woman who thought she had a chronic candida infection, and turned out to be a chronic Lyme rash that responded after the treatment with oral antibiotics. Have lights, please. Lights. When patients come to you with stage 2 and 3 Lyme disease, they're not going to come in and tell you that they have advanced Lyme disease. They're going to come in with bizarre complaints. And as you try to treat these patients, is not going to respond the way you would expect someone with their disease to respond. You have to have a very high index of suspicion to make a diagnosis of advanced Lyme disease. Otherwise, patients will be branded as kooks, neurotics, psychiatric patients. Unfortunately, when you do routine blood work, routine tests on the majority of these patients, you'll find nothing wrong. You have to think of Lyme. And as we see, not everyone is going to have a positive serology. I'd like to just go over 4 quick cases of what I call a bizarre presentation of Lyme disease that we saw in practice. The first patient was a 71-year-old male. Last August, he noticed he was having chest pain when he was cutting grass. He felt a little short of breath. He went to his family doctor. The doctor, without examining him, looked at him and said, "You have bronchitis. Here's some erythromycin." He went home, took the erythromycin, and immediately got worse. Thought he came down with a cold. About a week later, he was feeling better. He was in the yard and had a tick embedded in his back. And his wife brought him to my office and identified the tick as a common dog tick. But as we took the man's vital signs, we found that he had a heart rate of 30. So we immediately did an EKG, and we saw he was in a 3rd-degree heart block with diffuse T-wave changes. So with his history of chest pain, exertional dyspnea, going on for several weeks, we thought that he may have had a myocardial infarction. Several weeks ago, he was admitted to the CCU, and cardiologist was called in consult. It was felt that he had had an MI several weeks ago. Lyme titer at that time was negative. He was given a pacemaker. He went home. He was feeling fine. Over the next several months, he noticed he was getting fatigued and getting on through cardiac rehab and done well. He was getting fatigued. He was having problems with his memory. His joints were aching. His muscles were sore. He repeated his Lyme titer. This was now about 2 months after the pacemaker was inserted. And lo and behold, he had a positive 1-5-12. Started the man on oral tetracycline. Within several weeks, he was back in normal rhythm. Now he has a pacemaker sitting idly in his chest. And his symptoms all clear with oral tetracycline. Second case is a 17-year-old girl. 4 years ago, she had an acute onset of hallucinations, visual and auditory. She was diagnosed with schizophrenic. She also developed manic depressive symptoms on top of that. She was institutionalized for 2 years. She came out of the hospital last summer. She was on high doses of thorazine, lithium, tricyclics, and transient. She was on the beach while out of the sound and collapsed. Fortunately, there were some people around who knew CPR. She was taken to the hospital, found to be with a heart rate of 16 and 3rd-degree heart block. At that point, it was felt that this was a reaction to the psychotropic medication that she was on. She was given a temporary pacemaker and did well. Her father, who is positive on 256. She was given a 1-week course of low-dose intravenous penicillin. Within a week, the child was completely normal. All her psychiatric manifestations had cleared. There was no problem with her heart. For the first time in 3.5 years, the girl was able to attend school. She did well until about 2 months ago, when she again started into the psychiatric problems. There was a return of schizophrenia. Her parents tried to find someone in Connecticut to treat her. No one was willing. Brought her down to New Jersey. I admitted her in the emergency room. There were 6 security guards to restrain this girl. Get her shackled. She was a wild animal. We sedated her with enough authority to put her worship sleep. At that point, the EKG that we did, interestingly, showed the first 3 heart pounds. She was, at this point, on therapeutic doses of lithium and tricyclics. Within 3 days of receiving I-07, the girl was off all psychotropic medications. She was out of shackles. We continued her treatment for 21 days, and she is now back in school. The first-degree heart block also resolved by the 3rd day. Next patient is also very interesting. 21-year-old college student for 3 years has been plagued with recurrent sore throats and various viral. The next several months, she had increasing somatic complaints, including severe depression, overwhelming fatigue, myalgias, arthralgias. Her schoolwork deteriorated. She came to us, I suspected Lyme, and we started her on oral amoxicillin. Within 2 days, her depression became so bad, she became suicidal, overdosed on Halen, ended up in the ICU with a hypotensive and bradycardia. She has repeatedly tested negative for Lyme disease. However, she did test positive on the experimental T-cell mitogen stimulation test. She's presently being treated with penicillin. It's interesting that we've had a number of cases of women whose initial manifestation of symptomatic mitral valve prolapse occurred after they developed Lyme disease. These are generally accompanied by severe anxiety attacks and panic attacks. We had several women with Lyme and associated complications. These panic attacks have been so severe that they've actually developed agoraphobia. They're afraid to leave the house. They will drive completely disabled, mentally and physically, by this disease. The last patient I'd like to describe is a 2.5-year-old girl. She was born completely normal. She reached all the appropriate milestones in time. She began speaking isolated words shortly after 1 year of age. When she was 2.5, her parents realized that she had actually regressed in her speech. She was speaking, she had not learned any new words in 6 or 7 months. She was taking 4-hour naps twice a day, on top of sleeping 12 hours a day. She wasn't eating, she was losing weight. She had no history of tick bite, no history of ECM rash. pediatrician examined her, couldn't find anything really wrong with her, and told parents that they have a healthy child who is overly concerned. Parents insisted that blood be drawn for Lyme titer. It was very highly positive. The child was admitted to the hospital and started immediately on intravenous Rocephin. By the third day, the child was like a completely different person. Personality transformation was actually bizarre. The child was running around the hospital floor with more energy than she had displayed in over a year. While she was in the hospital, she learned 50 words. This was in October of 1988. Now, she is 3 years old. She is almost caught up to her peers. She is trilingual, speaking grammatically correct in 3 languages. The child with Lyme blood. In addition to that, Lyme disease is also me, my wife, and our 2 children. It's one of the reasons why I'm so involved in treating Lyme patients, and probably more aggressive than most people. Most important things that I'd like to leave you with is that Lyme has to be treated very aggressively. I don't follow a standard protocol for every patient. Since the responses are so varied, the treatment should be tailored to the patient. Don't be afraid to blast patients with antibiotics. I take issue with some of the physicians that will treat patients for advanced Lyme with 2 weeks of Rocephin or penicillin and tell them that they're cured, that whatever symptoms remain are not Lyme, that there's some quote-unquote post-Lyme autoimmune disease. We know that at best Rocephin is about 85% effective in eradicating the spider from the human. Penicillin is probably poorer. I've been using more and more clotrin, and I think clotrin is every bit as good as penicillin. It has worked for me in patients. Penicillin and Rocephin. It has worked for me in patients that have failed on Rocephin and penicillin treatment. I don't think we have the ideal antibiotic at this point. There are patients that aren't going to respond. But many of these patients who have seen some of the maidens of Lyme on the East Coast and were given 2 weeks of treatment, and they may have had some improvement and relapsed and were refused further treatment. If you treat these people, they will get better. And I think that's the bottom line. Questions?
Before we go on to our next speaker, now that Dr. Jewell has brought it up, I'd like to do something that's become kind of a tradition at these meetings. We have a show of hands of the people in the audience that have diagnosed Lyme disease.
Have diagnosis, or have had diagnosis?
Had it diagnosed in them. Our next speaker is Dr. Paul Mitchell from the Marshfield Clinic in Marshfield, Wisconsin, and he's here to speak to us today about serologic confirmation of Lyme disease.
I certainly appreciate the opportunity to talk with you this morning and share with you some of our observations as well as some of our concerns from And this is a fair question, and I've asked this question before too, and received some very interesting answers. Wisconsinites appear to be very innovative, and one of the most recent sports are tick races. I've got too many things to hold up here, and I need a pointer. To kind of show you what's going on here, of course, it's a dark room. And most of the taverns, side roads in Wisconsin are quite dark. And you can see some money down here. So they're betting on these guys and gals. And here we have a racetrack. And this is the chief tick master. And you're very close to it, and he has a little gallon. Two things are placed in the center of this racetrack, and after so much time, the tick that has not moved gets the gallon. Okay, well, that's one of the most recent I was introduced to Lyme disease several years ago now, and because Wisconsin is an endemic area for Lyme disease, people ask, and there are T-shirts that say, we're going to go with Marshfield. And, well, Marshfield is right in the middle of the state. And the medical complex is quite unusual. We are the third largest HMO in the United States with 300 physicians, and we see approximately 2,000 patients a day. Joining the Marshfield Clinic is St. Joseph's Hospital, approximately 600 beds. The Marshfield Medical Center Laboratory serves both the hospital and clinic, as well as over 400 accounts throughout the state of Wisconsin. And then the Marshfield Medical Research Foundation is also part of the complex. But what I'm attempting to show here is that these really represent car routes, and we dispatch about 16 cars every morning, 5 days a week, that travel to various physicians' offices, small clinics, hospitals throughout Wisconsin. We even get down here in the Milwaukee area, as well as pretty close to Minneapolis and St. Paul, as well as into the finger of Wisconsin here that goes down into Lake Superior. And what has happened here is that because we're an endemic area, you can imagine the number of immunoserologic tests that we performed for Lyme disease. And in 1986, it was approximately 5,000. We did project 55,000 for this year. However, based on the 4 months of this year, we will be well over 65,000 tests. Now, a number of us have looked at this realistically. And the only conclusion we can come to is that in about the year 1994, everybody in Wisconsin will know their Lyme titers. So I guess we're after a baseline Lyme titer. I really don't know why, but anyway, what I was going to attempt to do this morning, like I say, is just talk about some of our observations and more so some of our concerns, because this means things have gotten out of hand, and I don't know what to do about it, nor do a lot of us know what to do about it. If we look at the diagnosis of Lyme disease, And we have characteristic clinical manifestations. There's no tick exposure in an endemic area, and there's seropositivity. There's no problem making a diagnosis of Lyme disease. But what we are finding is that this triad really does not exist that often. Now, the primary method that we have used in our laboratory is the indirect fluorescent antibody assay. This particular assay is the one that was standardized by CDC. We employ an APO suspension as absorption. We utilize substrate slides, which are prepared by Bion Enterprises. A positive result is labeled as greater than or equal to 1 to 256. I'll have more to say about this a little bit later on. The majority of our tests, we are assaying for polyvalent antibodies. However, we also test for specific IgG and IgM by the IFA methodology. I might add that there are 3 laboratories in Wisconsin that have performed an IFA procedure. And the 3 of us get together periodically. We share serum, and we are very, very happy with the intra-laboratory results. For about the last year, we have been working with the fluorescence ELISA immunosorbent assay, which has been developed and marketed by 3M Diagnostic Systems. We have really put this assay through the works. And I'm happy to say that we are well pleased with the assay. And the primary reason we're well pleased is that they have reached a degree of specificity that I think is very, very important in immunoserologic testing. Sensitivity is fine, but we're really after specificity. And although there still are some problems in this area, I think they'll be corrected shortly. This particular assay detects both IgG and or IgM, and we label as a positive a result of greater than or equal to 10%, which is a percent of the reference serum, which is used in the assay. First of all, I would like to say something about the IFA methodology. I love this test, and it is a great test, but you don't have to know how to perform the test. Now, the first thing that you notice on this slide, at least that I noticed, is the uniformity of the spirochetal microorganism. The morphology is excellent. You might see a few brighter stained areas that can be representative of the gamma or cytoplasmic webs of the organism. But we know that those bodies are really associated with older microorganisms or organisms that have been cultured in an unfavorable environment. Here we have organisms that are very uniform in length, and then when we look at staining intensity, I'm sure that nobody will disagree that this is like an 8 plus or a 10 plus. And we see this type of reactivity with some sera at 1 to 64, which is our initial dilution. And then the 1 to 128 is negative. Now, based on our criteria, our cutoff point is 1 to 256. Is this example an example of a negative test, and therefore a label of negative seropositivity? I don't think so. If I see a reaction like this, 1 to 64, maybe a 1 plus or a 2 plus, 1 to 128, and 1 to 256 is totally black, I think that is significant. And the physician deserves to be notified of that. However, that's not the way the test is really performed. Now, there's also problems with the IFA when it comes to interpreting when you have a background that is not nice and black like this, and your organisms are fluorescing at a 2 plus or a 3 plus. And they look like that at 164, 128, 126, 1512. To me, this is not a reaction of positivity. And once again, that reaction should be conveyed to the physician. But what we're seeing here is a nice clear background. We're seeing nice homogeneous staining of uniform-shaped microorganisms. And I feel that this is indicative of a very nice positive test. A few more comments about the IFA. Because you are visualizing the reactivity, I do not feel that it is a subjective type of interpretation. It's an objective type of interpretation. A lot of people that talk about indirect fluorescent and light techniques will attempt to convey to you that IFAs are subjective. Well, they don't have to be, especially to those individuals who are trained in this particular methodology. Atypical reactions are rarely discernible with this technique. And when you see spirochetal organisms that are staining lumpy bumpy, they've got globs of fluorescent globulin stuck on them, this is not a specific reaction. And we see this type of reactivity with several patients that have no rheumatoid arthritis, lupus, and other diseases. And then there are that group of patients that demonstrate this type of staining that we really don't know why. We recommend repeat testing on these patients, and in a number of them, 4 to 5 weeks later, we can do a nice test without those atypical reactions. And IFA methodology, no matter what anybody tells you, is easily controlled and standardized. We have found that out in Wisconsin. Quality of substrate is detectable, and this is most important. We have looked at a lot of substrate slides prepared by different commercial suppliers, and all I can say is I have seen some horrible substrate slides, and I do not think they should be used to assess the serostatus of patients suspected of having Lyme disease. As I mentioned, this methodology is applicable to isotype determinations. Yes, it is very labor intensive. And I've got some technologists that I know would like to walk out the door, but they're hanging on right now. Also, you need technical expertise to perform this procedure. But once you have your technologist trained, you've got to train. And I do a lot of reading myself, approximately 1 to 2 hours a day, and I have 500 people that read, and about twice a month, we just pull out slides at random, and then compare results, and we compare very, very well. Most generally, it's 100%. So much for my plug for IFA methodology. Some of our experiences, this particular study was done a couple of years ago when we looked at 200 normal individuals. They were scheduled for their routine physical at the clinic. We picked out 100 male, 100 female, and did the IFA methodology on their sera. As far as seropositivity, 22% of them had titers of 1 to 256 or greater. There were 21 males, 24 females. However, there were 30 of these 45 that had a titer of 1 to 256. I don't know if this is real or not, but I have a sneaking suspicion it's not real, particularly in this group of patients. By the way, the 15 patients that had a titer of 1 to 512 or greater were offered therapy. None of them wanted it. They were asymptomatic. We continue to follow these patients, and they're all doing well. But this group, I really have my doubts about. The Marshfield Medical Research Foundation performs an ELISA procedure, polyvalent G&M, and we decided to pull out a bunch of sera that we had performed IFA on and look at their ELISA procedure. And this is using a whole cell extract. And as you can see, we really don't have any problems up here. But here, 56 sera gave a result of 1 to 128. That's a negative by our criteria. There were 19 that were positive by this assay. However, sometimes it was just the M, sometimes it was just the G. Other times it was polyvalent and the M or the G. There were all kinds of combinations. So really, what percentage of that is, what number should be added here for true negatives, we really don't know. 256, once again, is a problem area, but excellent correlation at the 1 to 512 and over. We have also submitted a number of sera blindly, both to our laboratory and to the Mayo Clinic, where they use an absorbed enzyme immunoassay. And there were 168 sera, and we labeled these individuals from Wisconsin. 125 of them were negative by both assays. There were 11 that were positive by both methods. There were 24 that had a positive IFA but a negative EIA. But very interesting, there were 19 of these 24 where the titer was 1 to 256. And once again, I emphasize, I think that this can be a questionable area. There were 8 sera that were positive by the enzyme immunoassay, negative IFA. However, all 8 of them were reported by Mayo Medical Laboratories as weakly reactive. Once again, we attempted to look at some sera from a non-endemic area. And at that particular time, I was told that fits that category. And we obtained 25 sera. Very interestingly, there were 3 sera that were positive by both the IFA and the ELISA procedure. There were no discrepancies at all on the negatives. The place where I received these sera did have follow-up on 2 of these 3 patients, and a diagnosis of Lyme disease had been made in those patients subsequent to the collection of these particular serum samples. One of the patients was lost to follow-up due to moving out of that particular area. Okay, I just want to show you some of our preliminary information on the fluorescence ELISA developed by 3M. And this work will be presented at the ASM meeting in a couple of weeks. We looked at a limited number of patients with documented Lyme disease. There were 6 individuals that were diagnosed with early disease in the ECM stage, and all 6 were positive by this particular assay. The late stage patients, there was 31, 30 gave positive results. The one patient that gave a negative result here did have a positive IFA, and the patient was treated very early during an ECM stage, and the serum wasn't collected until the late stage. As you can see, yes, there is a specificity problem, but more recently, we have seen a distinct decrease in the number of reactive sera from patients with infectious mononucleosis, those patients that have nuclear antibody, and those patients with syphilis. So these particular percentages are lower based on some of our most recent tests. The particular normal subjects that were used here were some of my laboratory employees. Most of them are avid campers, avid hunters. They're true Wisconsinites. They're in the woods those other 6 months. And as you can see in this particular group, which is small, that there were no reactive biofluorescence ELISA, and their IFA titers were negative as well. Okay, and these are the reactivities of selected serum antigens of correlative or dorsiviriate in both the IFA assay and the 3 fluorescence ELISA. As you can see, those sera we had an IFA of less than or equal to 128, which we consider negative. 90% of these were negative by the ELISA. Great correlation at the positivity range, and you want to call this a clinical range or a positive range. Once again, excellent correlation. And then there were those sera that gave those so-called non-specific results by IFA, which you can see visually. And all 25 of those sera tested positive by the ELISA methodology. Once again, this is our preliminary work. Within the last few weeks, we have pulled out one of these sera, non-specific sera, and we see a reduction down to about 60% with those sera. And once again, the high-titer rheumatoid factor as well as nuclear antibody. So our conclusions were that the fluorescence ELISA is a highly sensitive assay, and it correlates very well with the IFA methodology. And I strongly feel that it lends specificity to laboratory testing, which we are in badly need of. We really don't need another VDRL for the diagnosis of Lyme disease. We need that FTA or an MHATP for the diagnosis of Lyme disease. The assay is reproducible, it's easy to perform, and applicable for high volume testing. And you can see why with some of those figures that I showed you earlier, why I'm interested in looking at an assay like this because of the large number of sera that we're testing. There are observed cross-reactivities, and of course we strongly emphasize the clinical correlations when interpreting the results. I don't think I have to go through all of these assays that are currently available. The enzyme immunoassays, some of them use whole cell extracts or plasma or antigen. Some have modified them with absorption. Of course, there's several antibody capture ELISA methodologies being used. Immunoglobulin, yes, we have a real problem patient. We do immunoglobulin. fluorescent immunoassay referring here to Whitaker's Speedax, and there's a report or two utilizing an indirect hemogglutination assay, but this is really not found much popularity. Up until a few weeks ago, I at least tried to be very fair and list here all of the commercial suppliers of various reagents for immunoserologic testing. And let me just say that I've heard good reports. I've heard bad reports. We had some experience with a number of these assays in our laboratory. I'm really not ready to voice an opinion yet. But I will say one thing, and I encourage this, is that not every diagnostic laboratory or physician's office that has a laboratory should be doing testing for the detection of antibodies for Borrelia. I highly discourage it, because there has to be some order brought about to some of the confusion that exists with immunoserologic tests. We have to remember that there are various antigenic components of Borrelia, which react with antibodies to other Borrelia species, Treponeme species, Leptospira, and of course, probably a big culprit is that common antigen of both gram-positive and gram-negative bacteria, as well as the Epstein-Barr virus. We also know that antigenic components of Borrelia react to rheumatoid factors, anti-inflammatory antibodies, thyroglobulin antibodies, and there are no doubts other antibodies as well as other so-called non-specific globulins, which will give reactivity with these antigens. Reviewing some of the problematic issues, and I'm not going to spend much time on this, we do know that antigen variations occur among isolates of Borrelia burgdorferi. But is this really a concern of immunoserologic testing? I don't think so. What about the differences between European isolates from the United States? Differences have been shown, but I don't think that they're really that significant when it comes to the applicability of serologic testing. We know that cross-reactive antibodies are present. We know that there are complex and variable immune responses in infected patients. We know that antimicrobial therapy, given very early in the disease, can abort the immune response. Infection versus disease. Yes, we do know that infection occurs without subsequent disease. But where is the role of immunoserologic testing in making this differential, especially when you think in terms of cross-reactive antibodies? There are variable clinical presentations and findings of the disease, and a subject which I could probably talk about for a couple hours is the non-standardized commercially available immunodiagnostic tests that are out there. And this is why I think that not all laboratories should perform these tests. Publicity, public awareness, yes, these also contribute to our dilemma of coming up with a test that gives good, reliable, specific results. In closing, just a couple recommendations. First of all, there must be a discriminate use of immunoserologic testing. I do not think that all Wisconsinites need a baseline type. I want to make that very clear. Also, correlated interpretations of immunoserologic test results must be made by the intended physician in terms of clinical findings, pertinent patient history, and of course, epidemiological information. Thank you very much. Positive with an IFA. At this point in time, yes. Thank you. But next week I may change my mind. And the reason I say that is that I know that there are people at 3M that are working very diligently on the specificity problem, as well as other commercial companies, as well as us. And it's, like I say, sensitivity doesn't bother me a bit. All the assays are sensitive, but it's the specificity questions that we start to have to answer. Yeah.
Can we do this later? We need to move on then. Our next speaker, I'm very happy to present, is Dr. Ted Stein representing the newly developed Lyme Borreliosis Division at CDC at Fort Collins, Colorado.
Thank you, Karen Fortune, for inviting CDC's participation in this symposium. As you know, CDC has maintained a national surveillance system for Lyme disease since 1982. The data from 1983 to 1986 were published in the Third International Symposium. Today I'll be presenting data from 1987 through 1988. I'd like to just give you an indication of what we hope to accomplish with this national surveillance, because the data that are collected is somewhat limited. Obviously, we'd like to follow secular trends and currents, geographic distribution of cases, and describe the epidemiology of the disease in terms of demographic characteristics and risk factors. We have two sources of data which I'm describing today. One, statistics on the case number come directly from the survey of state health departments. We merely called and wrote to state health departments to inquire about numbers of reported cases in individual states. So we have only raw numbers of cases in that data set. We also have a set of data from case report forms submitted to CDC from serologic specimens that were submitted, as well as case report forms submitted spontaneously by the states. This makes up only a small subset of all of the cases known to the states, but more detailed epidemiologic data are available on these cases. Since 1982, when there were about 500 cases reported, the incidence of Lyme disease has increased quite dramatically in the United States. In the years 1983 to 1986, there were approximately 1,500 cases per year. In 1987, there were approximately 2,500 cases, five times the number in 1982. And in 1988, we saw a doubling from 1987 to approximately 5,000 cases. This slide was made at a time when the reported cases to us was closer to 6,000, but that figure has been revised down to about 5,000. This shows the distribution of cases by region as well as the national totals. In 1987, there were 2,369 cases reported. In 1988, approximately 4,500 cases. You'll note that the combined total of these 2 years exceeds the total of cases from 1980 to 1986. The Mid-Atlantic region, which is just a three-state, it's a Census Bureau region of New York, New Jersey, and Pennsylvania, reported a vast majority of cases, 57% of the cases. The Northeast, which includes Connecticut, Massachusetts, Rhode Island, principally, and New Hampshire, Vermont, and Maine as well, reported 21% of the cases. North Central states, principally Wisconsin and Minnesota, reported 14% of the cases. And Pacific, chiefly California and Oregon, reported 213 cases in 1987. There are no reports for 1988. Finally, the southeast, exactly the southeast and the southwest, there was a fortunately small number of cases, about 5%. And lastly, the mountain region, very few cases were reported. greatest growth in numbers of cases by region occurred in the Mid-Atlantic states, New York, New Jersey, Pennsylvania. This shows a cumulative percentage of cases over time by region. And for most of the regions, there's a fairly steady increase in numbers of cases over this period. For the Mid-Atlantic region, over 60% of the cases were reported in 1987 and 1988. You can see in 1986, only 40% of the total cases in that region had been reported. And in the next 2 years, 60% of the cases ever reported in that region occurred. So the increase in the incidence of Lyme disease has been fairly focal in that 3-state region. I've given here the incidence per 100,000 with confidence intervals, plus confidence intervals for the region. And I include confidence intervals here not because the data are so exact, but so that you can make comparisons and know whether a difference of 6 versus 3 is significant. In terms of incidence, again, the order of regions here has not changed. The greatest incidence was in the Mid-Atlantic region, followed by the Northeast, although these differences were not significant. North Central Pacific had about a 10-fold lower incidence. The Southeast, yet lower, and the Mountain, the lowest incidence in the nation. All of the states reporting greater than 1 per 100,000 incidents were the Mid-Atlantic, Northeast, and then Minnesota and Wisconsin, the North Central region. So this overall regional incidence is diluted somewhat by all the other states in the region in which Lyme disease occurs relatively frequently. I think it's interesting to note that the regional incidence is parallel to some degree with what we know of the infection rates in vector ticks, and that there are approximately 10-fold differences in infection rates in exotic ticks in the Southeast, the Pacific region, and the Northeast. And there is a parallel difference in incidence rates in the Southeast, Pacific region, and in the Northeast and Mid-Atlantic states. This shows the state incidence. Again, the highest incidence areas are Minnesota, Wisconsin, and the Northeast. These are the only states reporting incidence rates from 1 to 10 per 100,000. In the Pacific Coast and in scattered states in the Southeast and in the North Central area, there are rates of 0.1 to 1 per 100,000. To other areas of the Southeast and the mountain states, 10-fold lower rates were observed. Nevada and Missouri previously reported Lyme disease, but none had reported no cases in 1987 and 1988. So the states in which we have not received reports of Lyme disease from states, it's not to say that there may not be individual clinicians here who have seen Lyme disease from these states. The 7 states that have not yet reported Lyme disease to us all are in the West: Montana, Wyoming, Nebraska, Arizona, New Mexico, Alaska, and Hawaii. This shows the county distribution of cases from 1987 and 1988. In the solid photos, the solid counties are those counties that reported Lyme disease through 1986, and the striped counties are those new counties added in 1987 and 1988. So the areas in which Lyme disease has been reported in the last 2 years, newly reported in the last 2 years, have been principally in these areas in the North Central states, in the Southeast, and scattered areas in Pacific and mountain states. Here are, this is not the 10 states, it's actually 9. By state, the 9 states reported the most Lyme disease cases in 1987 and 1988, with the average annual incidence for those 2 years. New York, with 2,553 cases in 1988, reported almost 55% of the nation's cases in 1988. I should say these 9 states made up more than 90%, 95% of the nation's cases in 1988. The highest incidence actually was observed in Rhode Island, 9.89, slightly higher than the incidence in New New York. But I think we should be aware that in New York, of the 2,553 cases, more than 70% occurred in just two counties, Suffolk and Westchester County. And those two counties reported 45% of the nation's cases in 1987 and 1988. Again, that gives you an idea of the regional nature of this problem. I think it's probably appropriate to look at the incidence of Lyme disease with respect to other communicable diseases that are notifiable. And using the 1988 Lyme disease statistics versus the 1987 statistics for these other diseases. See, Lyme disease is equal in incidence to a number of problems that we think of as public health problems: chancroid, non-A, non-B hepatitis, measles. Although there is low mortality associated with Lyme disease, it has chronic effects, and therefore I think one can appropriately say that Lyme disease is a public health problem on a national level. Certain Lyme disease is the leading vector-borne disease in the United States. In a 5-year period, 6-year period from 1983 to 1987, of the reported cases of vector-borne diseases, Lyme disease, Rocky-Mountain fever, Colorado tick fever, other viral encephalitis, flea-borne diseases, meningitis, and plague. Lyme disease constituted 50% of the approximately 7,500 cases reported. The second interesting point about this figure is that tick-borne diseases, Lyme disease, Rocky-Mountain fever, Tularemia, and Colorado tick fever, make up 95% of this Lyme. So that our division previously was devoted entirely to the study of other viral encephalitis and plague. You can see the impact of this new responsibility upon our division. Again, looking at the regional differences in numbers of cases, I think it's important to note that clearly in the Mid-Atlantic and Northeast, Lyme disease is a much more important vector-borne, tick-borne problem than Rocky Mountain spotted fever. But in the Southeast, Rocky Mountain spotted fever remains the principal vector-borne disease reported. There are many-fold more Rocky Mountain spotted fever cases reported in the Southeast than of Lyme disease. Certainly it's a disease that carries a significant mortality when untreated and should be recognized. I'd like now to describe some of the epidemiologic features of Lyme disease generated from a study of the cases reported to us in 1987 and 1988. There were approximately 6,000 case report forms submitted to the years interval. We made an initial selection by just going through individual forms, picking out those that had either paradigm migrants or positive serology. This is just a simple way of sorting through the forms. And from that group of patients, we were able to find 976 meeting clinical case definition. Now, there are many problems with this data set because they only reflect 14% of the reported cases that I've told you about previously. And there are major underrepresentations of reported cases from the Northeast and the Mid-Atlantic areas, which report most of the Lyme disease in the country. We have no data at all from New York and New Jersey, and we only recently have received data from Pennsylvania and Connecticut, and no data at all from Wisconsin. We have promises from each of these states that they would send us data from 1987 and 1988, and when we get them, then we will have 98% of the reported cases. So the data set will be an accurate representation of what's going on in these 2 years. The other characteristic of this data set is that it overrepresents California. This shows the distribution of reported cases and the distribution of our reported forms by region. And again, the major underrepresentation of the Northeast and North Central states, and then here you can see an overrepresentation of the Pacific region, which reflects mainly reports from California. We actually have more cases reported from California report forms than were reported to us in the survey of the state health department. The definition that we used in analyzing these data, the definition of the case that we used was the old CDC definition, which is ECM or positive laboratory serologic test and involvement of one or more organ systems if the person was exposed in an endemic county. If the person was exposed in a non-endemic area, then ECM with a positive laboratory serology or involvement of two or more organ systems which are required. Now, unlike the data set of 1983 through 86, in which 94% of the cases had erythema migrans, in this data set, there were only about 69% of the cases had erythema migrans, and about two-thirds had erythema migrans, and the remaining third had systemic manifestations. You can see that 92% of the cases were from endemic counties, and the remainder were from new counties that became endemic with the recognition of these cases. This gives you some descriptive epidemiology of this data set. Nothing has changed here. The overwhelming proportion of cases are among Caucasians. A few cases among blacks occur principally in the southeast and among Hispanics and Asians in the Pacific region. There are some interesting characteristics of the age-specific incidence of Lyme disease, which is seen fairly consistently in every state. The rates per 100,000, again, this is just for reference purposes. I don't mean to imply that we know these rates with any great accuracy. But there is a peak of higher incidence in children, a decline in incidence in very young adults, teenagers and young adults. And the highest incidence occurs in the age group of 25 to 44, and the decline with age thereafter. Show you a graph of that later. We saw no differences in risk by sex. There was a slight predominance of cases among females, but that is not significant given the larger number of females that are in the population. There were some regional differences in the age-specific incidence, in that there were fewer children with Lyme disease reported from the Pacific, and more adults in the 25 to 44 age group. If one looks at just the adult cases, there is still a low representation of adults in this age group in the Pacific region compared to others. So this is shown graphically here. This line, this lower line, shows the age-specific, percent of cases by age in the Pacific region. There's almost half the number of cases in this age group compared with other regions. Here's the decline in the 15 to 24 age group and the age-specific rates in adults. You see an exaggeration of this peak in the Pacific region compared with other regions. The general shape of this curve is consistently seen in state reports from Wisconsin and New York and other areas. It suggests that it's consistent, at least, with a paradomestic source of exposure in which children and parents, essentially, are exposed. And perhaps teenagers who may be less frequently present around the house may escape exposure. That's an inference. There's no data. Certainly not due to less grooming. Here's the distribution by occupation. Overall, the numbers of cases with a reported outdoor occupation is relatively small. This is fairly consistent with sero surveys done in other countries as well as studies in New York and New Jersey. Only about 5 to 10% of outdoor workers are infected in these studies. seasonality of cases, again by region. Overall, it's just hard to see these X's, shows the national epidemic curves with the peak in the summer months from May to August. The Pacific region, shown here in the diamonds, the epidemic curve is flattened somewhat, so that 40% of the cases in the Pacific region occurred at an onset reported between January and May, whereas only about 20% of the cases in other regions occurred in those months. A very large proportion of the cases reported systemic complications, and I think this is an artifact of the way in which cases were identified, largely through submissions of serum samples. So that in this set of about almost 1,000 cases, a much larger proportion of patients than we reported in the clinical series had neurologic complications and perhaps arthritis. The clinical series, I think the clinical series report approximately 50% of cases with arthritis, but prospective studies in Connecticut indicate that a much lower proportion, perhaps 20 to 25% of all cases have arthritis. Again, there were differences in the Pacific region with more cases reporting arthritis in that region compared with others. This is a significant difference. And this may reflect something, it may have some bearing. The circumstances under which these patients were identified have some bearing on this. You can see that in the adults reporting Lyme disease in the Pacific region, there's a much higher rate of arthritis than in similar age groups in other regions. We don't know much about how these cases were identified. It could be that what we're seeing are cases reported mainly through clinics in which arthritis is a concern, and this may be entirely a reported artifact. Certainly, is an observation that needs following on. It is the first indication that I'm aware of that there may be some regional differences in clinical presentations of Lyme disease within the United States. So in summary, in 1987 there were approximately 2,400 cases reported, almost double that number in 1988. Cases now have been reported in 43 states, but 92% of the cases have been reported in just 8 states, in the Mid-Atlantic, Northeast, Wisconsin, and Minnesota. The major increase in cases in 1987 and 1988 occurred mainly in these Mid-Atlantic and Northeast states, chiefly in New York. The 7 states not reporting Lyme disease all are in the West. And there is a parallel of the regional incidence versus infection rates in vector ticks. There's no great changes in the demographics of the disease since 1983 to 1986. And we've identified some regional differences in cases reported in California versus other regions. The fewer cases were reported in children. There were more cases in this 25 to 44 age group. A large proportion of cases had arthritis, and the seasonality of the disease was more diffuse. I'd like to just talk about some of the other issues that we hope to address, epidemiologic issues that we hope to address at CDC. I think defining the circumstances of exposure and risk is really one of the key things that we need to find out in order to develop appropriate prevention strategies. The only study that I'm really aware of in which the question has been asked, where do you acquire Lyme disease, was one done by Falcon and Fish in Westchester County, in which they found that almost 70% of cases can be traced to infection in the yard. I think if that's the case, Lyme disease is quite different from most tick-borne diseases, which we think of as diseases with an occupational and avocational exposure. Tick-borne diseases are diseases of place, and they usually require fairly limited, often somatic locations. And people are infected in their occupations or during avocational pursuits. It's almost unprecedented, with the possible exception of lapsing fever or acquired influx in Africa, to have a paradomestic site of exposure for tick-borne disease. So I think that the design of prevention strategies is quite different for that situation versus protecting individuals house is in the background. I think the reverse is the situation of Lyme disease in this country. So the design of prevention and control strategies must take this into account, because the frequency of exposure and occupational and avocational disease requires a different approach, which personal protection is a logical approach. In a paradigmatic environment where exposure is ongoing and where environmental impact on humans living in the environment must be taken into greater consideration. Personal protection may have a role, but environmental and ecological modifications, I think, are probably more important. We have, in the past 6 months, initiated some studies and contracts with various groups in the country to address some of these epidemiologic issues. We're working with a group in Massachusetts to define the risk of Lyme disease in Massachusetts state workers who have park maintenance workers. We will be doing some studies with Burlington Fish in Westchester County to define the density of tick vectors in various habitats in Westchester County. We hope to do a study of economic costs of Lyme disease in an endemic focus in New Jersey. And we hope to characterize with Jose Rivera at Public School of Public Health, to characterize the antibody response to accelerated Lyme proteins following bites of not only Xodes gammoni, but other vector ticks, to see what the specificity of the antibody response is, whether it can be used in some way to help in the clinical diagnosis of Lyme disease. Finally, we're looking at Lyme disease in the western United States in 2 studies. Dr. Roy has reported on Lyme disease, Lyme syndrome, occurring in patients who may be infected with relapsing fever. We plan to do a retrospective study of relapsing fever cases that occurred in the western United States in the last 20 years to see what proportion of these patients may have chronic features that of arthritis or neurologic complications that have not been associated with relapsing fever. We'd like to look at the serologic specificity of the reactions of some of these patients to see if there are peculiar reactions against the various ingredients, whether there's any pattern, whether there's a pattern of reactivity that may be unique to patients with Lyme disease in the western United States.
Disease which is different exactly from those that are from occupations such as leptospirosis, for example, or other spiral disease. And in Massachusetts, the Department of Public Health is doing a study right now that was just reported on in Worcester at a symposium where they are looking at seropositivity of canines in Massachusetts and the use of canines as a sentinel for human disease. It hasn't gotten down to the limits of taking a look at the data and showing that particular street is where you can find disease, although there are a couple of towns in Massachusetts where you can find actual streets where you don't want to walk down. That's very true. But using serology, IFA in this case, made a comparison and shown pretty good agreement between canine infection and human infection. I just want to bring up a point, and that is that no assay, to my knowledge here, is FDA approved or otherwise, is diagnostic of Lyme. It can only be used in conjunction with the clinical manifestation, clinical diagnosis by what I would call a physician who's competent in Lyme disease. I think really it's that way too. And in terms of specificity data that we've seen, any specificities or cross-reactivity data that are greater than 10% causes a real problem in using that assay because it just doesn't show the specificity necessary.
Do you have any mortality statistics?
No, we don't. I think what's important in the literature is all that's available to us. I think the greatest mortality is in general infections.
Yeah, just one of the issues that's been brought up repeatedly in meetings is that of standardization. I think one of the things that was brought forth in one of the meetings was that there is a need for standardization, and perhaps CDC at their facility might be taking that task on.
Yes, I meant to follow up on that as well with that comment. The Association of State and Territorial Public Health Lab Directors, in conjunction with Dr. Hanson and Margaret, will be looking at commercially available diagnostic kits in a multi-center study in which 3 or 4 state health departments and a couple of other reference laboratories will all be using the same kits on the sample set of zero to look at interlaboratory variability and precision and other issues.
Thank you very much. Next speaker I would like to introduce is Dr. Alan McDonald from Southampton, New York. Speak. His first presentation today will be the dermatologic manifestations of Lyme borreliosis.
Thank you, Julie.
I have 94 slides to show you this morning. I'd like to invite you, before I go on this Federal Express rapid fire delivery, for everybody to stand up and take a stretch. And while you're doing that, I'd like to thank my wife, who's not here today, who's allowed me to be one-dimensional for the last 5 years, and to let me accumulate some of the materials from patients that I'm going to try to share with you today. The previous speakers have covered an awful lot of very important territory. One of the things I'd like to touch on, which has been alluded to very briefly, is the model with syphilis. I think that clinical observation over 400 years gave us a lot of information that was very useful in syphilis. None of that depended on laboratory testing. And just about all of it has held up in the post-spirochetal treponema era, so that the clinical observation, which is the essence of the practice of medicine, is very important. And what I'm going to focus on today is one of the possible clinical manifestations of Lyme disease, which we call path on the mind, which means it is bulletproof. You see what I'm going to show you. This is Lyme disease, period. No laboratory test is necessary. You don't need to have a crutch. You don't need to have somebody hold your hand. There are, at the end of the lecture, some cases that I'll show you that are red lesions of the skin which are not Lyme disease. Lyme disease is not somebody else's problem. Let's go back to syphilis again. The French thought it was the Italian pox. The Italians thought it was the English pox. Lyme disease here is everybody's problem. And to quote Dr. Steer, one of the most difficult things to do is to get a physician to diagnose his or her first case of Lyme disease. For that, you have to look at activation energy. That's the atomic bomb that you have to put under the chair of the doc to get them to take this infection seriously. Can I have the first slide, please? While that's coming up, McDonald's first caveat. It is always easier to make a less specific diagnosis than a more specific diagnosis. Then lights off, please. And the first slide. This is a physician. The physician is a surgeon at our hospital. Writing a post-operative note in the recovery room. McDonald comes in for a cup of coffee. Across the room from 25 yards, the diagnosis. There is only one correct answer. What is the diagnosis? Erythema chronicum migrans. Now, chronicum is an artifact. We don't use chronicum anymore. We call it erythema migrans. Erythema is area. Here it is in the intubral fossa. The physician has no symptoms. You may think it's a spider bite. It's not a spider bite. Black widow spider, brown food spider, they can bite, do symptoms. Other spiders, to my knowledge, are not capable of inflicting injury on a human host.
It is not ringworm. If you want to find out whether it's ringworm, do a blue light exam. Take a quick look. Ringworm shows up with a phosphorescent glow under black light. It is not a localized sunburn. Didn't forget to apply the PADA to an antifungal process. This is Lyme disease, plain and simple. There is nothing else that I know that corrects answers. Now, a brief appeal to Dr. Ted Sy. Dr. Sy, I think, is the best thing that's happened to Lyme disease from the CDC point of view, since my personal contact with the CDC over a 5-year period, and I applaud what he's done. One thing that he's saddled with is the obsolete definition, which requires erythema migrans plus positive serology. You know, the great many patients who have this sort of lesion never develop an antibody titer that's convincing. So I hope that we can get that arcane definition out of the CDC case criteria. Next slide, please. What's wrong with this slide? It's not chronic all the time. As Dr. Bergdorfer said, chronicum was applied to the disease to describe a particularly exaggerated form of it that may be transient. Next slide, please. This is a lesion from the back of a 7-year-old child that had come from New Jersey. Didn't know that Dr. Drew was in New Jersey. To Long Island to get a diagnosis. What is it? Erythema migrans. Has a two-tone edge, advancing red erythematous border. This is on the posterior back near the belt line. Next slide, please. How does it start out? It may start out with a crusted area near the tick bite site. And our little hospital booklet from Southampton Hospital says Lyme disease, a small tick can leave its mark for the rest of your life, if not correctly diagnosed and treated. Next slide, please. There are the non-parts of the tick, and they are in yellow. See if we can get this one here. Focus out a little bit. You see that the non-parts of the tick then embed themselves just beneath the epidermis into the papillary reticular dermis, and from this point on, it's all downhill with the spider weed. Next slide, please. This is the way it starts out. In our area, with 85 to 100% of the ticks carrying the spider weed, we've had a very successful program of public education. Our patients are particularly sophisticated, and they will look at this lesion. They'll go down, find power. This is from a youngster. There are two little red bites that might be called non-specific. Next slide, please. Mother has the same thing. Mother pulls up from her arm. Next slide, please. A very small exotic tick, which is capable of, very often in our area, is capable of carrying this spider weed, really a Bergdorfer. Next slide, please. Now, lesions have lives just like all of us. So it starts out as a little red spot, and then it expands. This is about 4.5 centimeters to 9.5 centimeters to 25 centimeters. This is across my body. I'm not sure whether some of you more hefty Texans would have a broader span across the anterior midline or posterior midline. Next slide, please. And you may have two-tone varieties. You may have a bullseye configuration. You may have a homogeneous spot. You may have the 45 centimeter to 50 centimeter variety, which will cover from clavicle to belt line and beyond. Urticarial forms in children. You may actually have to have the patient disrobe. My God, disrobe patient, physical examination. That's almost museum quality here in rapid high-tech medicine. You may have to look under the armpit to find it. You may have to look hard. I'm going to show some of these faint advancing boards where the center is not very impressive. All the action is the edge. Or you may have multifocal disease, which orients itself along line response. Next slide, please. So, here we are. Criteria for diagnosis. Bulletproof. Erythema migrans. Nice, but not necessary, protection of the immune response. And as Dr. Duray will show you later on, detection of the spider weed. Also bulletproof. Next slide, please. This man came to us telling me that when he sleeps at night, one arm is around the wife, the other arm is around the dog. Guess which side? Don't let your pet sleep in bed with you, and tell your patients not to let the cat asleep in the bed. Very clear that the tick got him here. There's the crust. Next slide, please. The lady with the two-tone variety. You can see there's a little pale area between the two advancing edges. Next slide, please. This is Lyme disease on suntanned skin. One of the great unfortunate things that I see from the CDC data from 1987 is that Lyme disease is underdiagnosed in black people and in dark-skinned people. And I will pay a bounty for somebody who will give me a photograph of an erythema migrans lesion on the skin of a black patient or a dark-skinned patient. They do not exist as far as I know. This lady came to our area, got a suntan, there's a little intensification here, that's the whole erythema migrans lesion there, and the rest of it is suntan. So it's extremely difficult sometimes in its paler forms to see on darkly pigmented skin. 2.5% of the 5,000 cases in the CDC registry are reported in black people. 2.5%. I think it's a great challenge for us to do better in the diagnosis of Lyme disease in black people and dark-skinned people. Next slide, please. This is a lady who came for a weekend and went home with a special surprise. Here she is, right here, and we know what it is, and we gave her some medicine. She did well. Next slide, please. You have seen this slide before. If you were paying attention to Dr. Bergdorfer's lecture. This is from Dr. Bernard Berger's magnificent collection. There are migrants lesion on the skin of the back, central red intensification, pale advancing edge. Next slide, please. This is a lesion that appeared in one of our papers, a spectacular lesion. Dr. Raymond Beckwell reviewed the paper, didn't like it. He said it wasn't typical. I'd be very careful to tell Dr. Berger that he doesn't know what Lyme disease erythema looks like. But he also said that biopsy site in the center. I don't like that either. That's not a biopsy site, Dr. Beckwell. That's a mole. Next slide, please. Next slide, please. Here it is with a two-tone variety, an oval shape, sometimes following Langer's line, sometimes in the creases. Next slide, please. This is a pale area. Dr. Berger always biopsies the edge of the lesion, and that's where he finds spirochetes. Dr. Steer tried to find the spirochetes by biopsying the center and failed miserably. So if you're going to find the spirochetes, you look at the advancing edge. Now there's studies in the works, and I think Dr. DeRay will be involved in these, which will look beyond the area of advancing erythema to see if the spirochetes are there too. And I wish Dr. DeRay the best of luck. It's a very tedious process, and he'll have some information to show you later on. Next slide, please. Well, this is a homogeneous erythematous patch that is approximately 7 to 10 cm in diameter. Next slide, please. This is a lesion that's almost purple or blue, and I'd be careful about misinterpreting lesions in children that look like child abuse. This is almost a purport form of the disease, and this is a very intense form of Lyme disease. I believe we will help this spirochetes from the biopsy of this patient. Next slide, please. This is on the skin of the breast, and you can see that sometimes it's triangular shape. The tightly fitting garments can find the spread, they think, that's really not sure, but it is not obliged or obligatory that the lesion be round or oval. Next slide. Here it is, and we did culture from this patient. Spirochetes came out after 10 months. 10 months in the incubator before the spirochetes grew to a dark field threshold. This patient has it on the neck region. Next slide, please. On the back again, you can see crusted center and advancing erythematous edge, a clear zone between the two. This is a variety of two-tone erythema migrans with a non-homogeneous advancing edge. Next slide, please. Langer's lines are used by plastic surgeons to make sure you don't get scars when they do surgery. Lyme disease orients itself sometimes when you have more than one lesion along Langer's lines. I have absolutely no idea why that's true. Pityriasis rosea also does that, and other erythematous conditions are less likely to do that. So here we worry about pityriasis rosea versus Lyme disease. Pityriasis rosea has a colorated scale, little white flakes. These lesions do not have scaling that we have so far identified. Next slide, please. Multifocal disease, spectacular case from Dr. Berger's collection. This patient was very sick, and you can see that the lesions are not distributed in any particular fashion. Next slide, please. Now, where is the lesion? Does this patient have Lyme disease? Have I shown in the negative case? Okay, here it is, advancing edge. Sometimes, you're going to have to look under daylight because shades of red are sometimes hard to see under artificial light. So if you have a skylight in your examining room, I'm sure Dr. Drew and Dr. Drew have a skylight in the examining room, they don't seem to miss any cases, that's what you're going to look for. Very pale advancing erythematous. Next slide, please. Here it is again, around the edge of the ribs, the insertion of the serratus anterior muscle. Next slide, please. Multifocal disease with patches of erythema here. Some of them are all Langer's lines, some of them are not. Next slide, please. Now in children. In children, we have a form of disease which is a little different from what we see in adults. The New England Journal of Medicine had a case where they did a urticarial disease. These are hive or hive-like reactions. But you see, we have here on the back of the skin of the back an erythematous patch which meets the usual criteria for Lyme disease. So in children, urticarial manifestations are more likely to be seen than in adults, although you can see them in both. Of course, disseminated disease. Next slide, please. This is the second of Dr. Berger's slides for those of you who are awake this morning. And Dr. Berger is very, very proud of this one because this is a rare form of Lyme disease. What makes this thing different? It's different because the center is completely clear. So in Dr. Berger's collection, this is a jewel. This is a 10-carat diamond. And he's very proud of this lesion. Next slide, please. Now, Lyme disease may involve acral areas, which means the ends of the body, the hands, the feet, the eyelid. And here you see the person was walking through tall grass and open-toed sandals. Guess where they got it? Right there between the web space. The old tick bit them. And you can see that the erythema has formed half of what you see on another part of the body because the rest of it would be out here. This sort of erythema then, on acral skin, may be misinterpreted as cellulitis or a type of infection. It's infection, but this is Lyme disease because the patient had septic meningitis and facial nerve palsy, which brings me to McDonald's caveat number 2. And that is when disease expression in different parts of the body coexist like heart block and joint effusion or palpitation of the heart plus aseptic meningitis, suspect Lyme disease because those are clinical flags which should alert you to the possibility that something Lyme-like is going on in the patient. Next slide, please. You can see that the patient can't flex the toes because the pain around the tendons has made it difficult. Flex the toe here, can't flex it there. Next slide, please. Pale lesion in a golfer. Went out to the golf course and came back 7 to 10 days later with a very big area of redness, kind of pale. If he had something there, he probably would be able to get the photograph at all. Next slide, please. This is a small lesion, and this lady had fever still 104, concurrent aseptic meningitis, and multiple arthralgias required intravenous therapy. So this is more than several disseminated lesions. A particularly small type of erythema migraines. Next slide, please. Hold on hit. See where the tick got him right there at the crust. Red intensification in the center, advancing red edge. Next slide, please. Pregnant patient came in, told that she had chiropractic disease, and they manipulated her joint like this and shook the neck around. Fevers continued, neck pain continued. Chiropractor couldn't figure out why she kept throwing her neck caused vertebrae out of alignment. Eventually she sought medical attention, and she was admitted with Lyme disease based on physical examination here, erythema migrans in the popliteal fossa. For those of you who don't know the anatomy, popliteal fossa is right here behind the old knee joint. Next slide, please. And move her husband to count down the days of antibiotic therapy. This is IV therapy day number 1. You can see that it's faded a little bit. You can still see the crust in the center. And IV therapy day number 2. Almost gone. So, I'm going to show you another couple of reactions, how this thing clears antibiotic therapy. Next slide, please. This is a lady who had a very large erythematous patch. She gardened. She has a very broad patch of erythema migrans. Next slide, please. She also had very painful radicular neuritis, or pain in the distribution of dermatome, segmental distribution of the nerve along the chest. This is after 1 day of IV antibiotic therapy. Look at that, how that's come under control beautifully. Next slide, please. patient who went out picking strawberries and kneeled down to get the strawberry plants, and guess what got her? In the popliteal fossa again. Old friend, Ixodes damni. Next slide, please. This lady's a nurse in our intensive care unit, and she's seen a lot of Lyme patients, so she knew what she had. She came in, checked in, and because she had disseminated disease, even though we have this stage concept, it's like one bagger, two bagger, three bagger home run, stage 1, stage 2, stage 3. Dr. Berger and I particularly prefer to use the generic descriptions, localized disease versus disseminated disease, because the disease can disseminate early. And we see it, I'm sure Dr. Drew has seen it, and I wouldn't be locked into a stage 1, 2, 3 sequential view of the disease. You can have concurrent arterial migraines with heart block, concurrent arterial migraines with active joint fusion. Next slide, please. From the Mayo Clinic, where Lyme disease always obeys Duffy's rule, which is that after 4 weeks you move from stage 1 into stage 2, and then after the start period of time you move from stage 2 into stage 3. This is a patient who had arterial migraines, and they wanted to watch it. So they circled it in magic marker, and on the second day, it had crossed the Rubicon. And on the bottom. Next slide, please. Hold it, Jan. All right, well, what happened in this patient was we gave the patient antibiotics, and the lesion crusted. Crusting in erythema migrans is a problem that we haven't seen, but they did report it in the Mayo Clinic. Usually when the erythema clears, unless there was a crust to begin with, there won't be a crust later on. There it is, there's a crusted lesion. So here at the Mayo Clinic, another new observation, crusting healing phenomenon in treated Lyme disease. Thank you for saving the bacon on that one. Let's go on down to the next one. Lyme disease in children, urticarial form with spectacular erythema migrans lesions, multifocal on the face. Next slide, please. After therapy is a beautiful child, nice, complete recovery. Next slide, please. Here's what the urticarial lesions look like on the feet. Next slide, please. Here's how it looked after therapy. So complete clearing in this case. Next slide. Once again, in the tummy, these are very disturbing. Next slide. On the back. Urticarial forms of disease in children and possibly in adults. Next slide, please. This patient has a very faint form of erythema migrans. It's right here. It was more intense before she got to the hospital. I called her, I said, bring the child in, we got a good picture. By the time the mother was able to get in after lunch, the erythema had faded. That's why we don't use chronicum anymore. We use erythema migrans, because you can have transitory or evanescent erythematous lesions. Next slide, please. As a little extra bonus, look at the diameter of the ankle on this side and the diameter of the ankle on that side. Diffuse swelling in the lower extremity without obvious erythema. This patient was carried in piggyback because Carol couldn't walk and mother carried her in on her back. Next slide, please. How's that for psychosomatic illness? This sort of erythema is a puzzling type, and we're not sure whether this is erythema migrans or not. So now what we're going to do is hedge our bets a little bit. We can't always be sure. It can always come in classical forms. We did the biopsy, did the cultures. You couldn't get a line. Next slide, please. This is another patchy sort of erythematous lesion, which is non-diagnostic by Dr. Berger's eyeball and by my eyeball, certainly, because I'm not a dermatologist. Next slide, please. When it is diagnostic, sometimes the skin biopsy will show some inflammation, and I want to tell Dr. DeRay I'm not going to show too many more histologic slides, except at the end, where we go over non-Lyme conditions. Next slide, please. But when we see lymphocytes and we see them in the right distribution around the right types of vessels, we have a suspicion that it could be Lyme disease based on histologic parameters. We really, though, do need to see the spirochete or throw it from the skin in suspect cases before we can be sure. Next slide, please. There's our second bagger. We're going to go for a quick reprieve. Thank you. Next slide, please. What I'm going to try to finish up with, how am I doing for time? Time over? I'm going to going to show you some non-Lyme conditions. One of the ironies is that when you become successful and make a live diagnosis of Lyme disease, then people accuse you of having intraocular spirochetes. You see that? You see them people, they can't see it. And people get angry with you and they tell you, you know what Lyme disease is, and you're calling everything Lyme disease. What is this? What is this? Is this ringworm? Is this sunburn? Is this artifact? No, that's erythema migrans. That is Lyme disease. Patient also has second-degree heart block, aseptic meningitis, fever 102, and because the neurologist who saw her didn't do a physical examination, that is, had the patient disrobed, worried about other things, ordered $5,000 worth of medical tests. There it is, cost-effective medicine, right there. Lyme disease, plain and simple. Next slide, please. This sort of bubbly, poison-ivy-like look, sometimes around tick bite, we're not always sure what that means. Other ticks can present lesions that cause irritation in the skin. This is not really a diagnostic lesion. We don't know what this means. Ixodes, Ammonite, maybe you could do this. The dermacentrics can do it too. So beware of bumpy vesicular lesions. We don't really know whether those are part of Lyme disease or not. Next slide. This is a case from an ophthalmologist, an eyelid. And I put in there just for my buddy Dr. Lawton Smith, who will speak to you. What do we have? Fat eyelash? Next slide, please. It's studies in and I removed, and there's a little red spot of the sudden stick like easy from Dr. Howard Frieden of Washington State. Next slide, please. And an advancing edge of erythema at the bite site several days later. Next slide, please. And look at how it's going. Antibiotics were started, and the process was short-circuited. Next slide, please. So we may have that, and we may have lesions that look like trauma, like somebody bruised the skin. And actually, this is a form of Lyme disease. So, let's go on now. We're going to go to the non-Lyme conditions. Very quickly. These are the spirochetes. Next slide. Spirochetes again. Next slide. Now we've gone. Lyme or not Lyme? This is really tough. Fixed red eruption due to sulfa, not Lyme disease. Next slide, please. Ringworm. Next slide, please. Erythema multiforme. Multiple red spots. Next slide, please. Well, it could be poison ivy, bullous form of erythema multiforme. Not Lyme disease, at least not now, not yet. 4. Do not form part of our current understanding of Lyme disease in the skin. Next slide, please. Herpetic whitlow, herpes simplex virus on the hand of a little kiddo. Lyme disease very, very rarely involves the palms and soles. Palms and soles are syphilis or Rocky Mountain spotted fever until proven otherwise. Next slide, please. What's this? Erysipelas. Erysipelas is a mass-like area of erythema due to a strep infection. It's somewhat similar to butterfly rash, or the malar rashes, the malar bones, but this was treated with antibiotics, not steroids. Next slide, please. And here we have the gentleman in the convalescent phase feeling much better. Next slide, please. Erythema nodosum, multiple patches along the skin of the anterior thigh. Okay, so all you people out there who have a chance to talk to people, we do make a diagnosis of non-Lyme erythemas in Southampton, New York. Next slide, please. There is erythema nodosum on the back of the leg. Next slide, please. What's wrong with this patient? Anybody who says baldness will be shot. We'll erythema here on the top of the head. Next slide, please. A little more on the skin of the arm. Next slide, please. How the patient is rubbing. Boy. Look at those crusted areas. This is malignant lymphoma involved in the skin called mycosis fungoides. Next slide, please. There is Leon. Okay? Next slide, please. And that's what it looks like in the skin. Mycosis fungoides, multi-creating microabscesses. Malignant lymphoma in the skin. Next slide, please. Other infections can produce horrible skin problems with advancing areas of erythema. This is a toxic strain of Staphylococcus, which produces a toxin which destroys the skin. Epidermal necrolysis, we call it. When you want to hide, you use Latin. So that's what we call it in dermatology. Epidermal necrolysis. Next slide, please. Enoch Schumann purpura. It's kind of a black and blue look. Next slide, please. There it is on the legs. See See how kind of reticular it is? Next slide, please. Annual theme of unknown etiology. Next slide, please. Red ears. Well, one of the things Lyme disease can do is to cause red ears. But the red ear and Lyme disease is usually down here in the soft, fleshy part. Most of the red up here is in the cartilage. We call this relapsing polychondritis. Next slide, please. A little more on the other side. Relapsing polychondritis. Next slide, please. And this is a kind of a blotchy pattern of vibrating redness of the skin, which is really hard to find. In this case, it's a very rare condition. Next slide, please. Another leukemia condition. Biopsy called non-specific by one lab, reviewed by our lab. We did electron microscopy. These are all convoluted T cells. Patient has Sézary syndrome. Incidence of that is 1 in 4 million in the population. Okay, next slide, please. Here we are, Sézary syndrome, masquerading as quote-unquote non-specific dermatitis. Next slide, please. And finally, a horrible skin lesion, a malignant tumor of the skin, a malignant lymphoma in this case, with central necrosis and cavitation. I'm sorry to show this so close to lunch. Next slide. All right, so we have to think of lots of lesions. We must be flexible, and we must have a library of visual images up here, about 10 trillion, to fall back on to make the diagnosis of Lyme disease in a cutaneous form. When you can make it, it is cost effective, it is bulletproof, and it is very, very satisfying. So thank you.
Good afternoon. I'm a neurologist, and as a neurologist, I have a perspective on the disorder that other people.
Pick the mic up.
My name is Dr. Weinstein. I'm a neurologist, and as such, I have a different perspective on this illness perhaps than some of the other physicians here. And I just like to take you through a tour of Lyme disease through the neurologist's eye. First slide, please. Neurologically, and as Dr. Bergdorf has already mentioned, in 1922, I do describe a tick-bite leading to EM, which now I know from Dr. McDonald's talk is EM, reticulopathy and meningitis. And then Barnwell subsequently described chronic fatigue meningitis plus neuritis. And typically the neuritis can involve either a specific nerve root, peripheral neuropathy, or a cranial neuropathy. And the most commonly involved cranial nerve is the seventh cranial nerve, which, as other people have stated before, would be termed Bell's palsy. And then Dr. Bergdorf's work subsequently, moving right along, showed us that the spirochete was responsible for the infection. Subsequently, the spirochete was focused in the blood, skin, and spinal fluid. And it's always very nice as neurologists, where we have so many curable diseases that are progressive, to find something that is treatable and perhaps reversible. I mean, that's just terrific. Here's some of the neurological findings that you may see with Lyme disease. Patients just are the predominant symptoms early on. A lot of these symptoms, the go-to list to me, are symptoms of mild encephalitis, sleep disturbance that can occur, somnolence, lethargy, poor memory and concentration. These are cognitive type of defects. The affective changes that occur are seen with encephalitis, clumsiness. Some of these are just non-specific events occurring with mild encephalitis that you might see from any type of infections or any type of encephalopathies due to metabolic or toxins. Signs, again, not to belabor the point, but the facial palsy is very important. So sensory losses, limb weakness. Chorea does not refer to a place in Asia in particular. Chorea involves a movement disorder which is similar to like a hula dance, and that's been described with Lyme disease.
ataxia, which is usually thought of as a cerebellar type of event, causing incoordination, much like a drunk would experience. Begins to be signs of local neurological signs have been seen with Lyme disease. Interestingly enough, in this particular series, although the patients had pain and stiff necks, they didn't feel that they had meningeal signs of meningitis on physical examination, which you would like to see with a patient who is treated for meningitis. This again is another slide with neurological findings. Again, headache, meningism was described here. Cranial nerves, interestingly, you see bilateral Bell's palsy occasionally. Other cranial nerves might cause extraocular movement paralysis, so the patient will be cross-eyed, auditory or auditory problems or suspiciousness lead to cranial nerve problems. Again, the radicular neuritis seen with Gurey's von Rott syndrome can be seen. It doesn't have to be necessarily in the limb. It could be in the thoracic or truncal region. It may or may not be painful, and there may be some numbness in that particular dermatome. Myelitis has been described, again, encephalitis, organic brain syndrome, and they describe the neurasthenic syndrome. What's a neurasthenic syndrome? That's probably correlated with the chronic fatigue syndrome. And that's a very peculiar type of complaint. And I would say that Halpern described a number of these patients who went through tests with this chronic fatigue business and found out that with extensive neuropsychiatric testing, that these people were not depressed on this test. They actually did demonstrate problems with their memory and problems with intellectual deficits. And when they were treated, they had improvements on these neuropsychiatric tests. So here again, we're talking about patients who may present with depression, which appears to be on an organic basis, rather than a reaction to their to whatever else is happening in their life. I'd like to draw an analogy between Lyme disease and syphilis, which is, syphilis is another spirochete. I don't want to belabor the point because there are differences. For one, syphilis is a sexually transmitted disease, and we've already talked about Lyme disease being caused by a tick vector and so forth. But because of their distinct biologies being spirochetes, they do seem to follow a similar time pattern. And I think that's important. You can see with syphilis, at least, which probably I suspect occurs early on in Lyme disease as well, there's immediate invasion of the central nervous system with the spirochete. And subsequently, you'll see that meningitis predominates sort of in the middle phase or secondary phase of the illness. And in the tertiary stage, you see that there's parenchymal involvement of the central nervous system and peripheral nervous system. I was taught as a medical student that syphilis was a great imitator, and anytime anybody came in with something peculiar neurologically, they always got a test for syphilis. And I think nowadays, if you live in an endemic area for Lyme disease, you better check for that too. Certain syndromes that have been attributed to syphilis that have been well described include meningitis, meningovascular syphilis, which causes stroke-like syndromes in people, and certainly focal meningoencephalitis has been seen with Lyme disease causing stroke-like disorders. General paralysis of the insane, which we call dementia now. I think it's much more poetic to say general paralysis of the insane, don't you? Tabes dorsalis, which may present with lightning pain, optic atrophy, which I'll leave for Dr. Smith, and meningomyelitis. So there are, as you can see, similar findings in syphilis, and you better be thinking of Lyme disease as being the new great imitator now, otherwise you're going to miss certain cases. Again, clinical manifestations of Lyme disease, these are the three stages that are described, and as other people before me have said to you this morning, things don't always follow these stages, but I think it's helpful to have some structural framework when when you see a patient so that you could determine treatment and understand where you're going, although one can't be too rigid about saying the patient is in this stage or that stage. Stage 1 of the neurological symptoms will be basically that of mild constitutional problems, and the patient may have headache at that time and some neck stiffness, but they don't have the cellular reaction that you expect to see in stage 2. In stage 2, you may see an associated cardiac abnormality, and so stage 2, you might see an AV block, a pericarditis or a pancreatitis. This is typically when Barnwell syndrome occurs. So if you see a patient with radiculitis and they have some problem going on with the heart, think of Barnwell syndrome. Obviously, everybody I saw in my office who came in with a so-called pinched nerve, I got Lyme titers on it. That would be inappropriate, but certainly if there are some other abnormalities, you should be thinking of Lyme disease. Being a neurologist is somewhat like being a detective, and you've got to be looking at all the associated symptoms. And I think if you can make a good pattern to suggest Lyme disease, you ought to think of it. Stage 3, the neurological symptoms would be perhaps, but not always, accompanied by arthritis or skin manifestations. The arthritis might be intermittent attacks of oligoarticular arthritis or symmetric polyarthritis or chronic arthritis. The skin manifestations would be ACA or, as mentioned earlier, acrodermatitis, chronic atrophic hands. It's interesting that this particular slide, which is an old slide, they just say chronic involvement, including myelitis. So the spectrum is much greater than just that. And we'll be discussing this in the next slide. Just like syphilis, Lyme disease can affect all of the central and peripheral nervous system. And in this particular paper in 1986, written by Packner and Steer, they mentioned the typical findings that you may see with tertiary Lyme disease. And that would include neuropsychiatric syndrome, skeletal central nervous system lesions, and the profound fatigue that we had already discussed. And I believe that this is perhaps, as a neurologist, the most interesting aspect of Lyme disease. Is certainly the most challenging in terms of diagnosing. Many times patients who do not have associated other symptoms, organ systems involved have low titers as opposed to having high titers, which of course all of us feel more confident about the patient if we can have high titers. But typically this is not seen in tertiary Lyme disease, particularly in my own experience. Other disorders associated with Lyme disease, which are perhaps less commonly described, include peripheral neuropathy. Many of the patients, particularly in the tertiary stages, will describe as limb numbness, and that's not a very specific complaint. And in my experience in seeing patients in the office, certainly if somebody has other complaints go along with it or suggested history, one should think of Lyme disease. Temporal arteritis, optic neuritis has been seen. And inflammatory myopathy, where the spirochetes has been cultured as a muscle, has been described. Anorexia nervosa in a young boy was described by Packner et al., and this particular patient responded to intravenous penicillin. Pseudotumor cerebral, which is a syndrome where the patient has headaches and increased intracranial pressure and potential complication of blindness, has been seen with Lyme disease. A dementia illness, general paralysis of the insane, has been described with Lyme disease and may be amenable to treatment. If all my patients with Alzheimer's disease had Lyme disease instead, life would be a lot simpler for everybody. Multiple sclerosis has been described as possibly being related to Lyme disease, and Julie Rollins will be talking about this with Dr. Bergdorf later. These patients may have oligochronal bands seen in their spinal fluid. You may also see intrathecal, demonstrated intrathecal Lyme disease antibodies in the spinal fluid, which would make you think more of Lyme disease rather than typical MS. On the MRI of patients with Lyme disease who have an MS-like picture, you may see the UVOs or unidentified bright objects that we have seen typically in patients with multiple sclerosis. In terms of the spinal fluid, it's nice if you could find a pleocytosis in the spinal fluid. You don't necessarily, you may see an elevated CSF protein. There was one case described of a Lyme syndrome where the patient was thought to have a lymphoma because he had atypical lymphocytes in his spinal fluid, but subsequent studies bore out that it was Lyme disease instead. So one has to be vigilant in pursuing this diagnosis. And obviously, it's better to have Lyme disease than to have a lymphoma. In terms of the peripheral nervous system, there have been various descriptions of nerve abnormalities when you actually take a biopsy of the nerves, and variously described have been primary demyelination or an axonal degeneration followed by secondary demyelination. In addition, Halpern showed one of his studies that a lot of these patients who do have that, peculiar just numbness of a limb actually do have abnormalities on their EMG and their conduction studies. And some of them who had so-called normal studies, once you treated them and their symptoms improved, they also had further normalization of their studies. So in other words, while their initial studies were normal, when you recheck them later after clinical improvement, they were supernormal. Okay. This is just an interesting slide. I don't have a big reason for this, maybe somebody else does, but children apparently have a higher incidence of meningitis than adults having more of the typical Lyme syndrome. This slide is from Dr. McDonald's article, and I would just like to mention to you that in terms of treatment for Lyme disease, if we compare this again to syphilis, syphilis was first described in the Old Testament and also in ancient China, so that disease has been described a lot longer. It's only been since the 1940s that we've really had effective treatment for that disease. They used to say one night with Venus and a year with Mercury for treatment of syphilis, because all they had that before the days of penicillin was the heavy metals for treatment. So we've come a long way in terms of treatment for that disorder, and we're really only in the infancy stage for treatment of Lyme disease, and I'm sure as this seminar progresses, further controversies about treatment will ensue. Just a few points just to mention here that are particularly distressing about treating Lyme disease is that you need to make sure that your antibiotics crosses the blood-brain barrier because if it doesn't, the disease is going to progress. We don't have a real good way of being able to follow a patient for Lyme disease, and this is difficult because your serology really is, as Dr. McDonald points out here, serological scars. It doesn't necessarily vary with the patient's clinical course, so you really just have to ask them, are you doing better or are you not doing better? As many of you know, once the nervous system is insulted, it doesn't necessarily recover very nicely. So it's very important to avoid the tertiary stage of Lyme disease if you can, and if you do have a patient with the tertiary stage, to hit it hard because it may not improve if once a lesion has already accrued in the central nervous system. It just isn't very good at repairing itself. The first-time allergic reactions are helpful in a sense because the patient may have this in response to antibiotic treatment. This is a symptomatic flare of the disease, accompanied sometimes by a high fever, and especially in patients with negative titers, it's reassuring to see that they have this particular syndrome. I think this is a very exciting disease to follow. I think Lyme disease is at its infancy in terms of its description and in terms of our knowledge about treatment of this disorder, and I await with bated breath what's going to happen in the next decade in terms of our knowledge of Lyme disease. Thank you.
Our
next presentation is titled Neurologic and Ophthalmologic Manifestations of Lyme Borreliosis, presented by Dr. Lawton Smith of the University of Miami. Dr. Smith.
Hey, Jeff, he needs to use the other mic because it's tied into the video. Needs to use them both.
Thank you very much. Need to hold it. I appreciate Ms. Julie Rowland for inviting me here, and I want to acknowledge Dr. McDonald as my hero in getting me interested in this disease. I've been in neuro-ophthalmology for a long time. I've been interested in ocular neurosurface for years, and the parallels between these diseases are striking. Now can we turn this on? And we'll go from the neurologic to the ophthalmologic. I'm pleased you're not getting anything. Most of you in here are aware of this book that Dr. McDonald brought to my attention, which is Lyme disease and related disorders, which was a book from the New York Academy of Sciences, and it is loaded with red-hot gems and pearls. So I brought it in case some of you are not familiar with it, you're going to want to get that reference. From that particular book between most of these early data, and as we've already known, that it's been increased, it became affordable in New York State in 1986, and they had really trouble with October 88 to latest data that I had, the number of cases there. But it's also been reported from every subcontinent that Antarctica. And it's very interesting to see some of the countries it's been reported from. Here is a paper talking about the neurologic aspects. It's 44 cases of progressive encephalomyelitis and 4 tertiary disease reported from Germany. It's been reported airborne migraines from Soviet Russia. 302 cases were documented in one county there in China. It's in that particular reference. And this was a very impressive statement to me, is today the most common bacterial pathogen of the nervous system in Sweden. That's pretty heavy. It's certain menstruococcus of the snort pipe, staph, pneumococcus, it's rolling. Now this slide is out of date as of this morning after Dr. Science paper. I've rushed on to change that to over 13,000 cases have now been reported in 43 states. Let's look at what we're seeing in Florida. This 71-year-old lady, she is a politically forward individual. I won't get into that. Visited Martha's Vineyard last September, spent some time in the woods. She did not feel well after that. She began running a low-grade fever, and she noticed a large red blotch on her left forearm. The next day, she had another red blotch in her axilla. She went to an internist, and he thought she'd had a spider bite. He said, "I don't think there are any ticks in Vermont." I thought that was an interesting statement. And she didn't feel so well, so she came back down to Florida. Shortly after she got home, she looked out the window. There's a big bridge that goes out to Key Biscayne, and she said, "I saw this bridge that brought from out the parasitic, a weekly old description about utopia." And she noticed 3 days later the whole right side of her face went numb, and the following day developed a bright purple facial palsy. She was admitted to another hospital. She had some left axillary nodes. She was afebrile at that time. They worked her on through the studies, which you can see there, and because of what they thought was a Bell's palsy. And here you can see a little more evidently when she shows a little expression. And she had a very long, this is kind of like one of those pale airfield migraines. I did not get a good picture of it, but if you have a good imagination, and probably out, you can see the edge of like one of these. It was the whole area. It was now pretty much gone. And we felt we could treat them their involvement and the history that she gave was pretty evident. And she was started on doxycycline 100 milligrams 3 times a day by mouth. She came back 10 days later and said the double lesion cleared in 2 days and the facial pulse was totally gone in 7. And that to me was very impressive because here she is a week after treatment. And the following picture shows her the week before closing her eye. And you do not see a Bell's palsy clear that rapidly or that profoundly at all. Within a week of doxycycline, it was very impressive recovery to me with that facial palsy. We sent our blood work out to MRL laboratory, and Dr. Portion's work with us was very kind. I did it outside. And when we saw on October 23rd, she had a non-reactive RPR, she had a reactive TBS, and this is very, very important. So we're going to get into a little further in this talk, because 22% of patients with Lyme disease have been reportedly showing a little higher 1 to 5 false positive TBS tests, which is an extremely important point, because that's kind of like a bar of ivory plunging to the bottom of the pool as far as several diagnoses. She had a strongly positive ELISA, a 1 to 2 56 IgG and negative IgM, and when she came back a week later, you could see that her ELISA was basically the same, but her IgG titer was hit at north. And we follow up subsequent issues. She's maintaining the report of my knowledge. She's doing well, symptomatic in this fall. This young man is interested because he's from Haiti, and we have reported press of patients for Caribbean nations, Puerto Rico, Haiti, Honduras, and Jamaica. So this disease is in the non-endemic areas are capitulating. This man lived in Haiti until 6 years ago when he moved to Miami, so we don't know whether he acquired infection in Haiti or in Miami. But a year ago, his eyes became red and painful, and he became photophobic, and he began to lose vision. And he went for a visit to New Jersey. We were planning on New Jersey if he hadn't had the eye symptoms before we went there. And an ophthalmologist told me he had arthritis, and treated the top with steroids and dilator drops. His past history was negative in arthritis, sexually transmitted disease, and risk factors. You recall some type of skin rash back 6 months ago. This is he showed his eyes over, they looked white, it would show you his vision was terrible. He'd almost given up, his brother brought him to the hospital, almost leaving him around his finger behind the right eye, 2400 to the left. We will show you the slit-lamp pictures of his eyes, and you can see this extreme posterior synechial that caused a scar appearance of his pupil, this chronic uveitis that he had. Here on the slit-lamp, you can see these big button-fed RTP correct precipitation in the back of his cornea and his chronic uveitis that he had. We did not get a good front pictures because he had dense arthritis. We didn't see the evidence change his skin at this time. His HLTV was negative. He was seronegative with surplus. We sent blood out again in California. They reported a 1 to 160 IgM, which is the highest IgM that we had gotten at that point. And they lived in the hospital. What about once you showed you had 30 white cells in the spinal fluid, which is 75% lymphocytes. All cultures sustained for this were negative, and we started them on Roceptin gram every 12 hours and I'd be in the hospital. We also sent serum and spinal fluid to the Pulmonary Institute. Now I want to give them a definite acknowledgement. The Institute out in Pulmonary is the National Center of Reference for Trouble Hematosis of the plants. It would be equivalent to the CDC here. And we've cooperated with the years, and they were very helpful to us because they were not only almost impossible to get PPI tests in the United States, but we would get these quantitative, and they do 6 serologic tests specific. This man had non-reactive ERL, TPI, FTBS, TPHA, a syphilis hemagglutination, and an IgM FTBS, all negative. But they found, they reported to them over 100 IgM and IgG titers. So this was an empirical lab, and they considered this as consistent with a recent infection. We kept him on the IV for a second, added penicillin, and he was not responding. I will say this, we have treated a few patients with IV Roceptin. 3 or 4 days out, they're not responding, and we at that point add IV penicillin too. So I believe that they're responding better to this than to Cetrax on the loan. I can't kind of square that, but that's my clinical question. After he was discharged, we kept him on oral tetracycline. You can see that he's also sent blood out to California again. They came back with 1 to 320 IgM, and within 6 weeks his vision had improved from finger counting back to 20/70, 20/80, so he had a very gratifying improved vision at that point. But he still continues to have chronic detritus and chronic uveitis in both eyes. And this disease is a very serious Lyme disease, and much more common involves the eyes in the literature of gives credit for, in my opinion. Many patients say they have conjunctivitis or red eyes. These people need split eye examinations because a lot of them have an iritis, a keratoconus, a vitritis, and a lot. Now, let's show you some more. This is a 25-year-old young man. Now, we get close to Florida. He was referred to me after he developed iritis in both eyes. He was complaining of blurred vision in both eyes for 4 weeks. He said 3 years ago he developed a Coates-Bell's palsy on the left. 2 days later he developed a Coates-Bell's palsy on the right. So he had facial mallesion. So he went to his neurologist, and he immediately suspected Guillain-Barré syndrome. Put him in the hospital, and they started him on steroids, and he responded so dramatically to steroids that they didn't even do a lumbar puncture on him. But he had a recurrence of the facial palsy 6 months later with steroids, and another recurrence about a year after that. He loves to hunt, he goes all down the Keys, he's remembered several tick bites in the past, and the only reason I can't blame him totally on Florida, remember now, he's 25 years old. He did go to Cape Cod on vacations when he was 11 and 14, but that's been 15 years ago. He didn't volunteer it, but he did recall he had occasional palpitations. He had some vague aching in his right knee for about 2 months. And because of the iritis, his ophthalmologist first him to the rheumatologist. He did a complete workup on him for ANA, conference, and so forth. And the neurologist had heard Dr. McDonald, gave him another kudos, speaking at our ophthalmology course. He said, you got to check this over Lyme disease. His iritis came back over 2. So we sent him over to us because we were interested in this. He had very severe mild vitritis and iritis. And I'll be able to show you his address. See if I can show you. I don't want to show it too well. When he will close his eyes, you really need to see this in a movie. And then he'll have a little contraction of abdominal regeneration. Several of these old patients we are talking to will show you a little interfacial syncresis of abdominal regeneration and stuff. And all of those eyes look like the vitritis is so bad that it's hard to get clear from his pictures. His nerves, this is more than left eye, there are lots of vitreous cells, nerves are hyperemic. And while we watched it, he developed these granulomas in the vitreous that attach to the retina, and I can't show you a good picture of it because his media is so cloudy, but here are 3 granulomas that have pulled tear in the retina. If you can imagine a fish mouth red tear, and you can see this with indirect ophthalmoscopy. We could not get a good picture, and I've seen another case of this. And they developed these granulomas, generally both of them are temporal, and the top on the retina and copper retinal away. So we know that some of these patients are going to develop attachment sooner or later problem. We repeated his ELISA, it was strong and positive, again on 2, we treated with doxycycline, he really had no response. We then did a course of IV-07 and IV-penicillin, and he gradually improved. He's had 3 recurrences since then. So that this is a bad disease when you've had it for a long time, and particularly repeated courses of steroids as he's had in this case. Now, what about the seronegative cases? Well, that's when the grapefruits are going to start flying up to the podium. That's very hard. Let's see what's thinking this young lady. This is a 23-year-old girl, which is very sad. She's now legally blind in both eyes. She was visiting in Danbury, Connecticut. She and her husband were living in an apartment there, and it was a big pile of leaves out back that accumulated during the winter. April 87, he decides to go and sweep out the leaves and police up the compound. He said when he swept that thing of leaves, it was tick city. I mean, they went mad. They bit him on the neck, they crawled in the bed, she combed him out of her hair, sleeping in there. It was just tick city. Within a week, her right eye became blurred. She was seen by an ophthalmologist in Connecticut, told her she had arthritis. She was seen by a neurologist. They did a negative spinal tap, a negative CT scan, and they treated her with steroids. She had some transient facial numbers. Pay attention to that. Numbers are all three kinds of vision. Now, on the center side, I'm not talking about just as a facial problem. They tapered her off the steroids. She had a recurrence of red eyes, and she wasn't feeling well. She went to another doctor who gave her some Cadillacs that was mentioned as normal just before, and she improved on the Cadillacs. She came back to Florida. She continued to have mild arthritis. She had an MR scan, and that poor lady was kept on 60 milligrams a day of prednisone for 4 months. She was creaking over, her vision was worse. She came over with her institution. It was 2400 to 2080 with bilateral arthritis and papillitis. She had decreased sensation in the right foot, trigeminal division. It's hard to see her this far again because this disease gives you big arthritis. That's what it loves to do in the eye. It will give any type of inflammatory disease. The disc is definitely swollen on the nasal sides with arthritis here. Trying to show this with the pictures is hard to do. I think you can see the disc is certainly inspecting that side. There was a little teeny bit of macula, but that was not causing her vision deficit. Her ANA was negative. She had non-reactive RPR TBS. Notice this. She had absolutely zip negative Lyme IFA, but she'd been on prednisone for 4 months. So our neurologist was working with me on this case. We started her on erythromycin, and she went 2400 to 2080 in 1 week, 2030 to 2020, nothing but erythromycin alone. This is at 4 months of steroids. Now, I wish I could give you a slide of that. She recurred following this. She was given a course of ibuprofen, cleared up again, and went 5 months and had another recurrence. She's had 2 other courses that we've had to give ibuprofen plus oral antibiotics. And since she has subsequently relapsed since then and is now, last I heard, less than 2400 in both eyes. She's totally seronegative. Her lysa was negative on her repeated later. We laid on the lysa on her Sunday broke, which they reported was negative. And I think she has seronegative Lyme disease with arthritis and mild arthritis. Of course, we had no problem with diagnosing that in symptoms. But let's go back a little bit to symptoms. Here's a classic picture that Dr. Tommy Turner, let me give you the environment of it, published in 1950. This is the backs of 2 rabbits that had been shaved. He used to be the dean at Hopkins Medical School. Very interesting experiment several years ago. He injected the same number of middle-strain T powders intradermal in the backs of both of these rabbits the same day. This rabbit was put on cortisone and this one was not. A few weeks later, and here's the date, you see these classic umbilicated crusted syphilomas on the back of this rabbit. The one that had the cortisone, the lesions are not as scarred, they're not as inflamed, they're not as umbilicated, but they're just convex 3 times as big. In other words, just as in every granulomatous disease, tuberculosis steroids, T-powder steroids, these fire heats think cortisone is vitamins. So it's that big. There's also, which is very controversial, and the D71, the jump on the seronegative Lyme disease has not more time for prevention. I'm going to move quickly. You cut them times up to 2 little serologic studies. We wanted to know what is the prevalence or incidence of this disease down in Florida, in a non-endemic area. So Timothy Parsons, the young man working with me, the first week of April last year, running through blood, 75 patients going through our hospital. 35 of them just routine pre-op, the blood's normal, routine pre-op cataract surgery. 15 were patients followed up with the neuro clinic, and 25 consecutive people going through the emergency room who were permitted to roll with this. We thought that was pretty representative. Now, we took it back to the early center. Aliquots, the same serum went out in MRL there, and they did an IFA with the lysa. And we also made the same serum in Paris. And they did the Fourier Institute, did a VDR, TPI, TDS, TPHA, and IgM-MTA, and an immunization for syphilis. All one of these 6 steps for syphilis. They did IgGs, this is the Institute Fourier strain, IgGs, this is the National Center Blood Transfusion of Northern plants, another viral strain, and immunizations of that strain, and IgM. Nobody did 5 tests for Lyme disease, 6 tests for syphilis, only 825 tests. All ones in California that were borderline and doubtful were repeated. Now, I'm going to thank Dr. Portion, who's here, and Madame Paris, the co-director of the Cornell Institute, doing all this laboratory work, but we had to pay for that. We do this. Hallelujah. Now, let's get back. In California, reported out of these 75 patients that 9 had positive IFAs and positive lysis by their criteria of being positive, which I'll explain in a minute, 12%. They showed 5 that had positive IFAs and negative lysis, 7%. 3 had positive lysis and negative IFAs. They reported 77% of these as zip negative. I'm not going to give you the numbers. They found some seropositivity, 23%. I was very impressed with the paper today of the study of normal mid-Wisconsin population, and 15% showed some seroreactivity. They called 1 to 128 a greater positive, 1 to 16 to 1 to 64 is propofol, that's 1 to 16 is negative on IgG. Did you put on that? Okay. They call lysis less than 1 is negative and greater than 1 is positive. I have some revelations in there about 0.9 to 1.2, but that's their numbers. Now, this is going to be interesting. Paris comes back, and they had only 8 out of the 75 cases that showed seropositive to any of the tests. 11%, remember there's 23% from MRL. This is the same serum. But of the 8 cases that were positive, 6 were unequivocally what we call the French acne. Now, that's an old term from the new dermatology department. He said, "Madam, I'm sorry." Now, we'll go about these 2 cases. There were 2 cases who had all the 6 treponema tests negative that were definitely positive for Lyme. But I want to draw this young lady to your attention. Hard to see this slide. If you had only drawn Lyme serologies on this lady, you would have gotten a 1 to 3,000 IgG by one antigen, a greater than 1 to 4,096 by another, a 4 plus hemagglutinations, and a 1 to 256 IgM. In other words, you said, man, oh, man, Chevy's for a Lyme case. But she had, I think you noticed in this, her EDRL 256 bills. Her TPI was 100% of mobilization to a titer of 650. Her FTBS was 4 plus reactive to a titer of 25,600. And our TPHA was 4 plus reactive to a titer of 20,000. And you can get titers like that in the United States, so we call her in. She was living with a Montreal refugee for 6 months and had a skin rash on her back. She had classic acute secondary poliomyelitis and was sneaking out of the health department getting bi-weekly bi-7 shots. So she was nothing but a cross seroreactivity with real high titers on the line, doing a course of secondary syphilis. And so only 2 of the cases were seropositive for Lyme, were totally seronegative for syphilis. I'm not going into all those. 6 out of the 75, 8% of our clinic population is serologic evidence for syphilis. We've done this repeatedly. In the eye clinic, if you find anywhere between 8 and 12% of our patients are seroreactive to syphilis, if you just check them over the eye clinic. Of the 8 positive from Paris, 17 positive from California, only 5 overlap, and 4 over syphilis. Now, we then reviewed the charts on all the patients who showed any seroactivity. We only found 2 cases that I think were probably Lyme disease. The first was theirs. 12-year-old Puerto Rican boy had a painless progressive loss of vision in his left eye for 6 months. But in the past couple of years, it had an unexplained FUO. They worked up the ribs, he had a negative conversion test, and he had a history of Bell's palsy. You know, he ain't supposed to have that at age 11, which is clearly on its own. His vision was down to 2400s in the left eye with old uveitis, secondary cataract. He had a retractor in it. Described a global retinal granuloma surgery which it didn't biopsy, which killed me. He had a 1 to 200 IgG, and the Lyme antigen, the SUL premier, but a 1 to 512 in the national stomach blood antigen, and all of the 6 steps of syphilis were negative. I think this is probably Lyme uveitis and this palsy. The conclusion is 8% of our population has serologic evidence of syphilis, 3% has serologic and clinical evidence consistent with Lyme borreliosis. The highest Lyme titers that we get are in patients with syphilis. There is a significant percentage of the population with ambiguous serologies. And the question comes up, this is very important for research. There are a lot of people from New England who have retired at elderly age and come down and live in Florida, South Florida, and cataract surgery at 70, 75, 80 years of age. If you get some significant serology on that, is there such a thing as late disease and it's comparable? They have a lot of heart disease, a lot of pacemakers. Whether the age, death, coronary disease on its own basis, but is there a cardiac latency here that we need to evaluate? Now this is the take-home message to the clinicians. You've got to get all 4 of these tests in any one of these patients. You've got to get a reagent test, whether it's an RPR, either a ribbon titer and an FTDS, and I think that you should get both an IFA and a Lyme if you are studying this. Now Dr. Portion has been giving us a square deal, and I have no interest, no stock in his company. But when we offer a Lyme syphilis panel, which you can get for 1 red drop tube of blood, for $50, they'll give you an RPR with a titer, an FTADS, a Lyme IFA, IgG and IgM, and a Lyme ELISA. And I'll tell you, they're charging, they're ripping off people all over the country. I know a lady in Charlotte paid $170 for a Lyme ELISA. Many places that would cost you well over $200 for those if you bought into those individually. 22% of patients with Lyme disease can have false positive FTAs. At first, lady I showed you that false positive FTA. It's a little higher, but they don't work more virus. So if you don't get it comes back reactive to the clinician, you then have to go and get these other troubling tests to prove that. It's inadequate to get a VDR on an FTA. They say that patients with Lyme disease do not show reactive VDRL. But remember, 40% of cases are like 7% negative VDRL. If you get a VDR on an FTA, you want to list the biologic false positive reactive. So you must have both the non-specific reagent test and the specific treponema test to differentiate that. You cannot, if you have a reactive FTA and no VDRL, you can't tell whether Lyme disease is syphilis. You also have no reagent titer to follow. It's inadequate to get an IFA on an ELISA. We've got several cases of clinical Lyme disease, borreliosis, who have positive ELISAs and negative IFAs, and vice versa. But we can get variable results, as has been discussed today. But what we do now is we keep an extra tube in the icebox so that we have a case that's controversial or different left. We can send it to Paris, we can send it to Western Boston. I would advise you to keep some of these pieces that are, this is like Dr. McDonald said, it's clinical, it's not a laboratory diagnosis. We're not making a diagnosis all simply the blood test alone. All of these cases should be reviewed clinically. These are cases now being reported out of the academic region. How do we treat it? Well, I noticed recently septic's been added. I want to try that. I have not tried that. We've been using either doxycycline 103 times a day, or tetracycline with the mycin, and later we give them IV. What was that an antibiotic something? Avoid steroids. There was an article in the May 28, 1988 Lancet which said there was a doubt that you could eradicate the organism, but all of patients who said steroids. This, of course, is a classic lesion that's been demonstrated, and I'm going for this case. I don't have time to go on. This case, you will take home as the most smashing case I've got. This young lady is from British West Indies. 2 years ago, she began to have some trouble hearing. She had tinnitus, a little vertigo, and had some hearing loss in her right ear. About that time, on occasion, her eyes would get red and inflamed. This continued and slowly went on for about 2 years until January. She went to bed one night and woke up the next day stone deaf in both ears. Stone deaf. So she was admitted as an emergency to the hospital. She gave us a history of having had some Bell's palsy in the past, at least twice that she was running on the left. And I think you can see here, now we're asking her here, she's at rest, to close her eyes, and gently, you can see the raw reflection of that side of her face. You see one angel little fall like that she's recovered. And she definitely had that regeneration. She had that was a bilateral facial involved with things. She had chronic red eyes, and in this eye, you would not be impressed. You could see some slight clouding of her cornea. Her vision was good. We had to get all her history by notes, and she is totally there. I mean, she would carry them down the wall of the clinic. She couldn't hear anything. Here she had absolute textbook old visual keratitis with this big sewing machine, this big gut eye you could see with a hand light, and it was just on the certain angle that you could see her cornea is clear, back down that leaves a silverish textbook for syphilis, or in this case, Cogan syndrome. I'm sure you recognize this young lady's having Cogan syndrome. And again, you can see the stromal changes in her cornea here. Well, the rest of it. Cogan syndrome is a rare entity which is called bilateral non-lytic interstitial keratitis. And David Cogan, an old professor, first reported in 1945. This girl came into the textbook Cogan syndrome. She's been seronegative to syphilis all around the road. She came back. The treatment was thought to be steroids. She was given megadose IV steroids for 4 days. Totally dead at that point. We thought, as soon as we saw her, we immediately thought of Lyme disease in her. We got a lymolyzer on her, which is 1.5. We immediately added albumin-7 and penicillin to her treatment. Within 4 days, her hearing had improved to the point that you could now maintain a conversation with her. Not good. I mean, she came back from zip negative, total hearing. She was kept on both steroids and the antibiotics for well over a month. She's now been stabilized at a very low hearing level, and I think she came back from no hearing to a little bit. So the take-home message to me, for you guys on this, if you see anybody in question of Cogan syndrome comes up, be sure to get serologic reaction to the Lyme borreliosis, and I would definitely advise covering their antibiotics as well as steroids, because the steroids are very possible dangerous. And all cases for Cogan syndrome should be investigated for Lyme borreliosis. We don't have more time for the rest, and I want to thank you very much.
Our next speaker is Dr. Paul Duray. The title of his presentation is Pathology of Lyme borreliosis. Dr. Duray is with the Fox Chase Cancer Center in Philadelphia, Pennsylvania.
Good afternoon. I'd like to thank Julie and Karen and the State Department of Public Health for this symposium. I think this is very timely, and I think that as we move on like this, that we narrow the gaps of our knowledge as things go on. This is a brief presentation on pathology. That is, we'll take a look at the tissue damage as this fire heat has gone throughout the systems. And you've heard at least a beginning concept of all of the things that can really be going on. What are the lessons that can be learned by pathology? Why should we go back and look at how things look under the microscope? Well, since we don't know what is actually happening in human beings with this disorder, for that matter, many of the other disorders we just left studying, which is syphilis, it is quite possible that looking at the extent of the damage, we can look at research questions down the road. Now we use dynamic technology to try to figure out how the immune system is interacting with this. And as I said, listen to these experts coming up and telling us really what's going on. I really marvel at this fire heat, and it frightens me at the same time. So can we have the first slide? Got so many gadgets here.
We've heard a lot about syphilis, and this is not Lyme disease. This is a silver chancre. Sorry, it wasn't a chancre. It was a primary oral lesion removed from a cancer patient at Fox Chase Cancer Center, so we do see infectious disease there. This was a tonsillar lesion in a 39-year-old lymphoma patient. Initially, of course, my colleagues thought this was Lyme disease. My eye was off on a junket like this, junket not being junk, but rather a traveling talk. They actually signed this out as Lyme disease when Paul sees this case. And I came back, and this was not the CDC's syphilis control, by the way. This is a human biopsy. I came back and I looked at the microscope and I said, that's not Lyme disease. Did anybody tell me why it isn't Lyme disease?
Too many Spartans.
Well, I don't know how good our stains are after 9 years, but I heard that there are too many spirochetes. There are probably 700 spirochetes that could be counted here in the slide, which would indicate that a few microns deep into that section, we might pick up a few thousand more. I said, I think we better talk to the clinician, and she had all those tests you just eloquently heard about for syphilis, and she also had long lymphoma. She did recover from her syphilis. We've never seen this kind of thing occurring in Lyme disease, and let's move on, because that's the last time we see that many spirochetes in the next 20 minutes. Let's just take a look at pathology. Here's the tick bite. This is Vincity's Dayni attached into the skin, and the inflammatory. How you guys did this? Hell, all these machines. Let's take a look at this inflammatory thing right at the base. I think she'll sharpen that one up. And you can see that there is this absolute war going on here with the inflammatory cells. How a spirochete would survive so many leukocytes, neutrophils, and macrophages, and inflammatory mediators in the dermis, I don't know what they do. And this is a section from Seattle, Washington, of a tick bite site with the organisms. I had another one from Holland, but it won't fit through the slots, it's too thick. So here we do know that the organisms are surrounded by a mess of inflammatory cells, and they can survive and get into the bloodstream in the dermis in that direction. Now, for the rest of the talk, I'm going to go by systems. I'm going to show you everything that happens in the skin, at least that we've got time for, and certainly not every lesion, but we'll go through the acute and then the chronic damage to the skin, and then we'll go, believe it or not, on a brief tour of the deeper viscera. Now, this is the first lesion we see. This is the rash. This is erythema migrans. There's just a few plasma cells, lymphocytes around those capillaries. Not a terribly interesting slide, and one that a pathologist wouldn't be very excited about, probably wouldn't even comment on the fact that there are a few plasma cells, but that's enough. A few plasma cells around the capillary of the skin in a patient with erythema migrans would be erythema migrans and usually not other rashes. Now, this is interesting, something we've recently seen after a period of erythema migrans. The patient was adequately diagnosed and treated, then came back with a lesion on her shoulder, right exactly where the erythema migrans had been, and it was biopsied because it looked like a red raised lesion that reminded the clinician of a plaque. And what we see here is almost a pre-mycotic pre-mycosis fungoides type of histology. That is a flood of T cells coming up into the epidermis here. She did not end up having mycosis fungoides, but it certainly reminds of that, and there were several spirochetes right at the base of that, and a culture that. Now, this is a little pale. This is another patient with a similar history of recurrent erythema migrans developing plasma cells around the veins of the deep dermis. And again, after that recurred, it was treated and then went away. So we know that erythema migrans then may be a forerunner of things happening in the skin even within a month of illness. This is an interesting case from the Bronx in New York. Puerto Rican woman went to the beach and was bitten by ticks, came back, developed a Lyme titer. Again, a shoulder lesion of very thick plasma cells and lymphocytes growing deep into the dermis and into the subcutaneous fat. It was called lupus erythematosus initially there. The type called lupus profundus, that is a discrete lupus lesion, which then gets into the pannus or the fatty tissues of the skin. But then because she finally gave them the history of tick bites, we did go and found numerous spirochetes, actually found more spirochetes in her skin lesion than we have ever found, and she had a Lyme titer. She's doing well and had an antibiotic therapy. I heard Alan talk about lymphocytoma cutis. This is something we're not seeing so much here, but we are beginning to see it in the United States, and that's been described in Europe. And this is Lyme disease occurring in the base of the inferior lymph node, inferior helix. This can also, this reddening and outpouching and swelling can also occur in the nipple of the breast and in the axillary skin. And if we biopsy that, and sometimes it is useful to do so, we'll see it's profound lymphocyte hyperplasia, complete with follicles and germinal center formation. And this is one lesion in the skin where you'll see myriads of brilliant or vertebrae, both by culture as well as staining. So we're beginning to add up a few things that we haven't seen before that can be found during the acute episodes, acute meaning up to a few weeks of just having the disease duration. Things that we're not sure have or should have names, but rather do have pathology connected with them, at least in terms of the architecture. And we now know that the disease can reach the base of the skin or in the fat during these acute periods. Now, chronically, this is a woman from Sweden, from Eva Osbank, who had active dermatitis chronically, tropicans. She had many of the features of it down here. You can see how yellowish and thin the skin is. Then she developed a look at this. It's not a matter of fact of photography. There's a white, squared out, very peculiar lesion. It would be very unusual to develop something like that. Then she had another thickening here. You can't tell by the photo, but it's very thick if you were to run your fingers over that. So she has three things. She has ACA, or acrodermatitis, chronic atropicans, atrophy of the skin with the veining showing through the capillaries. The spread out lichen sclerosis plaque that's developed over the lower abdomen, and then a scleroderma reaction. All three sites had spirochetes. And we must remember that ACA, or atropicans, may have a proliferative phase, and pathologically it's represented by a thickening of the dermis, lymphocytes and plasma cells growing throughout the dermis and into the base. Now, later on, as this goes on and the disease progresses after a period of years, the inflammation will abate somewhat, and you'll be left with a very thin skin, which will be seen in this slide, where the epidermis is intact. There's a silvery scale of keratin on the top. The vessels are prominent, showing through, and there's persistent inflammation. And we now know that you can demonstrate spirochetes as well as culture from those lesions. Now, ACA in this country has been rarely seen, but we're now beginning to see it, and this is such a case from Alan Steer's practice. The epidermis is off to the right. We're seeing this beginning widening of the vessels and numerous plasma cells here, and that also had organisms. Now, recently, workers both here and also in Europe have been describing this thickening of the skin that dermatologists refer to as a localized scleroderma, where the collagen becomes almost 2 or 3 times thickness. The normal collagen in this case should be coming up above this area of the fatty tissues, and you can see the collagen just extending way deep. This is from Germany, and they've now isolated spirochetes directly from the sclerodermoid phase of the skin. Here's a biopsy from Minneapolis, University of Minnesota, just a small punch biopsy, simply done, and you can see again the sclerodermoid collagen reaction in this skin biopsy, and that patient's scleroderma has disappeared with antibiotic therapy. Here's the histology of lichen sclerosis in Lyme disease. We have plasma cells down here floating around, and this pale staining collagen, loss of the reedy ridges, again in a patient with ACA. And recently we've encountered a case of a patient who had ACA, was treated, improved, and then had a recurrence, and this biopsy was performed to try to understand. What we saw there was a vasculitis of the superficial vessels, so we know that there is an active vasculitis that occurs during the context of the pathogenesis. So it looks like we can expand the list a little bit in the skin manifestations of Lyme borreliosis as it goes on for a period of time, with or without scleroderma, fasciitis that can resemble Sjogren's syndrome, lichen sclerosis. Certainly people are now reporting this with increasing frequency. Well, let's move on If we go deeper from the skin, we now know there is a myositis. It's very real. I'll show you a case at the end of the hour because it's too thick to get into the slides right now. This is a case we had in Connecticut of inflammation and pain. These patients present with a swelling and usually of the limb girdle musculature, but maybe any muscle at all. They're very tense, they're swollen, and quite painful. And we suspected that the spirochetes were there. We demonstrated it in only one case, not others. But now I am told by Karl Weiners in Germany that they've actually isolated organisms from myositis. Now, pathologically, that looks like myositis that you might see in dermatomyositis or polymyositis. Can't tell them apart. This is a recent case from Philadelphia of a Lyme borreliosis patient with the myositis. This can develop anywhere from 3 to 5 weeks after onset of infection or as long as 6 months later. Very unpredictable, but it may also be near the joints. Now, moving on into the viscera. We've talked about lymph gland enlargement or lymphatic. I like that term. I don't know why we don't say lymph glands more often, but I hear it so often over the phone. I'm calling them lymph glands instead of lymph nodes. In any case, here is a patient with lymphadenopathy, with numerous plasma cells growing, and this proliferation of stimulated lymphoblasts that are seen here. We've seen that now so often that I don't know why they haven't described it before. In this case, you can see that they look very atypical, almost like lymphoma or tumor cells. And they can be seen by prostate stains to be actually making IgG, as you can see on the right side of the screen here, as well as making IgM. So these very large, early precursor, immature B cells are synthesizing IgG and IgM during the lymphadenopathy phase and probably longer. Not a very good picture, apologize for that. It's a Polaroid of that lymph node, and you can see the spirochetes actively present. So it's not an empty phenomenon, the organisms are directly there. This is a spleen from a patient from West Germany who died with advanced neurologic disease after several years of von Wie's syndrome. And you can see that these, again, atypical plasma, tumor-like, almost cancer-like cells growing within the spleen. Persisting for long periods of time. This is a case from Hartford, Connecticut, who presented in the emergency room with a rupturing spleen at Hartford Hospital, who had active spirochetes in his spleen, had many of them. And you can see how well they were staining from this photograph here. Another case with another spirochete right in the center of an area that's showing necrosis. And then hepatitis. This is a photograph from a woman in Wisconsin who was a rose gardener, developed hepatitis, and actually was interpreted on biopsy in a hospital that cannot name, or wouldn't name, and was diagnosed as having monocytic leukemia because she also has swollen glands and had some thick gums around her frontal teeth. And with this liver biopsy, because of her enzymes and beginning jaundice and pain, she was called probable monocytic leukemia. Eventually, she was diagnosed as having Lyme disease, and everything went away. She's totally doing well. Now, the heart, we've heard a little bit about it today. This is a biopsy done by the right antetuberous fossa vein, so it was not an autopsy. We're glad of that. This was a successful living diagnosis of a patient with complete heart block at Yale University, and you can see that it's a small biopsy. There is a interstitial myocarditis of plasma cells and lymphocytes, and here you can see that the mononuclear inflammatory cells produce almost a layer cake phenomena on top of the endocardium. And whenever I see this in biopsy, I always think Lyme disease, and we've been right about 50% of the time, even when the clinician hasn't thought about it. Now, I've been waiting for, how many years is it now, Alan? I guess 8 years, to see a kidney. And we finally received one very recently. This patient had died. I had partial details, extremely high titer of Lyme disease, and the necropsy was done. Here's the kidney with numerous lymphocytes and plasma cells filling up the interstitium, which you can see here. The glomeruli are very large, as you can see, and they're showing an increase in the mesangial cell, and the cells supporting the capillary loops within the glomerulus. To me, that looks like a lupus type of glomerulus, or even an early nodulus sclerosing kidney and chemostable diabetic kidney. But this is, remember, a patient with Lyme disease. And if we do a trichrome stain, you'll see that the the basement membrane zones under the capillaries are quite thick. Now, we don't have electron microscopy done yet to show you if there are immune deposits, but I can't imagine anything is there but immune deposits that have circulated through and got into those capillaries. If we look at the vessels inside the rest of the interstitium of the kidney, they're very thick, almost closed off, and almost rimmed by collagen, as you can see here. Very interesting case. Now, the arthritis is something that goes on for a long period of time. This is a patient with advanced arthritis, in Lyme borreliosis. There's a lot of soft tissue component here and beginning erosion of the bone. We need to remember that if Lyme arthritis is not treated, it will lead to loss of bone and erosion and very early osteoarthritis. So we'll actually get two pathologic processes for the price of one if it's not diagnosed. And the way of looking at the tissue changes in Lyme arthritis is that two things will happen. Number one, the synovium will either begin to grow, almost in a tuber-like fashion as it's doing here, stimulated to grow, accompanied by some lymphocytes and plasma cells. Here's the close-up to show that the synovial cells actually leave the synovial zone and begin to grow deep into the deeper tissues. Initially, we thought these were just macrophages, but they're synovial cells. It's a strange phenomenon that occurs in response to this disease, but it occurs nevertheless. In those cases where we see a lot of that synovial hyperplasia, we see a lot of IgG being deposited directly in the synovium. So I don't know if that's actually playing a role in the continued proliferation or not, but it's easily seen and demonstrated. The other thing that we see, so that we're likely to see either this inflammatory type of arthritis or we'll see this type, and that is where fibrin and fibrinogen products are being deposited directly under as well as on top of the synovial layer. Now, it's not unusual to see synovial membranes on top of the layer because you can see that in Writer's arthritis, and even I'm told, although I haven't seen it, psoriatic arthritis, as well as in mildly in rheumatoid. But to see it under the synovial membrane is unusual, and when a pathologist sees that, he or she should think of Lyme arthritis. Here's just such a case, which is a different one, of the damaged, inflamed synovium with a cap of fibrinogen on top, from a case here. And then in Switzerland, as they're beginning to look at their cases, their arthritis, because they're now seeing it. This is a case from Dr. Kroboff in Switzerland. There is fibrinogen on top of the synovial membrane, as you can see there. Now, this is the other type that we would see if you can sharpen that. Good. This is from Dr. Rob in Chicago. This is a patient with Lyme arthritis, a very interesting kind of nifty example of almost a lymph node growing within the synovium. So that's the two types, I think. I think we'll see one with a lot of lymphocytes and plasma cells, true lymphocytic hyperplasia occurring within the joints on the one hand, and on the other hand, we'll see the other type with a lot of fibrin and fibrinogen being deposited. So we usually see one or the other. This is very unusual. You can see that almost looks like a lymph node, but it's not. It's right in the joint. Sort of reminds me of lymphocytoma acute. This is the ear lobe that you saw. And organisms there, yes. Absolutely. And how many times in culture have we all that are growing these in our gardens have seen the spider move around like that? Just a gorgeous, really the growth thing that shouldn't be in the joint. And that's why we're having disease there. One of the reasons. There may be other reasons. This was an initial exam that many of you have seen ad nauseam of our cases at Yale, showing an arthritis occurring directly within the joints. Here's the fibrin cap, which you can see stained with a trichrome stain. But this to illustrate that there's unscathed damage of the arteries, small arteries occurring within the synovium, much like you'd see in lupus erythematosus, or much like you'd see in syphilis. Here's a case of synovitis from Minneapolis. Again, you can see the same sort of thing happening there as well. So it's not a geographic difference. The pathology is the same, I think, worldwide. Now, quickly, we're going to be left with the nervous system. This looks like a bone marrow clot. It's spinal fluid filled with lymphocytes and plasma cells. And just take a look at those terribly atypical plasma cells occurring right within the spinal fluid, almost tumor-like, to go along with the same kind of cells that you saw in the lymph nodes and in the spleen. Now, some of the cases I'm going to show you on the brain are not happy cases. There have been some deaths. Fortunately, they're not that common, but at least we're learning a few things. If you can sharpen that just a little bit. Here's the cortex of the gray matter. Here's the fibrinal lymphocytic cap where the And you can see that the lymphocytes and plasma cells are showing a band-like deposition directly within the meninges. So we imagine that that's how the meningitis probably looks in some cases, and would lead to the pleocytosis that you see clinically in spinal fluid exam. Now that's probably variable in all patients, but imagine they get some degree of that lymphocytic infiltration. Other patients will have perivascular cuts with an increase in microglial cells and oligodendrocytes, as you can see here. Now, not all cases, and I'm sure Ellen would back this up, have had this degree of inflammation, but some of them didn't have it. And if we take enough sections, we'll find them. And that's another key clue, is that a blind biopsy may or may not pick up these findings. They're not uniformly and diffusely present throughout the brain. This is a separate case of a young man who was a happy case. This was biopsy to rule out herpetic encephalitis at Yale. He ended up having a microgliosis, which was very patchy and focal, which was revealed by MRI scan, and had titers of Lyme disease, titers to the brilliant later, but not early, which kind of fed everybody, made us pretty confused, but eventually he was treated with large doses of penicillin, recovered and went home. Great case. This was a case we recently had in Philadelphia. Now that we moved to Philadelphia, now that I'm there, we're seeing the same situation here. This is a biopsy of a woman who went into coma all the way from, she had multiple tick bites on her abdomen in another part of Pennsylvania, and she was given all sorts of diagnoses of strange psychiatric problems. But eventually, her stuff lapsed into a coma, and she underwent a biopsy. You can see that there is some spongiosis taking place here, but not much in the way of inflammation, just a lot of spongiosis. And at a higher power, there's some round cells present, and then some vacuolated cells are taking place. Not very cellular, but not very good-looking brain. And remember, this was biopsy during her coma phase. So you know what we were looking for, and we found them. There they are. There's Dr. Berger's spider team. And you can see that the clean background, there's no other fibrillary tissue fibers, as we call them. There it was. She went to the Geisinger clinic, was transferred out because she did wake up, and I was phoned about 6 weeks ago. She was back eating breakfast and taking meals where she had been at home prior to that. This is spinal cord of a cat. So now, I think if you have 2 or 4 feet, have warm blood, you get Lyme disease. And this is a cat that didn't make it, but the spinal cord, this is the nerves exiting the spinal cord, this transfers section of the spinal cord. Again, notice all these vacuoles and spongiform appearance, the oral power. There's just these tremendous vacuoles occurring in the dorsal horn of the spinal cord. This was a cat that couldn't move his right leg. That was all that was wrong, except for spinal carditis. Now I want to show you some human material of the ganglia. This is an autonomic ganglia. Let's spend a little time with this because we've heard now some syndromes today, and we're quite well aware of the autonomic dysnomic syndromes that patients get with neuroborreliosis. And this is the ganglion here. This is the sympathetic ganglion portion. Here's a part of the nerve exiting the ganglion. There isn't much to see until we go to higher power. Now, the important findings are, in addition to clusters of lymphocytes and plasma cells coming in, what they're actually doing is ridding the autonomic ganglion cells, the cells that you and I need to have nerve function. And to me, these cells are actually disappearing. So I suppose, and I hate to use the term, but I hate to use it, so I will. But it can be misconstrued. I think a pathologist may think of autoimmunity in one direction, and an internist may think of it in another, but maybe we two will get together somewhere. But I think that this is nerve damage and cell dropout due to the immune system going at it. Now, I think, and my guess is that the organisms are in those cells, but at this point in time, I've not been able to prove it. It certainly reminds me of the situation in hepatitis B, where the virus is in the liver cells, and the immune system, the only thing it can do is kill the liver cells. In other words, destroy the village to save the country. You have to get in there to try and do something about the intracellular. That's just speculation. It's not fact. I have to think about it another way. Here's another patient with Lyme borreliosis involved in the autonomic ganglion, and again, you you see the same patchy distribution seeming to get around the cells, around the autonomic cells themselves. Now, we know that there's neuropathy, peripheral neuropathy patients may have foot drop, and they just have mild motor weakness, or they may have biosensory loss of any of the limbs. And the serum nerve, of course, is accessible. This was a patient with left foot drop, serum nerve biopsy was performed. You can see lymphocytes and plasma cells coming at that nerve. This was a case from Connecticut. This is a case from Austria, from Peter Stockbridge and his group at the University of Vienna. The same sort of thing, except that the vessels have a perivascular infiltrate around the vessels. And then if we go inside and look deeper, we'll see that the lymphocytes are lining up near the intraneural vessels inside the nerve itself. So it looks like the vessels are catching it in the nerves. There's a violent stain of a patient with peripheral neuropathy due to Lyme, and you can see that the lymphocytes and plasma cells are again clustered around the vessel, and there's beginning to be loss of myelin around some of these nerve fibers. This is a case from Switzerland, from Paul Spire. And we're just about done. I can't close without talking a little bit about the pathology of the fetus and of the placenta. This is a section of the placenta. It almost looks like edematous synovium, but this is placenta. It looks okay, except that there's 505 fibrinogen being dropped into the chorionic villus of the placenta instead of in between. So if it's in between, that's an intervillous thrombus, and that's what we expect. But here we have what's called villitis. And the last time you saw that word villitis was in the syphilis literature. And then we went on our hunt for Dorothy, and there it is in that case. We went to fluorescence. Here's control using the monoclonal antibody H5332 by fluorescence. And going back to that case, we were able to find it. And so I feel better about calling that silver stained spider piece of Dorothy after using the immunofluorescence. If we use rhodamine, and we do that just for color coding, we sometimes use hyperimmune rabbit serum because it'll give you a stronger reaction, and if we did that, it worked too, but we didn't need to do it, but we did it anyway. I'll close just a couple slides here. This recently is a stain produced by an Army E5. E5 means that you're well on your way, but you're not there yet. It's an enlisted rank. But I think when this man gets his master's degree, he's going to get his commission. This is John Gentile's recent fuchsin stain that he developed during annual training, so you taxpayers are getting something out of your tax dollars. And it's a very easy stain to do. It has a few tricks with it. John has yet to publish this, and I've been aching him on to get it published so we can talk more about it. But it's a good screening thing, and it allows you to really see the structure and the morphology of Borrelia burgdorferi. And I tell you, once you start staining these things, you'll never do anything else. You'll never go home. It just fascinates you to look at the different morphology. Here's one that turns on the T-cell system, and a lot of other things that take. There's one that's dancing. I don't know what I'm talking about. You can't do anything else. When we start finding the bodily fluids, as Sterling Hayden said in his movie Bodily Fluids, this is urine, and there it is. I'm convinced that's Borrelia burgdorferi, and now that they're moving on to prove it, and this is human urine. This is not mouse urine. It's human urine. I have no idea what it means. I have no idea if everybody secretes Borrelia burgdorferi in their urine during their course of infection, but surely they do at some point. Now, I just wanted to put this last slide on, only just to leave you, well, with no other drama, just only because the slide is too thick to fit in the other portion. This is the polymyositis case from Germany, from Karl Reimers, and you remember it resembled the one from Connecticut. And just to show you that he's called in the last couple of months, they now have an isolate out of this case. Actually have grown Borrelia burgdorferi out of that muscle. Took them 2 months to do it, but they finally have an isolate. So many of these tissue damage components that we're encountering are definitely due to the direct presence of the organism. They're surviving in tissues that are there, and as they screw up, pardon my expression, mess up the immune system, the tissues are being damaged in a double way. I think I had time for a couple of questions. Well, I know Alan is trying to isolate that. I've never looked at semen. I could have. This doesn't mean I can't do it, but I've never encountered a patient who, I mean, I've given them and it's the same way of doing that test. It's very important. It's obviously very important. I have not looked at that. Alan, can you tell us?
We have some attempts that have all been negative to culture it. And we have no information, so I think that what goes on in urine shouldn't be confused with what might go on in a venereal situation. I think the press twisted the good news.
Oh no, they wouldn't do that. So no results yet. I haven't seen it, but yes, Paul.
I've looked at 7 semen, tried to culture, and looked at them.
You looked at the soldiers' images?
And I've treated symptomatic seropositive males and have not seen it. Again, it's a negative result. It's hard to publish negative results.
Yeah. No, I haven't looked at it in the Lyme lab, but it's not unimaginable that it could be there, but we just have no experience yet. Any others? Thanks a lot.
It's now 3:05, so we're scheduled for a 30-minute. Our next speaker is Dr. Alan from the Southampton Hospital in New York. His presentation is titled Isolation of the Gorilla.
Perhaps you're wondering why I'm up here again. The reason I was up this morning was that Dr. Berger, who is the world's expert on the cutaneous manifestations and who is in our hospital, was unable to attend. So Dr. Berger's slides were most of the goodies that I showed you this morning. The verbiage was mine and the insults were mine. So please don't put any of that to Dr. Berger. Julie Rollins, well I call her Dr. although she hasn't been formally conferred, is one of my personal heroes because Dr. Rollins is the person, and she'll probably not want to tell you this, but she's the person who put culture positive seronegative disease on the map by identifying spirochetes from clinical isolates, clinical human isolates from this area. And that work is extremely important because it...
Seronegative patients.
From seronegative patients. And that work is in the tradition of Koch, who defined with 4 postulates the points of proof that are necessary to make a firm link between a bacterium and a disease. Most of the things we've been talking about this morning are indirect links, with the exception of very important initial studies which were done with Dr. Bergdorfer and Dr. Barber in collaboration, which established by fulfilling those postulates with colleagues in various countries that the spirochete, there's Dr. Bergdorfer's name, is the cause of disease. And what I would like to do is now to pay special thanks to Dr. Bergdorfer for giving us a career's worth of work and a very nice meeting. So thank you, Dr. Bergdorfer. Dr. Bergdorfer's appointment is at the National Institutes of Allergy and Infectious Disease. He is not on the staff of the CDC, although I bet you they'd love to have him. And people who came to Texas before Dr. Bergdorfer was a man named Theobald Smith, whose work is described in Micro Hunters. And what Dr. Smith did was he tried to identify a cause of death in cattle in Texas. And he studied something, a situation that was puzzling. He came up with a tick transmitted illness. Now, it wasn't Spirochetes that did the cattle in, but Dr. Smith's work, Theobald Smith, was the first time that they had established evidence of a disease which is transmitted from insects to man. And it set the stage for several Nobel Prizes, which unraveled the cause of malaria and sleeping sickness and a lot of other arthropod-borne diseases. I think that we have anything to say about it. Dr. Bergdorfer's work will be recognized in that same vein, hopefully not too soon, not too far away from now. We know, because insects can transmit disease, that malaria is not caused by night air, in spite of the Roman term malaria, bad air. We know that sleeping sickness occurs in certain regions because a specific insect makes its home there. Lyme disease is not caused by a virus, in spite of Dr. Steer and Malavista's authoritative textbook chapter. To the contrary, written in 1981, in the year of Dr. Bergdorfer's discovery of Bergdorfer. So what we're going to do is we're going to start with our little friend, and that's what my friend Dr. Duray calls the spirochete. We must come back. If we seek proof, we must seek the spirochete. Okay? First slide will show a dark field picture of the spirochete. Hopefully we can get it going. Behind remarks that start with the word they know what I have, they did a lab test, they found a heck of a lot more than juvenile rheumatoid arthritis. Behind all of those days is the work of Dr. Bergdorfer and the work of Dr. Barber, and that work I believe was the 13th of November 1981, is that correct? Probably on date. What they don't often say, even in 1989, is that they grew the bug from my blood, or they saw the bug in my spinal fluid. We still don't have a tool to pull this little friend out of the infected host. Next slide, please. So, Dr. Bergdorfer, with this tape section, handed the specimen off, handed the baton off to Dr. Barber. Next slide, please. And Dr. Barber, with his virtuoso ability to culture these things from his experience with relapsing fever, as we've heard this morning, was able to, within 5 days, I believe, come up with spirochetes in the tip dissection. We are still struggling to catch up with that sort of virtuosity as we attempt to get the spirochete out of human material in 1989. And we are miles and miles behind these two gentlemen because they have paid their dues and we haven't. So in order to find the spirochete, you have to pay your dues. I'm going to go over some of the recipes that I think are very important. They're all defined by Dr. Barber in his magnificent papers. And let's start with what you need to make it grow. Next slide, please. Here are the isolates as photographed in the report by Dr. Barber in his wonderful paper written in the first symposium, and it's poetry. For anybody who's interested in growing spirochete, I urge you to go back and read it. It's just as sweet today in 1989 as it was the day he wrote it. These are the spirochetes from the primary isolate. These are spirochetes at the bottom of the tube. You know, it's kind of like talking to George Wall about color vision. You know, Dr. Barber in the audience, I want to make sure that I don't make any mistakes. Next slide, please. With the right media, we start out with a very enriched tissue culture souped-up medium that has been defined by Dr. Barber. We can show it some antibiotics. Sometimes you can use it with curved valve discs. You can have it in other ways. The antibiotics help to suppress the growth of contaminants. Spirochete can bathe in rifampin, it can gargle with trimethoprim sulfa, it can shower with nalidixic acid and 5-fluoroaerosol and still proliferate in a very, very luxurious way. Next slide, please. As the spirochete grows, it produces acid byproducts, turn the pH of the medium from a neutral or a slightly basic pH to to a more acid pH, and as the color becomes yellow, growth slows down, spirochetes die. So in order to keep them going, you have to pass them on a regular basis. Next slide, please. We try to get it out of skin. This is a skin specimen, which is the silent tick bites. I look at all that damage control spirochete has created. We grind it up. Next slide, please. We also try to get it out of the unfortunate babies that may acquire the infection transplacentally. And I'm going to show you down the next series of slides how you might prepare tissues. But first, we're going to start with the raw materials. You're all able to order these through your biological supply houses, CMRL, through GIVCO, and acetylcholine, which is key to making the survival of spirochete a reality. Next slide, please. These are crucial. All albumins are not created equal. There are friendly albumins and there are unfriendly albumins. This is expensive. You can spend several $100s to buy your albumin, and if you don't buy this product, you may wind up with an unfriendly albumin, which does not allow your spirochete to grow. So, in a way, you're taking a risk if you order something from a lot that has products which we can't right now identify as being dangerous and helpless spirochete. But we know that this product, and Dr. Barber once again has led the way in showing that this product is safe and effective. I think if the FDA approval for albumin, this one would pass, the other ones would have to scramble. Rabbit serum also very important. They use a pellet-freeze product. I've had some luck with the second product. Next slide, please. Viscosity enhancers, gelatin, and agarose. These have been used in various laboratories, and I think that some people now have great success with agarose, which is a sulfate-depleted agar, which is the basis of many microbiology culture media. Next slide, please. You filter it with a filter that keeps bacteria out by restricting the size of the particles of the species that can pass across it. So we use a 0.2 micron filter with vacuum. And if you try and filter it with heat, you'll come up with a coagulum, and you lose hundreds and hundreds of dollars. Don't try to autoclave your PSK. Use cold sterilization. Next slide, please. The tissue is prepared with a sterile technique. These are sterile dressing sets in the hospital. Sterile everything on this grade. Next slide, please. Cross swords, scalpel blades ready to mince the tissue in a little tube. Next slide, please. When it's minced, it is transferred into this tissue grinder. It is triturated or triturated or ground up, made into a puree. Paddles. Next slide, please. And you can see here the sterile transfer of the tissue right into the grinder. This is the operator, ground glass, which will mince the tissue into nearly a suspension. Next slide, please. And here it is on its way down to meet the tissue and to prepare. Next slide, please. Now, for every successful culture, there is a little lag phase standing behind it. And that paraphrase is very important because spirochetes in the wild must adapt to laboratory conditions. And when you put into a laboratory culture media, even though it's very rich and very luxurious, the bug will take a while to adapt. When it adapts, and when it's happy, and it will decide when it's happy, we can't decide necessarily when it's happy, it will start to divide, and 2 will go to 4, will go to 8, will go to 16, and we'll have a binary increase. After 2 to the 20th generation, we can be pretty sure of finding them in a dark field in an average microscopic field. After a while, because of limitations of food supply and toxic buildup, like culture media don't have kidneys and can't excrete all waste products, you're going to have stationary phase, and then eventually the number may start to fall off due to just disintegration of bacteria. This is basic microbiology from Delvecco's textbook. Now, what else does Delvecco say about microbial growth? He has something to say about microbial growth and the mass of the earth. Listen to this. If a bacterium divides every 20 minutes, and you provide unlimited food in 45 hours, every 20 minutes it divides, in 45 hours, the weight of the bacteria will exceed the mass of this planet. Think about that. not overwhelmed by bacteria because of substrate limitation factors and the blessed effect of acids and other byproducts. Next slide, please. Here we are. 1 goes to 2, 2 goes to 4, 4 goes to 8, etc. That's your binary cell division. And we expect that this will happen with Borrelia burgdorferi in certain conditions. Now, next slide, please. This is the cause of those 13,000 plus cases of Lyme disease that have been reported in this country, and probably another number equal to that in other parts of the world. How many times has the bug been cultivated from human material? I'm not talking about ticks because Dr. Anderson, with his extensive expertise, I think that Dr. John Anderson is the Luciano Pavarotti of isolation from the state of Connecticut and the realm of spirochetal infections from animals and from other insects. From human material, 41 times have been published. So 41 cases of success, and as Dr. Smith would say, 99.9% flame out on all the other attempts. There are some things that we are puzzled by. People who succeed, they are credentialed people. They are people who have succeeded in growing the spirochete from defective human material. Dr. Bernard Berger, Dr. Ava Aspirin, Dr. Goran Stinstead, have published, and this takes guts to do it, but they published cases where they had 100% flame out. They tried and they failed with culture medium that in different patient material will yield isolates of the spirochete. So the same people with the same reagents, with the same technique, will succeed once in a while with some isolates and fail miserably in certain other prospective attempts to grow the spirochete. So what is going on? Why is it not cooperating? Why won't it grow for us? Next slide, please. Well, I think that there are some possible clues, and one of the lines of investigation which we are interested in is the extension of clinical observation back to the microbiology lab. We know that some patients who acquire infection treated with antibiotics will relapse. That means that if they won't be infected, the bugs are in the body and they are still there and they're capable of growing again. There are people who have disease that only shows after an extraordinarily long period of time between the time that they take victim and the time that their symptoms flare. After dermatitis chronic hypertrophy, an excellent example. They've cultured spirochetes and ACA lesions have been present for more than 10 years. So there must be something going on in the internal biological clock of the spirochete which enables it to adjust to a hostile environment. The human body is not BSK medium. The human body is a hostile environment. And the spirochete is able to adapt to this hostile situation. Next slide, please. This is the way we expect to see it. And this is a spirochete from an European Lyme biopsy from Dr. Berger's prospective clinical study. Very nice, very robust. Next slide, please. Here is another spirochete. It's a little more uncoiled, but very active and mobile. Next slide, please. One of the things that is important to have when you're looking at spirochetes is very high quality optical equipment. And we have dark field condensers and we have bright field condensers. You can see the light coming through the light field and you see no light coming through from the bottom of the dark field. This is the dark field with oil. It's a dry dark field. Next slide, please. The light in the dark field, instead of going straight up, goes across and is bounced off so that it goes at oblique angles to the plane of the slide. And if it hits a spirochete, then and only then will the light go straight up into your eyepiece. I like dark field microscopy. How many of you own a dark field microscope? How many of you use your dark field microscope daily? How many of you have done more than 300 dark field examinations in your career? I don't see any hands up. I see one hand. Okay, 2 hands. Dark field microscopy is an art, and we need to cultivate it if we're going to see the spirochete. Phase contrast is good, but dark field is, I think, a little better. Next slide, please. So here is a journeyman apprentice borreliologist looking for spirochetes with a dark field microscope, and we have a TV camera here. You can see the spirochetes on the stage. That is not a cutaneous manifestation. Next Next slide, please. I don't like the dry duct field because the numerical aperture is 0.95 to 0.80. The higher the number, the smaller the structure you can see. Next slide, please. I like the oil because the numerical aperture goes up to 1.41. And with optimal control, with an oil substage dark field, you can see things that are almost within the realm of low power electron microscopy. Next slide, please. About the light source. The more light, the more you'll be able to see. Dr. Boyle uses a 20-watt bulb. He does very well with it. I use a 100-watt bulb. And so some of the things that I'm capable of seeing with my dark field oil, he can't see with his 20-watt with a dry dark field condenser. That's not because, that's just because of the laws of physics. Next slide, please. This is a spirochetal clump from human isolate, and you can see that they have clumped together. This was taken through a prolonged, very tedious purification process. Next slide, please. And with Dr. Barnes 9724 antibody, you can see that the spirochete binds the antibody. Next slide, please. And here, another spirochete from that isolation. So you use monoclonal antibodies to prove that what you have are Borrelia. 9724 doesn't make it Borrelia burgdorferi, you recall from Dr. Barber's series. That only puts it in the generic Borrelia category. Next slide, please. This spirochete has some structures which you can't see unless you have a dark field. It's got these little things on the end that are smaller coiled forms that are about 1/3 the diameter of the normal fat spirochete. Sometimes these things are the first manifestation that you have growth. Not these. And then if you nurture them, you can get them to assume the shape. Next slide, please. On the other hand, there are situations where this sort of thing, we've got it from skin, under laboratory conditions, degenerates and becomes a culture of material that only is very small corkscrew-shaped forms. These may only be skeleton forms, but I think not because they can be propagated over several generations. What does that mean to me? It means that the spirochete is capable of morphologic heterogeneity. Next slide, please. This is the way they look when they're healthy. You can see some of the smaller forms attached to the plumper, fatter form of the spirochete here from a very early isolate from the skin biopsy specimen. Next slide, please. They're all mobile. Now, the other thing that you can see is tadpole-shaped swellings, and Dr. Duray has seen these in clinical material. These sometimes are called gemming, and some people have other names for them. But these add rather than subtract specificity when you're looking at spirochetes and tissue. These make it more likely rather than less likely what you're looking for the spirochete. Reticulum fibers don't make tadpoles or sperm head rounded swellings at the end of their structure. Next slide, please. So for example, small tadpole form. Next slide, please. Small form. Next slide, please. Now, what I showed you in the last three were silver-stained spirochetes, pure cultures of Borrelia burgdorferi, the B31 reference strain suspended in agar. This is a more straightened Borrelia form. Next slide, please. And this is a coil form, moving through the agar like a snake would move through. Agar, it has a salutary effect on growth. Some people who have had spirochetes that grow that don't move have gotten to move simply by adding agar to the mix. Next slide, please. Ada Aspirin told me that, and I think that's also true for Germany. Now, going back to syphilis, you can see that the shapes of the syphilis spirochete vary from regularly coiled to partially straightened to segmented, beaded to a form of little dots that are just barely connected or possibly actually totally disrupted. This work led early investigators to postulate that spirochetes had a variety of forms that include the easy to recognize form and the form that's not so easy to recognize. A form that if you disrupted this and mixed it up in a medium would look just like a small stack of coppers. Whether these are capable of growing or whether they are dead end products really doesn't matter if these can elicit an inflammatory response and cause tissue injury. Next slide, please. Living and dead can both called prime tissue. What's this? Is that an artifact? No, that's from pure culture B31. That's a ring form as far as people. Some of the isolates will appear as ring forms where the two ends kind of meet, wrap themselves around each other, and stay linked in continuity for prolonged periods of time. These may also be mobile, and you can watch them pour like a windmill. Next slide, please. So, how do we put it all together? The Rosetta Stone. This is the work of Dr. Warren. Dr. Warren showed that returning of powder in certain regions. The top row is easy, the middle row has the sperm head forms, this middle region has the ring forms, and then you get down into meatoid forms and granular forms. We have seen, I have seen, I don't know if anybody else has, all of these in various stages of borrelia burgdorferi under unfavorable conditions in laboratory cultures and culture. That means that when Dr. Duray is looking for spirochetes in tissue, he has to be aware of this form, he has to be aware of this form, and God forbid, he's got to think about these forms too. The only way you can nail these forms is by DNA. You've got to show the DNA of these matches the DNA of Borrelia. There's no other way to prove it. Every other attempted proof will do you a failure and get you rejected from every microbiology meeting in the country, including the one at Washington, D.C. Okay, next slide, please. This is a nice look of a Borrelia spirochete showing the tadpole forms. And look at what we have down here, a ring form. Now these are not your most robust vivacious spirochetes, but these spirochetes came from the umbilical cord blood of a baby who was born alive with Lyme disease, who had spirochetes in the placenta, and who was treated with Rocephin for intra or neonatal sepsis and recovery. Next slide, please. Some of the forms are very small, and you have to use image intensification, computer-enhanced technology to make them visible to make it up. Here's our favorite spirochete, and here's a very, very small form that is bridged by a very, very delicate small petal. Next slide, please. They're a very thin form, and then thicker forms, which you can see. You can't resolve these unless you use another dark field. Next slide, please. Now, I'm going to get into the controversial stuff. Under conditions of prolonged growth, and I'm talking about letting these things go in the laboratory for 1 year, well beyond the time that they live in discarded, these forms appear in pure culture of Borrelia burgdorferi B31 ATCC strain. What are they? They are membrane-bound, spherical, or globular, or cyst forms. Next slide, please. There's one under dark here. They float along like little soap bubbles. Next slide, please. There's another one. Isn't that wonderful? Look at that. It's almost like a soap bubble of spirochetes here. Next slide, please. We know that they're not contaminated because we subculture. There's no fungal growth. There's no other bacterial growth. It was B31 pure that went in, and it's B31 because it wasn't contaminated. It's just an alternate structure which appears in cultures of Borrelia burgdorferi which are grown under unfavorable conditions. Is there any electron microscopic substrate? Well, if you look at these pictures from Rocky Mountain Lab, you can see that Borrelia burgdorferi has a tendency to produce these little outpouchings. Next slide. What you call them is not important. Fact is that they are optically empty, membrane-bound spaces. Dr. Clark Guerin has examined these, has found that they contain DNA, and that they are under active investigation. It is Dr. Guerin who suggested that this is a method, or a possible method, for amplification of the pathologic effects of Borrelia burgdorferi. You just sit in the tissue, and you let these things loose, and they do the damage. Now, I'm not sure whether that's exactly as Dr. Guerin intended it to be, but that's my translation of Dr. Guerin's telephone discussions with me in a very preliminary way. And if I'm wrong, I take full responsibility for it. This is what I think might be a new mechanism of pathogenesis for Borrelia burgdorferi. Next slide, please. So here we are, and they're letting these things go, and eventually they'll pinch off. There's something in here inside the form too. It might be an axial film, it might be some other membrane material. Next slide, please. This is one of those more complex structures with something inside from the age culture B31, B burgdorferi. Next slide, please. A very, very, very complex form age culture of fever or throat rot. Doesn't look at all like spider fever, does it? Maybe degenerative, but I think it's capable of producing tissue injury. Next slide, please. Is there any reference precedent in the literature for cystic forms in association with spider bites? The answer is yes. This is the work of Edward Dilamata, who studied syphilis, and Dr. Dilamata said that syphilis virus can look like this, and there are certain conditions that make these rounded cystic forms in laboratory material under controlled situations of growth. Next slide, please. Another reference in the oral literature, oral spider bites. Next slide, please. Spherical bodies. What does it look like under electron microscopy? It's membrane with some material that looks kind of like the cylinder of the spider feet, but it's a big bag of material with a variable amount of material inside. Next slide, please. Higher view from another spider field species studied by electron microscopy by David Tyson. Same animal. Next slide, please. Keep your eye on this one right here. This one, we know what it is. Keep your eye on it. We've got this structure out of a culture of peripheral blood from a patient with multiple sclerosis. Next slide, please. Kind of matches that, except back it up a little bit. Now it's well preserved. Next slide, please. Cutting the power and buzz. Well, some people say it's an artifact of culture meeting is breaking down after a year. What can you expect? Same sort of things we're seeing in chancres. Chancres don't participate in culture activity. Next slide, please. There they are. Dark field microscopy, not really good optics, but cystic forms. Next slide, please. And this is an age culture which has a form that I think is that form with a spider fetal form that appears to be working its way out, almost like you hatched from an egg. 5332. Monoclonal. Here's a very acceptable one right there. Next slide, please. And once again, from Delmar's work, look what's inside the bowl. Lots of little spider fetal forms. This is syphilis. This is not borreliosis. Next slide, please. High power. Next slide, please. And once again, maybe something working its way out. Couldn't really prove it. Here's something attached to it. You don't know whether it's done its way in, whether it's out, or it's just waiting for a bus. Next slide, please. And these then are the possible origin of those spherical forms. Next slide, please. Under electron microscopy. There they are again. This is T. Paladin. This is not Borrelia. So we have a precedent in the oral spider feet literature, the T. Paladin literature, for Dilamata's work, and for experimental studies at Southampton Hospital with a doctor, what's his name, who believe that these membrane-bound vesicles may have an important pathogenic role. Dr. Duray showed some pictures of Lyme spongiosis. What's spongiosis? An object with empty space that may or may not be lined by a vesicle or membrane on electron microscopy. Next slide, please. Where do they come from? Well, here are spider feet that are dead. This is an image intensification photo. And look at what's coming off our roof frame from later fry. Very long membrane-bound cystic structure. Next slide. Almost like this in the Rocky Mountain lab, or electron microscopy of the real thing. I think this is Dr. Garen's photo, which he was kind enough to allow me to reproduce. Next slide, please. And some more of those posters from Rocky Mountain lab. Next slide, please. So there it is. It's a possible topic for future investigative effort. And next slide, please. A possible clue to a mechanism of pathogenesis that hasn't been previously described. In quote, a tool for Koch's postulates to be realized is the culture of Borrelia burgdorferi. So for all of the manifestations that we want to nail, leave the doorstep of Borrelia burgdorferi, we must satisfy Koch's postulates. I'm a believer in that. One possible advantage of this investigative work is a source of new material, possibly better lab tests. And Dr. Anderson has identified a very important strain of Borrelia from his work. Doesn't look like P31. It's material for the study of infections in animals, material for vaccine development, and material to prove that culture positive, seronegative disease is real and not a figment of the imagination. Thank you very much.
presented by Dr. Tom Schwan of Rocky Mountain Laboratory in Montana.
Thanks, Jeff. I'd like to thank Julie Rollins for inviting me here, and also the Lyme Foundation. This is the first time I've participated in a meeting with this group. I was asked to speak on molecular aspects of Borrelia, and you heard quite a bit about molecular studies from Dr. Alan Barber this morning, who's done a lot of that work himself, along with his co-workers, both at Rocky Mountain Lab and in San Antonio. And so what I'd like to do is briefly review some of the things that we've been working on in our lab for the last nearly 3 years. Now, certainly molecular biology has the potential to allow us to understand many aspects of this bug, as well as the potential to improve diagnosis, treatment, and control. And what I'd like to do is talk about 3 areas that we've been working on since I've been at Rocky Mountain Lab. One deals with the identification of the spirochete. One area deals with understanding the pathogenesis or the ability of the bug to infect. And then a little bit about changes in the spirochete associated with persistent infection in mice, and showing some relevance that might have to human infection. So if we have the first slide, please. It's a tremendous research facility in a wonderful environment, and I went there 3 years ago from Yale and started working on Lyme disease then, so I'm a relative newcomer to the study of borreliosis. For those of you who haven't been there, there's a new movie out that's filmed in the area called Disorganized Crime, and you can see that, and from what I understand, the reviews give Hamilton a better review than the movie itself. For those who don't know what Montana is, some people think that it's the edge of the Hudson River, and I say that because I spent 3 years at Yale, so I'm qualified to make that statement. But the bitter reality is in the far northern part of the state right there, and as I said, nice place to live and work. Okay, the laboratory is divided into 3 labs, and I'm in the laboratory of pathobiology. And the facility has a long history of working on spirochetes. Gordon Davis, Kurt Stoner, Dr. Lee Bergdorfer, Alan Barber, and I'm a recent spirochete person myself. Now, we have a section there called the arthropod disease section, and this is our group presently. Now, we've grown since I got there 3 years ago. Warren Simpson's a new fellow from New Zealand, a molecular geneticist, and helping out a lot. Rex Thomas is working primarily on plague, which we also work on in my group. Stephanie Schutz, a veterinarian from Germany, and then Bob Parsons and Mary Schoenberg, 2 technicians, and Dr. Willie Bergdorfer is down at the bottom, but he's an integral part of our group when he's not on the road. He's traveled quite a bit. Okay, one of the other members of our lab is on this table, really at the top. The spirochetes are a pretty diverse group with many genera, and some of these have been described just within the last year, and most of them are free living or commensal. And you can see the 3 stars with Borrelia, Treponema, and Leptospira, the 3 genera that cause infections in humans. You've seen peripheral blood smear of Borrelia illumicii this morning. Just a little reminder of what these things look like in the blood, and it's much more difficult to demonstrate Borrelia burgdorferi in the peripheral blood, but they look similar to this. Scanning electron microscope view of Lyme spirochete adhering to aerosols, 2 different levels of magnification. Now, if I get into the molecular aspects here, I realize that for those of you who don't work on molecular biology, there's a tendency to fall asleep when these types of graphs are presented. So I'll do my best to get through them, but that's what I was asked to discuss. Now, you saw some gel this morning. This is a polyacrylamide gel showing the different protein components of the spirochete. There's B31 and P1 on the left and repeated on the right. These are duplicate pearl-like gels. They're stained by silver on the left and mossy blue on the right. And if you haven't worked with these or are confused by them, I kind of compared it to everybody in this room and boil them up, break it into heads, toes, fingers, livers, spleens, and then mix them all up and threw it down on a stair roll. We'd have heads separating out on one step and fingers on another. We come up with a profile that describes this population of people. That's sort of what we do with fire keys when we separate them out in an electrostatic system. All right, so we're going to see a few of these gels throughout the remaining 15-20 minutes. Of course, the other way that we can define these organisms is by the DNA sequence, and I guess our country is now involved with determining the entire genome sequence of the human species, and we can do the same thing with Borrelia. Now, we've been doing a little bit of DNA work to try to come up with a diagnostic piece of DNA to identify Borrelia burgdorferi from the rest of the spirochetes that might occur, at least are known to occur in the United States. And that work got started when Alan Barber, before he left for San Antonio. And if you were there, I thank him for that, but he's on his way back to his office. Now, what I'm going to do is show you a few DNA co-hybridization profiles using pieces of DNA that are very specific and specific for identifying the spirochete. Now, what we've done is taken a piece of DNA from a gene that encodes a protein specific for Lyme disease spirochete. This particular gene is called OSA. It encodes for one of the outer surface proteins that is unique to this species of spirochete. We thought that the gene that encodes this unique protein would be a good candidate to come up with a sequence to specifically identify that spirochete from other species of spirochetes. And so in this particular plate here, you can see that across the top we've taken 3 species of Borrelia burgdorferi, 3 strains of Borrelia burgdorferi, and 6 other species of Borrelia. We've grown them up, purified out their DNA, standardized the concentration, and sort of diluted it downward. You can see that the amounts of DNA loaded on this membrane on the left-hand side of the plate. Then what we did was we denatured this DNA, and then took our DNA probe, denatured, labeled the radioactive isotope, and reacted to this membrane and exposed film to it, and then developed it. And what we see is a pattern in this dot plot where our probe is reacting with 2 North American strains of Borrelia burgdorferi on the left, reacts relatively weakly to a German isolate, and cross-reacts with Borrelia hermsii. So this suggested that maybe a sequence out of this gene with a unique protein might not be the best candidate for a specific probe, but it also indicated that maybe our cultures were contaminated with Borrelia hermsii. So we just studied a lot. And on the left is an autogrowth gel where we've taken individual plasmids of Borrelia burgdorferi in range 1 and 2, and Borrelia hermsii in range 3 through 6. We separated them out in electrophoretic autogrowth gel, transferred the DNA onto a piece of paper, and hybridized it with the probe. And what you see is that there is a specific reactivity in these lanes here of our OSA probe to specific plasmids of Borrelia hermsii, which is an interesting genetic phenomenon, but it makes our probe a little less valuable as a specific reagent. So we went looking for another piece, and we found another clone that we obtained that was better. And this just shows that this other piece of DNA reacts better to the German isolate and doesn't cross-react at all with Borrelia hermsii, and may be useful in specifically identifying species of spirochete from others. Here's the same probe tested with 10 strains of Borrelia burgdorferi going from left to right, and then the far right 2 lanes together, 2 strains of hermsii, and which the probe did not react at all. This is a second plot that just shows, again, the reactivity of this other probe to the 49 kb linear plasmid when this gel is overloaded, but you can see the reactivity at the top. And that's important because this particular probe is from a piece of DNA that is stable within the spirochete. It doesn't seem to be lost with cultivation. Okay, I'm going to talk about a series of experiments we've done looking at changing biological phenomena of the spirochete associated with in vitro cultivation. Now, Russ Johnson had showed earlier that the spirochete loses its ability to infect hamsters at some point between the 3rd and 30th passage in vitro. And there was another observation that he and a student did later about a possible loss of one plasmid during in vitro cultivation. And Alan Barber this morning showed the loss of a particular plasmid at some point during 4 years of continuous cultivation. So what we did was we started with fresh isolate and thoroughly passed it and began looking at it in a variety of ways during that passage. Those are P0 through P25 and all that, every fifth passage. That's what those represent. And we inoculated 4 mice at each passage level and attempted to re-isolate the organism from the tissues indicated on the right. And you can see that these passages here all produced infections in mice, and subsequent to P10, we got no re-isolations of the organism from the mice. So that suggested to us that there's something important going on between the 10th and 15th passage that changed the spirochete's ability to establish an infection, or at least changed our ability to re-isolate from those mice. One of the things that happened along with the loss of infectivity was a change in the plasmid profile. And again, the same passages up here, P0 through P25, with the plasmid-rich DNA separated out on agarose gel. And you can see that, well, there's 2 panels here with replicas with just different amount of DNA loaded to get resolution for different size plasmids. But the thing I was pointing out here is that in the first 0, 5, and 10 passages, there was a small circular plasmid which dropped out with subsequent in vitro cultivation, which was associated with the loss of infectivity. So right now we're pursuing the possible role that plasmid might have in the spirochete's ability to establish and maintain an infection. This is what that little plasmid looks like by electron microscopy. It's a small circular plasmid, nearly 8 kilobases large. Another thing we noticed that happened along the way was a loss of one of the major outer surface proteins, OSB. And here's the filament gel here with the same passage as noted on the top. And you can see with the arrow a change in the stand here, which when defined by monoclonal antibodies and Western blot analysis is outer surface protein B, which is lost with serial cultivation. And again, the disappearance of that outer surface protein correlates with the loss of infectivity in mice. So that showed that there was a potential for antigenic change, or at least changes in the protein profile. Now, others have shown that. Alan Barber has shown that. Bettina Wilson has shown that with serial cultivated spirochetes. Again, this is the same condensed version of P0 and P25 showing the loss of OSB here and some changes in the lower molecular proteins down here, which happen spontaneously during in vitro cultivation. The same thing happens when we put it into a mouse and then we isolate organisms from a mouse and compare the gel profile. What this represents is the same P0, the initial isolate used, put it into a white-footed mouse, number 32, and 16 weeks later we filled the mouse and we isolated the organism from it and just compared it by gel profile, and you can see that in this region around 20,000 and above, there are some changes in these lower molecular proteins. Now, Alan Barber showed that this morning with his gel, comparing gel profiles of spirochetes isolated from cotton acid loading 10 gauge we're working on. But there was no analysis of the reactivity of those isolates to the antibodies in the mice that the organism was isolated from. Now, if you look at that and compare the antibody response in the animal that was infected with the initial inoculum, and then compare the reactivity of that same serum sample when we isolate from the animal later, you get a very different pattern. We'll just concentrate on this right in here. 0 represents the inoculum, and 16 represents the re-isolate at 16 weeks after infection in the mouse. Run out of the filament gel transferred and reacted with a 4-week-old serum. That is, 4 weeks subsequent to the infection, the animal was bled and reacted to these 2 isolates, the inoculum and the re-isolate. And you can see that in these lower molecular weight proteins, when reacted to the same serum sample, you get a very different pattern of reactivity, so that the antibody at 4 weeks is reacting to what was inoculated into the mouse, but not what was re-isolated from 16 weeks post-infection. You can amplify the antibody response by adding an amplifying antibody to see how that compares. And again, even when you greatly amplify the reactions, you can see that there's a great decrease in the specific reactivities of the antibody with some of these lower molecular weight components. When you take the same antibody to spirochetes passed in an artificial medium, you don't see that. You see equally intense antibody responses, except for where the protein may have been lost, rather than protein being present but changing in the antigenicity in relation to the antibody response. So we initiated another study, and we infected a lot of mice and led them sequentially over time, starting with a pre-bleed sample here, the first 7 days post-inoculation, and then after day 84. And what this represents is an antibody response defined by optical density at one single dilution, 1 to 256. And this is specific for an IgM response. And this represents the mean values of 10 mice. So what this shows is that optical density is going up, really starting the first day after inoculation, peaking on 5, going back down again, and then with a secondary peak in IgM higher during the 3rd and 4th week and dropping back down again. Now, some of these animals actually show a 3rd peak at day 77 to 84. And I think this suggests that the spirochetes are changing and cycling in their parasitic load in the mice and stimulating like a booster response to an IgM in these mice. If you compare mice that were inoculated with non-infectious spirochetes, you don't see a secondary peak. This shows the IgG1 response in mice infected with infectious spirochetes, and you will see that throughout the course of the experiment after the 12th week, they continue to increase the antibody titer specific for IgG1, and they do the same thing in their IgG2 response. So these mice are infected with infectious spirochetes, they maintain the infection and make a lot of antibody, but they stay infected. And what we're working on right now is trying to look at the mechanism that allows the spirochete to maintain a persistent infection in spite of the mouse antibody response in the host animal. And what this shows is a series of Western blots from one mouse as an example, again with our pre-bleed sample before inoculation out to day 77, with what the animal was inoculated with. So what we've done is we've taken the gel and run out the individual components of the spirochete that was used as an inoculum, and in each case reacted each of these individual serum samples to that same material to see how the antibodies develop specifically to the different components of the spirochete that the mouse was inoculated with. And up here you can see that during the first week there's some fairly weak but specific IgM antibody to mid-range components of the spirochete, and then at this time frame we see another transient but fairly strong IgM response disappears, and then at the 2nd week going on, we see antibodies, IgM antibodies to different components. Here we see specific IgG1 and IgG2 antibodies to the different components of the bug, and they're essentially identical. This is important because IgG1 is the complement-fixing antibody in Paraliscus. And so we thought initially that possibly there might be an IgG1 deficiency response in mice, which would explain the persistence of infection. That doesn't seem to be the case. Maybe the other ones yeah, sorry about that. I'm almost done. Okay, this shows Western blots again, separating out spirochetes that were used as inoculums and spirochetes that were re-isolated from these animals, or from one animal at 12 weeks post-infection. And then looking at specific IgM response. Again, you can see that when you react, the same, for example, day 7 here, the same serum sample reacted to what the animal was inoculated with versus what was re-isolated at 12 weeks post-infection. And you can see that the patterns are different. That is, there's antibody in the mouse that reacts to what it was inoculated with, but the diversity of antibody response to the re-isolated is much less, suggesting, I think, fairly well, that during the course of infection, the spirochete is changing its antigenicity in relation to the antibody response in the mouse. This one might, well, that's all right. I'm so sure this is going to go upside down too. This shows the IgG1 response, again, versus the inoculum and the re-isolate. Again, from the same mouse, this is one individual reacting all these serum samples taken over time with what the animals inoculated with versus the re-isolate at the end of the experiment. And the bottom line here again is that there are antibodies reacting specifically to the inoculum that are not reacting to the re-isolate. And there's a complete disappearance of one with a molecular weight of about 24,000, which even our control marker didn't react with. It was completely gone at the end of the infection. All right, one more slide, then I'll quit. This shows the variation from individual mice that were inoculated with infectious spirochetes. And so each of these numbers must be represented in the animal. Some were inoculated subcutaneously and some were inoculated intraperitoneally. And what I've done here is reacted the same serum sample, for example, from mouse 11, to what it's inoculated with. And down here is the reactivity to a long cultured strain, B31. And concentrating up here, you can just see the variation from one mouse to another in its antibody response when inoculated with the same organism, the same strain. Down here, I think the important point is that the diversity of the antibody response is not nearly so rapid when you react that same serum sample to a long cultured strain of Borrelia. And I think this still has implications even for what's considered the gold standard of serology, that's the Western blot. Because here's an example where if you react the individual's serum with what the animal is inoculated with, you see a pretty nice diverse pattern. If you react that sample from the infected animal to a long cultured strain, most of these would be considered negative, with reactivity is only one or maybe no bands at all. And I think that should be looked at in relation to human serology when Western blots are considered to be the definitive answer. But what's used as the antigen is something that's been in culture for a long time. Okay, thank you.
Our next presentation is titled Ecology in Relation to Lyme. Presentation will be presented by Dr.